this day. Yes. So good morning, ladies and gentlemen. We welcome you to this inaugural first annual Reproductive Health Symposium for AOGU West chapter. I am Dr. Livan Tivaijuka. I have been the chair for the scientific committee, and it's been a lot of work happening in the background. Literally some sort of labor process, but it's time for us to deliver at this point. Before we dive in today's program, we really want to thank you all. Looking through the work that has gone into sharing of the abstracts, having them reviewed, and having the work that these people have to go on and present today through the several sessions that we are going to have. I want to thank you all, the authors, the presenters, our reviewers, and the organizing committee for making today possible. This symposium runs on a theme that is research-driven innovation for better maternal and perinatal health in Western Uganda. It's not asking for just work in regards to the research that we put in to generate the evidence, but aims to ask whether we can get more. What do we get more from the evidence generated to ensure that we are helping to ensure that the women, the babies, the adolescents, and their families across board get to benefit from this. The program carries across 3 sessions. The morning session where we'll start with reproductive health, adolescent health, and health systems. Of course, typically talking about policy, contraception, menstrual health, and maternity care. After lunch, we will move into gynecology, and we eventually close it up with the maternal health with abstracts talking about outcomes, complications, and evidence behind safe deliveries. A quick note on the format for today, especially for the presenters. Since we have a full program ahead, each presenter will have 5 minutes of presentation, and we will have all of the presenters give their presentations. So I ask the audience to note down some of the questions. Then at the end of their presentations, we'll have questions coming into each presenter. With that, I think we need to go on and open the plenary session 1. That's about reproductive health, adolescent health, and health systems, which I will also take the pleasure to chair. With that, I will ask Susan Asimwe to come and present her work on adolescent reproductive health policy in Uganda. Please, Susan, you may take the floor.
Ladies and gentlemen, protocol observed, good morning. My name is Susan Asimwe. I'm a lecturer at Kampala University and a PhD at KU Leuven in Belgium. Today, I want to, like mentioned, I'm going to talk about a study. Maybe I should start with a scenario that we can associate with. Imagine a 14-year-old girl coming to one of the health facilities and she wants a contraceptive. One facility tells her, counsels her and tells her about abstinence and emphasizes that if she needs a contraception, she either comes back with a husband or with a parent. she moves away to the next facility where she requests for a contraception, and they counsel her about the various methods, and they give her the method. And now the question is, the health facilities in Uganda are operating the same policy environment. Why is this adolescent getting different versions of the response? So this study looks beyond if we have policies or guidelines, but it asks, how are these policies developed? How are they interpreted? How are they enacted? And how are they implemented at the level of the health facilities? And that's why we say that this is from centralized policy development but to uneven implementation, because the implementation is different at different facilities. When we look at our a little bit maybe of the background, I have no conflict to declare. We see that indeed Uganda has policies, very many policies, but we still see that the outcome is still suboptimal. When you look at the adolescent pregnancies in Uganda, they say 1 in 4 adolescents has either been pregnant or has had a childbirth. We have guidelines that are helping us to understand this, but we still ask why. So we know the determinants, why are they becoming pregnant? But we don't know how are these policies developed, how are they implemented? And that's the question that this study answers. The main objective of this study was to understand the adolescent reproductive health policies, how are they developed, how are they implemented. Then we also had to look at what are the facilitators to implementation, but also what are the barriers. After understanding the barriers, how are these health workers coping with the barriers? Then we see how was the study conducted. When you look at our methods, this was a qualitative study that was done among policy makers and policy implementers. Our policy implementers included the nurses, the doctors, the VHTs, and we had policy makers from the national level, and it was conducted in southwestern Uganda, that is in the 8 health facilities in Mbarara and Kabale district. The central finding of the study was a chain. When we talk about policy implementation, most of the times, people are going to come at the implementation. But when you see the problems that are coming at the implementation, they are actually originating from the development. And at the development, we see that donor dependency, centralized governance, they shaped how these policies were developed. But weak dissemination, policies are not in the health facilities. They made the health workers or the frontline people take decision. It means they are interpreting the policy in a way that they understand. And when that happens, we end up with an even implementation within our health facilities. And when we look further into what facilitates development, you will see that, yes, there was a structure. Participants reported a structured ministry-led process. But we see that the district partners, their contributions were not necessarily informing the policy development processes. We see that they had donor support for the policies to be developed, but also the study found out that the donors had to shape what are the priorities of the policy and what should actually be included. Then when we look at the implementation, what is happening in our facilities? Weak dissemination, policies are not there, guidelines are not there in the facilities. What is there? Resource gaps, staffing, stockouts, and so many other things. Consent ambiguities. Health workers were in the dilemma of, do we give a Do we give a service or we don't? And why does that happen? That happens because the guidance is not present on the ground. So that alone led to health workers taking the decisions in their hands, and that means that there will be differences in the quality of care they give. But with all that, we asked, how do you cope? How they cope? Yes, they will improvise. You'll find that the funding that was for something around PHC, it will be improvised there. They will integrate adolescent reproductive health services in other routine services. They will use community support, but all these were informal. And when all this is informal, it means that the decision and the progress of adolescent reproductive health services depends on the individual. It means that when they find me in a facility, I will decide which service you get, but not the systems helping you get the service that you actually need. So how do I conclude? In conclusion, we are saying that Uganda has adolescent reproductive health policies, and it is committed, but the implementation is very uneven. And for us to move from that unevenness, it means that we must get stable funding for the adolescent reproductive health. There has to be a clear consent guidelines for the health workers, and also policies have to be disseminated. They have to be supervised. We need feedback so that adolescent reproductive health can become even facilities. Thank you so much. That's my presentation.
Thank you very much, Susan, for that first presentation. Yeah, so stays with us for the next presentation. Of course, our next presentation is looking at how the World Health Organization Global Standards for Adolescent Health Care plays out in practice. Over to you, Susan, again. Make sure we have a timekeeper just here, so you need to keep looking at them to ensure that we are keeping in time.
All right, thank you so much again, Chair. And this study is more like a continuation of what we have just finished. Here we are looking at when policy meets practice. And the previous study was done among the health workers, but this study was done among adolescents and their caregivers. So there you're seeing like a 16-year-old girl reaching a health facility to get a service. But what happens at the health facility? Do you think this girl is going to get the standard quality care that she deserves? And that's what WHO it describes the exact care that this child or adolescent should actually reduce. So when we look at our background still, we see that we have the policies like already mentioned, and they actually align with the global requirements. You will find that if the WHO says that these are the service standards, Uganda has taken on the initiative to say these are the service standards that we are taking on. But why is it that we are still seeing the outcome that we are seeing? So here we wanted to know, how are these standards implemented within our health facilities? The main objective of this study, as mentioned, was to examine how Uganda adolescent reproductive health policy standards are implemented and experienced by the adolescents. We used the WHO as a benchmark, and then we interpreted the coping using that other theory, the street level bureaucracy. As mentioned still, this study was done in 8 public health facilities in Kampala and Mbarara. We also did in public schools, 8 public schools. We interviewed 80 adolescent girls aged 15 to 19 and their caretakers. And we mapped our findings onto the WHO standards, meaning that we had the WHO standards as our benchmark, and for us, our role was to observe is this being done or this is not being done? What was the main finding? As you can see there, we see that actually the central finding was that there is no single standard that was comprehensively adhered to. They were either partially or they were absent. But core in the health facilities, you can see that community support was absent, and also adolescent participation was very weak. When we look at the schools, curriculum integration was completely absent across all the schools, and the same to monitoring and evaluation. What did the adolescents experience? Now the adolescents interviews, they brought like the real life of the standards. That's what showed that actually standards are there or standards are not there. But what did they experience? Some experienced respectful care, confidentiality, but while others were reporting scolding, were reporting being abused, and so much on so. But these interviews showed us that actually the standards are experienced in the consultation rooms, and there are no standards within the consultation rooms. How did we interpret these standards? We ended up saying that yes, there is alignment, but without institutionalization. We are saying that policies are very good on our paper, but very weak within our institutions. They exist, but they are not in the budgets. They are not in supervision. They are not in data. They are not in schools. And that's why we have selective implementation. And as we conclude still, we are saying that Uganda has adolescent reproductive health guidelines and service standards, and they align globally, but they are very unevenly implemented within our institutions. And the recommendations we made is to embed adolescent reproductive health within financing, facilities, strengthening adolescent-specific supervisions. You'll be sure that when they come to supervise, it's hard that they will be specific on reproductive health for adolescents, and integrate them within schools. And that is it at the end. Definitely, I would like to, this paper has been published, and I would like to also acknowledge my co-authors, Professor Christine and Dr. Viola Nyakato. So thank you so much for listening once again.
Thank you very much, Susan, for the very eloquent presentation. We'll ask you to first sit and we get to listen to other presenters. By now, Eugene Kato should be ready to furnish us with information about menstrual products and security among adolescents at Chitagata Secondary School. Please, Eugene, proceed.
Thank you, Chair. Good morning, Chair, esteemed guests, protocol observed. Good morning. Our study was on prevalence of menstrual product insecurity and associated factors. Maybe we can start with a scenario. Imagine you're a 14 or 12-year-old girl in a rural area, for example, in Mbarara, deep in Chitagwenda district. And as you're seated in class trying to master his SST and all those subjects, you realize that you have started your menstrual periods, but you don't have a pad, a sanitary pad, you don't have money to buy one, and you have no one to ask for help. You can imagine what would happen to you. At that moment, your focus immediately, suddenly shifts from learning to fear, embarrassment, and simply trying to get through the day unnoticed. Because if you are noticed, it would be a big embarrassment. So we I have no conflict to declare. So we found that about 46% in literature, especially a study that was done by Ministry of Education with UNICEF, only 46 adolescent girls had access to sanitary pads. This is a very small number, considering that at least every girl should be able to access sanitary pads and not use other clean cloths, and some girls sitting in the sand so that it just blood just stops coming. So this is very small, and therefore our study wanted to look at ways on which policymakers, schools can bridge these gaps. There has been some policies that have been put up by Ministry of Education, but of course, as you know, a few years back there was a suggestion that these can be sanitary pads and sanitary materials can be provided to schools for every girl, but it has not been implemented, and such presentations give us an opportunity to find policymakers and who can take up these opportunities and change something. So two methods. So this is a picture that we got at the facility, one of the area, a toilet that was being used. So we had two objectives, as I said, prevalence and then associated factors. And we did a cross-sectional study involving 384 participants, the adolescent girls between 12 and 19 years. And we found out that 66.1% had insecurity. We looked at the past 6 months if you were able to use a good sanitary pad. And about 2 in every 3 girls had no good access. And especially those who was most affected, the young girls, young ones who have just joined secondary school. And of course, this explains also another category of senior ones and senior twos. And then also girls that were from poor backgrounds, low socioeconomic status at home. For example, a parent is unable to earn or earns less than 50,000 shillings a month. So, can continue. What do these results mean? I mean, so product insecurity is not only an economic health problem, but it is also issues that stem from inequality. School-based material product support programs, for example, like I said, to provide emergency pads. Then Ministry of Education and Ministry of Health can also put up a smaller budget, because as per now there is no any budget to focus on that. And we, the communities, can also try to address household incomes, because if a parent is okay, can be able to provide these sanitary pads to their daughters, to their young daughters. So that's our study. Thank you. Thank you so much.
Thank you very much, Mr. Eugene. We are glad that you're tackling a very good area of the adolescents. Please sit and wait for some of the questions coming from the audience. Maybe we shall get to listen to Tarema Julius. I'm not sure whether that is going to take a bit of time, but maybe as we
actually were happening, they all went back to zero. So that's why we are recommending that they need stable domestic funding. So if these things are to progress, it means it has to come from the policy development. They have planned for it. It is in their implementation plan. It is embedded within their financing. And that's the only way you can actually sustain it.
Great. Do you have any information? We have some DHOs, some managers of the facilities that might be actionable to your information. Any special message you're giving them?
I may not be very brilliant to give you the information that you may want to hear, but we may use the scenario that is happening in our, recently that is happening across the country, especially the visits that the honorable ministers are making, like in the local government. We have seen Minister Balam visiting the facilities, and they are shocked to see that patients are sleeping down. They're asking doctors, why are patients sleeping down? Now, you wonder, is this a doctor problem or is it a system problem? So that's why we are saying that the problem of that we are facing at implementation are problems that are originating from the policy development process. So it would be nice that fill your reports, submit your reports, raise your voices, give feedback so that actually feedback can be embedded within the policy development. But from this study, we saw that actually they did not have feedback from the ground. What they had were some consultations from the DHOs, but they were also not sure if they were going to inform the policy. So it is to continue to report, to continue to make noise, and to continue pushing for things to change a bit. Thank you.
Yeah, thank you very much. You scared us a little bit when you said they should call for Balaam. But at this juncture, we need to welcome Julius Taremwa to share his work on respectful maternity care in southwestern Uganda. Julius, please take the floor. You can use that microphone. Thank you very much. We shall continue to interact with them maybe for a few minutes after Julius's presentation.
Yes. Good morning, ladies and gentlemen. I'm Julius Taremwa, a researcher and a PhD student. I'm going to be presenting work on respectful maternity care. A study, one of the studies that we have conducted in southwestern Uganda, that is Mbarara district, Mbarara city, and Mitoma district. With the title, Prevalence and Determinants of Respectful Maternity Care among women delivering in selected public health facilities in southwestern Uganda. This is a paper under development. Respectful maternity care, it's a fundamental human right where every woman attending a health facility requires to be treated with dignity without abuse. Disrespect and abuse during childbirth remain common, especially in our health facilities. Poor birth experience is, it reduces trust in the health facilities and future utilization. So it's a big problem that we need to address, because much as we are addressing the factors to bring mothers to attend our clinics, but a poor birth experience will play us back to reduce the utilization. With the objective to assess the prevalence and determinants of respectful maternity care in southwestern Uganda. This is part of an RCT, but in this methodology I'm using a cross-sectional survey. Facility-based cross-sectional study in selected public health facilities. Study population was 700, we analyzed data of 753 as part of a mother study that had 824 participants. We used the standardized RMC questionnaire, descriptive statistics, and bivariant, and multinomial, where we graded respectful maternity care as low, moderate, and high according to the tertiles. In the results table, they might not be clear, but in the summaries, those are the age categories. The next slide. Yes. 64.9 reported moderate to high respectful maternity care. And out of the 753 women that participated in this study, apparently 82.2 experienced at least one form of disrespect and abuse in this study. This means respectful maternity care has remained common, and disrespect and abuse remain widespread. There were significant associations in the determinants of respectful maternity care. Significant associations, women that delivered in rural health facilities reported tended to be in high respectful maternity care. Rural was classified as a Mitoma and Mbarara district. Mbarara city as peri-urban. Women that attended health facilities with a birth companion tended to be in high respectful maternity care. Women that delivered by cesarean section and women that were attended to by specialists. These were common in the private health facilities that were part of the study. Surprisingly, there were factors that were not significant. That is age, marital status, education level, parity, which implies facility healthcare providers and women, facility and providers factors influence women childbirth experience more than the individual factors that we have talked about that include age, marital status, education level. In the recommendations to promote a birth companion during childbirth, women that came without attendants or that without husbands, without support people were low in respectful maternity care. And then to strengthen provider training in respectful maternity care. Thank you so much. This is the team. Next slide. Yes.
Thank you very much, Dr. Tarema, for taking time to share with us this important information on respectful maternity care. It's at this moment, in the interest of time, to get comments from or questions of this team so that we can go to the next one. Someone to move the microphone to the speaker behind there. Press. Yes.
Okay, thank you, Chair. My question goes to Dr. Taremo. I wanted to know what you defined respectful maternity care as. I was a bit confused as you were presenting. I was thinking, was it merely the absence of disrespect and abuse? Thank you.
Yes, you can give to the gentleman next behind you, so he can also give his comments.
Thank you so much. I'm Dr. Ronald Chatwembire. My question goes to the presenter. How did you assess that respect? Because I'm seeing the constitutional design, but did you use observation method? Did you use the questionnaire? Was it during the service? Was it after the service? Because some of those factors can actually influence what people may report to you. Thank you.
Yeah, thank you very much. Any other questions? Tarema, you're already seemingly having a full plate. Maybe I could add a little bit because you seem to notice you report 82.8 experienced some disrespect. Then you say 64.9 still rated care moderate to high. So I'm just wondering, how are you getting to marry this? Some are saying we have disrespect, and another, a significant population is also saying we are actually having care. Any questions? Any more questions? Yeah, I prepared a question for everyone. So Eugene, I'm interested to know, you said 2/3 of your population that you studied had insecurity, and do you have any intervention that you're putting across or that is already happening in the schools to ensure we have some sort of security in that regard? Maybe we can first hear from Dr. Julius, then we can hear from Eugene.
Thank you so much. In the definition of respectful, we assessed using a validated tool for assessing respectful maternity care. Why 82.6% reporting any form of abuse? We defined any form as any person reporting any form whatsoever. Someone might be reporting in the analysis, a woman might be in the high, but has at least one form of abuse, which could be a problem. So N is why we have the 82.6 is N. But then the overall, when we assess using a tool, respectful maternity care for moderate and high, is where we have 64. I think I didn't note down the question from Ronald. Ronald, I beg your pardon on the question. Yes. Yes.
You said use a standard tool, but a standard tool, the whole components of it, because some may be observational, some may be retrospective, a questionnaire, getting the experience retrospectively. So I didn't see the two. That's why I wanted to know why exactly are we assessing?
Okay, thank you so much. We are using a standard tool at exit after delivery. Within 6 weeks following delivery, we're inviting the women to the study center and then assessing respectful maternity care. So it was an exit questionnaire that had a validated tool. Which included, in the definition, that included dignity, privacy, confidentiality, freedom from harm, informed consent, and a loving environment as some of the components. Thank you.
In the interest of time, we may have to hear from Eugene so he can give us his comments. Then we can hear from the last presenter before we go to the next session.
Thank you, Chair. About doctor's question on the current interventions to address this insecurity, what is absolute and hugely clear is that these insecurities need policy interventions. But what we are emphasizing now is that each secondary school or a primary school has a senior woman, and what we can do right now is that we can equip these senior women to address some of these challenges to the biggest extent they can, and also equipping other teachers with knowledge, because they are the immediate people that can interact with these girls while at school. Thank you.
Thank you very much, Mr. Eugene. I hope the ball is already rolling in ensuring that you keep the teachers, or what you just presented is just a start of something big. Maybe in the next year we'll see what you will have to present for us. Yes, we'll receive the last presenter, Dr. Robert Mukembo. I know him for being a good surgeon in training, but I'm glad that he's also getting interested in emergency contraception. Please, you're welcome to share with us what you found and your team. Can have the microphone and please present.
Thank you very much. Good morning, ladies and gentlemen. I'm Robert Mukembo. I'm the head of medical services, Gulu University, and to assess the prevalence and factors associated with emergency contraceptive use among female students of Gulu University. And I do not want to preach the converted here, that emergency contraceptives are an important tool that we use if we are to improve reproductive health services across the globe. And majorly in the country, we have majorly the pills that are commonly taken. The common word in the community is morning after pill, and then intrauterine contraceptive devices, which can be used. The pills can be used up to 72 hours, whereas the IUCD can go up to 120 hours. Can move. We know that low utilization has been reported in several studies across the globe and in Uganda. And in Europe, we have seen that only 52.9% were using emergency contraception. And that's one of the highest that we found. In Brazil, it was at 50%. However, in sub-Saharan Africa, most of the studies showed a low utilization. As you can see, it ranged from 0% in DR Congo, and some sub-Saharan Africas had, like Nigeria, had 54.1%. And in Uganda, we had one of the studies which showed that 51% of our population is sexually active, and majority of them, they are not using contraceptive methods. We all know that university students are among the sexually active populations. Next. From studies, there are several factors that were associated with low usage of contraceptions, and as such, they end up with unwanted pregnancies and end up with the criminal abortions, some of them which have always ended into mortality or poor maternal outcomes. So this study was aimed at assessing how the university students are using, the prevalence of usage, and which factors hinder them from utilization. Next. The prevalence of usage and which factors hinder them from utilization. Next. We can go to the next. So our general objective was to assess the prevalence and factors associated with ECUs among university students, female university students aged 18 to 49 years of Gulu University. And we purposely, specifically wanted to determine the emergency contraceptive usage prevalence and then the associated factors. Next. In our conceptual framework, we noted that there are several factors which are associated with usage. This may be about age, you might be about access. We have people who may be marital status, which is affecting their utilization, and maybe religion. And all these can affect how the person uses the emergency contraception. And in the end, when utilized properly, it can reduce poor maternal outcomes and unwanted pregnancies, which can at the end improve maternal health. Next. We used a cross-sectional study design, and as I said earlier, this was a single center study which was done at Gulu University. Next. Our population was female students of Gulu University aged 18 to 49 years, and we targeted majorly female students of reproductive age in that population who were present during the study.
Okay, Robert, you have a minute to go, so you try to summarize in that time.
Okay, we can move to results. So in our study, we found that the mean age of the study participants was 24.5, and because of the tribe, the study was done in Acholi region, majority were Acholis, and then year of study, majority of them were in third year. We studied 415 participants. Next. So we found out that 60.5% of the participants had engaged in sexual intercourse, and with 169 of them having had unprotected sex, and the mean age at which they had their first intercourse was at 20 years, and 32.7% got pregnant due to unprotected sex, and most of them, 50.9%, were unplanned. We can move. Utilization was found to be low at 41.9%, and the majority of these had used emergency contraceptive pill. Next. The overall knowledge about emergency contraception was quite good, and you can see it was at 73%. And the major reasons why they were not using the EC methods was negative attitude towards emergency contraception. Others were not using because of questions about effectiveness, and yet others have issues with the sources of information. The major source of information about the pill among these teenagers and young people was from friends and from sexual partners.
You may give us the parting shots so that we can get a few questions for you.
We found that similar studies had found similar factors associated, and as we have seen in the background, several studies still within sub-Saharan Africa had shown low utilization. Specifically for Uganda, this was our recommendation, that we recommend that university managements prioritize reproductive health services when they are planning and budgeting. Because much as the Ministry of Health prescribes the medical health centers in the universities as first aid services, these are young people who are sexually active. And one of the reasons is they do not use the EC pills. One of them is cost. They have had sex in the night and they cannot access it easily in the nearby pharmacies. So if at all the government prioritizes provision of these emergency pills and the emergency contraceptive services in the university health centers, these young people, especially the young ladies, can easily access these services for free and protect themselves from unwanted pregnancies, and as such, also avoid the effects of unwanted pregnancies, including poor maternal outcomes. The other recommendation we give is that we do a multi-center study in several institutions, in several regions, because we know social cultural practices may affect utilization. How we access it in Ankole may not be how it is socially perceived in Acholi region. So we recommended that the study be done in multi-center studies across Uganda. Thank you.
Thank you very much, Dr. Mkembo. Any questions for Dr. Mkembo before we go to the next? Yeah, I was just interested to, maybe you can have a seat to know whether you think the problem is the knowledge or access, because you seem to notice those who have used before probably will use again. Yes, so do you think it's knowledge or access that might influence the non-use? Yeah, please.
Thank you. Like you have rightly noted that in the study we found that those who had used the EC method before were likely to use it again. But as you've noted, this was influenced because of their thinking that it will protect them. But in our study, we found that low utilization was actually as you proceed through the years of study. The third years and fifth years were actually less likely to use the pill. Much as we know that as they go through the university, they attain more exposure and more knowledge about some of these things, including EC methods. So we still think, yes, knowledge may affect utilization, and as you noted, that 75% had good knowledge. But despite that good knowledge, still the utilization was low. So we still have to emphasize and teach the young people about the EC methods, but as well as you teach them, you have to also improve accessibility.
Thank you very much, Dr. Mukembo, and thank you, the first presenters for the morning session. At this point, I thank you and want to ask you to take back your seats. Oh, you have a question, please.
Thank you very much, Chair. Sorry, I kept trying to manage the slides and I didn't concentrate very well. But my comment is about the policy about adolescent health. We clearly see that, yes, we have policies now. Very sure now we have even an adolescent reproductive health department with even a commissioner and the deputies. Moving forward. One of the areas that seem to be an issue is about the dissemination of these policies to frontline level workers. I know this may not have been spoken in the scope of the study, but maybe if you could speak to that. If we could speak to, if there are any areas that you have looked into, how we could improve on dissemination of these policies so that they reach us, the frontline healthcare workers, and ensure that we serve these adolescents.
I hope that is clear, Susan.
Yes,
this is.
Thank you, Dr. Ahabwe. And yes, we saw that policies and guidelines are not disseminated to the respective users, people who are using the guidelines. How they can be disseminated is not something that we looked into, but it is a process, but it is like we saw, it starts from the policy development. When they are developing the policies, they have implementation plan. In their implementation plan, they have a dissemination plan. So these things are affected by a number of factors. How is it developed? How is it financed? How is it interpreted and communicated? So maybe the real challenge is within how is it communicated, but it has to be financed. Who is going to go? Is there a budget for it? So all these things for them to actually work at the implementation in your health facility, in your hospital. It means that someone who sat on that table up to plan for this policy must have planned for how it's going to move. But if they don't plan for it in the policy development, it still means they shall not have policies and guidelines. Are we together? Thank you.
Yeah, thank you very much, Susan, for the response and the comments. Mukembo, you had a comment?
I wanted to still comment on the sexual reproductive health rights and policies. In the universities, we notice that most times the way these policies are formulated, the young people or the stakeholders, the students, are usually left out. I work with a university setting and I know how these things are formulated. And even when these policies come or are made, dissemination is very poor down to the students. And for my studies, I noted, one of the things which affects is how this information is distilled down to the young people. There is no proper reproductive health policy which is being implemented in the universities. So, like Susan has noted, the university management, for example, in my study, when they are formulating reproductive health policies, they should engage the young students and know their reproductive health needs. And as they develop these policies, they capture them and plan for them accordingly, rather than pushing down from top to bottom without their consultation. Thank you.
Thank you very much. There is someone with a very burning question at the back. Please, you have 30 seconds to share that with us so that we can move to the next.
Good morning. My question is to the presenter on emergency contraceptive. So 2 questions. Most of the presentations I see about emergency contraceptives concentrate on the morning after pill and give yet less information about the IUD. Do you have a clear-cut statistic for the IUD? Because it's actually an emergency contraceptive that is in the long run a long-lasting contraceptive method. So did you properly explore that in your statistics? And yeah, that's my question. Imagine the IUD. I want to know if you properly explored it, because it's a better, much as we spread so much information about the after morning pill, it could be more beneficial to actually give more information about the IUD to university students, because it's actually a long-lasting method. That's why over time they actually abuse the morning after pill, because there is actually lesser information on the IUDs. Thank you.
I'm not sure that I should answer for him. I know he only dealt with the pill and didn't deal with the IUD, but maybe I could give him just 30 seconds.
Like you have rightly noted, the most known method among young people and even a good section of the community or population is the morning after pill. And maybe it could be much utilized because it is easier to use than the IUCD, which is just provider dependent. So it is practically difficult to adopt among young people. But as you have noted, we need to do a study whether it is being actually utilized and who are the utilizers. In my study, the people I studied, majority of them didn't even have information about that.
Thank you very much, presenters.
Thank you so much. 5 minutes. My name is Emmanuel Nsadu. I work with Premium Medical Services. By God's grace, I work as the head of the marketing and sales. Department. So we are here not to present, but just to let you know about Premium and why you shouldn't leave the hall minus visiting our table of Premium Medical Services. Now with Premium, we look to be new in Western Uganda, but we are a well-established company leading in the fertility field, both specialized and concerned with providing exceptional, comprehensive and world-class medical services in Uganda and East African countries. As Premium, we have a huge 15 years experience of focusing on high quality products, representing companies from USA, American Medical and Science, Netherlands, and South Korea. Now what we do is the reason why we are not giving a scientific presentation. We do more of a service. Most of what we do is a service. We deal with facilities. We help facilities in establishing IVF facilities. We've been behind around 7 IVF centers, including the newest ones of Mlago and FemCare. So in case you would like to have your facility have the IVF equipment, start the IVF services, premium medical services, that's part of what we do. Actually, we do the A to Z of IVF, right from installation, servicing, and supplying you with all you need throughout the process, the catheters and everything concerning IVF. That's premium medical services. In addition, we also have fertility supplements tackling almost all issues of infertility. We have fertility supplements tackling endometriosis, supplements tackling fibroids, supplements tackling low ovarian reserve and mixed ovarian reserve, and many more. Supplements targeting quality of the ovum, of the oocytes. As for the male side, supplements tackling the sperm count, the sperm motility, and morphology, and more. So that's what premium medical services do. We work with reputable and experienced companies like the Copper Surgical for installing the IVF facilities. Then we work with AOGU Chem. This AOGU of the one you see for electronics, it has the side of pharmaceuticals. So we have a good number of hormones from the AOGU Chem. Then we work with American Medical and Science, very reputable in making the fertility supplements that we're going to see when you come to our stall. We've been given 5 minutes. My name is Emmanuel Nsadu. Thank you for listening.
Thank you very much, Emma. Representing Premium Medical Services, we have heard your story. So let's get a presentation from Maristops.
Yes, good morning. Good morning, colleagues. My name is George Blime. I'm the head of sales at Maristops Uganda. I know some of us know Maristops for programs, donor funding, but we have products that we do actually sell, distribute across pharmacies and hospitals. So I'll be focusing on that side. Briefly, I've come to talk to you about our Kobe pack. For your information, I know you know that we have the combination of mifepristone and misoprostol listed on the essential drug list. Before you could talk about this I don't know, behind the doors, but it's open now. And we have these products already listed by the government. National Medical Stores has their combi pack already. I have seen some product distributed by Joint Medical Stores as a combi pack already. However, there is the private sector. Some of us, I know, you work either from the public or private. So for those that need it, we have a product called Mariprist. Mariprist is a combination of mifepristone and misoprostol. And of course, the indication for this product is management of intrauterine fetal demise. And the government, of course, from the manual, they have provided the indications. But we also know that there is also medical abortions happening. Okay, someone comes for whatever reason, you have a conversation, and there's a need for medical abortion. Maybe you can move to the slide that has the product. So this product, if I may say, it is the Mercedes when it comes to the combi packs. There could be very many on the market, But when you want effectiveness, 98% effective rate. It has a tablet of mifepristone. This is how it looks like. It has 5 tabs. There's a mifepristone, which is a progesterone blocker. Okay? Of course, blocks the progesterone and will stop the progression of the pregnancy. So meaning, whatever is inside will stop to live. Now, you take this orally with water, all right? So after 24 hours after they have swallowed the mifepristone, they put the misoprostol under the tongue, sublingual. And of course there you have the contraction. And like I said, you have all the products of conception taken out. So it's very effective. So if you are a colleague here and you are still using misoprostol only for management of intrauterine fetal demise, you are practicing wrong science, like postdated science. This is the right way to go when it comes to management of IFD and medical abortion. The last product I would want to talk about is, I want to go through the science because I had made a lot of presentations, the contraindications, but we have a table which you can come and we can have those conversations. The last product is a Misoclear, which is the misoprostol only. So the other one was a combination of mifepristone and misoprostol, while the Misoclear is the misoprostol only. And of course, with this, we are positioning it for management of postpartum hemorrhage, very effective. Please note, if you're going to use misoprostol only for medical abortion or management of IFD, you have 78% success rate, while the combination we mentioned earlier, Mariprist, has 98%. So you can tell. Of course, with this, if you move to the next slide, we have made some changes on the pack. It wasn't looking like this, a few things we have done, but what has not changed is the formulation. We still have the right molecule that can give you the desired effect for management of postpartum hemorrhage. However, in absence of the combination, of course, as you know, this can still give you the results. But the priority for management of IFD and medical abortion, we should be able to use the combi pack that I mentioned, the Mariprist. While the Misoclear, misoprostol only, is for postpartum hemorrhage. That marks the end of my presentation. Thank you. I'll request everyone here for more information and more discussion. We have a table just behind here where you see the milestone banner and another one outside. We have other interesting products. I had you talk about the emergency contraceptive pills. We do have backup. We have Well Plan, which is a combined contraceptive pills. We have condoms. Visitors, we can have more conversation on our table. Thank you so much.
Thank you very much, the team from Maristops. I hope everyone has heard. For more info, please, you can reach them. They are right behind there, and you'll get all the information you need. Let's now hear from one of the other people that have ably sponsored this event and have been sponsoring us for a while. Mega, you're welcome.
All right, protocol observed. Good morning. I'm Aaron Sekande and I work with Mega Life Sciences. It's a pharma company which has worked with us for over 30 years and products are very common with us. Mentioned a few, but we supply Calcivita and Feodon. I know that's a common for AOGU or for Guy. So it's a pleasure to be here and I was so excited when I got the invitation, and Mega is one of the platinum sponsors for this conference. So I'll just go through one of the common reasons why ladies visit the clinics, and that is the vaginal infection. And our presentation will focus only on the mixed vaginal infections. So looking at the causes of vaginal infections, and BV, bacterial vaginosis is there, candidiasis is there, trichomoniasis, and the last one is mixed infections. And the clinical features are very common, we get them in the clinics. And looking at the study which we have here about the prevalence of mixed vaginal infections, the numbers are the numbers are here for Uganda. The mixed vaginal infection takes the biggest chunk of 58.45%. So whenever you get any issues of infection, vaginal infection, it's very rare you get a single cause. It's always mixed with them, both BV and or candidiasis, or the protozoal and the fungal cause. So what is the recommended drugs for this mixed by all the infections? When it's a BV, they recommend Metro. Metro for 7 days when it's BV. That is the CDC recommendation. Metronidazole for 7 days. And when it comes to candidiasis, recommendation is on miconazole. There are many. We have many. The old molecules like nystatin, clotrimazole, but the latest one is miconazole. So this looks at the recurrency and the cure rate, why we recommend miconazole, and the dosage is going to be for 7 days also. So, and last one is trichomoniasis, which is very risky when it comes to pregnancy, and we say for trichomoniasis, irrespective of the stage of pregnancy, you have to treat this patient. So it will cause low birth weight, and it can also cause the preterm birth for the mothers. So it is recommended, irrespective of the molecule, when it is trichomoniasis, you have to do the treatment, irrespective of the molecule. And what is the recommended treatment? Still, they recommend Metro for 7 days. You can do 2 grams orally single, but 7 days is preferable, where you can do 500 milligrams or 750 milligrams once a day for 7 days. When it comes to mixed infection, then it calls to have a combination therapy. So we bring to a combination therapy which manages the mixed infection. And other than it, unless you do culture sensitivity, most of the infections are going to be mixed, and rarely we do culture, or as we wait for the results, we have to treat the mixed infection. So the coexistence is very high, almost 70%. You get a BV or candidiasis combined. So what does Mega bring to you? I see my time is up. What does Mega bring to you? We bring to you a combination of the fungal and the protozoal, and the brand is called Invalfort L. It is available on the market, which is a combination of the miconazole and the Metro. Miconazole 200 milligrams and Metro 750 milligrams. And the most important composition here is the lidocaine. They all come with pain and burning. So Invalfort comes with the Metro, miconazole, and lidocaine as the only combination which has the lidocaine. Because the most cause which brings the mothers or to the patient to your clinic is the pain or the burning. And another reason why we put the lidocaine, miconazole as a molecule causes severe burning. And when I launched without miconazole, without lidocaine, most of the doctors and the mothers were known time adhering the treatment because of the burning from miconazole. But also the disease causes burning. So put in the miconazole, which is a local anesthetic, and also improves the adherence or the compliance of the patient to the treatment. So Invalfort is available to manage the vaginal infections, and the cure rate is very high when you use a combination of Metro and miconazole plus the advantage of the lidocaine. So we have the Invalfort on our table. You can pass by, samples are available, but also this combination is supported by a number of studies which we can check on any maybe PubMed and so on. So Invalfort is available with us, and it's a pessary, and we know the advantages of pessaries. 1, prolonged release, quick onset of action, minimal systemic side effects of the drug, increased bioavailability, fast pass metabolism is also foregone, and no GI side effects of the Metro. So we know the ladies can easily adhere to pessaries than the oral treatment. No one will take Metro for 7 days because of its side effects. So Inval is available, Invalfort is available, and it's an OD for 7 days. Preferably bedtime will be good for our patients to adhere. Thank you. That ends my presentation. I have a number of samples at the Mega stores. Thank you.
Thank you very much, Aaron, from Mega. We are going to straight away move. Please, those that have questions, you'll have a minute or two after to ask. Yes, a representative from Mankind Pharma.
Good morning, everyone. I'm called Sidney Ogwal from Mankind, and I would like to thank AOGU so much for welcoming us back. We were here last year when we launched our drug, and today I want to briefly talk about some new development on what we saw last time. Last year we were here, we launched Dydrobone, and Dydrobone is a new brand of dydrogesterone from Mankind. In Uganda, basically, we've been with dydrogesterone, yes, but as Mankind, we put our brand with the brand name Dydrobone. Ever since we launched this drug, we have been talking to very many doctors, and I found out that there's certain thing that we need to highlight today. Among the progestin, basically, we have the progesterone and we have the dydrogesterone. And as Mankind, we have the Dydrobone, which is dydrogesterone. So as Mankind, we've gone so much into women health care that we have put this plant, as you see, in a 24 acres of land in our plant. And this is a plan where right from the API up to the final formulation, everything is automated. There is no human touch. And of course, we are the second company to put dydrogesterone in the market. And we've been getting a lot of questions. How sure are you this drug will meet the stringent requirement? As you go down, you'll find out that. Next. When you see Dydrobone, it has the highest purity, even more than the innovator, 99.9 versus 99.8 of the innovator. And this is a drug that we have really launched, and right from the feedback which we are getting from the doctors is really very, very good. I believe we'll be able to get more. And of course, we didn't only start with NDA. When we got this molecule, we took it across the globe. As of today, we have almost 5 approvals from European big labs, right from France, Spain, Netherlands. And this has given us the confidence not only to promote this drug, but also with the result which we're getting from our doctors right here in Uganda. Dydrobone is going to be a brand that I think we need to take on. So, as I said, in Uganda, we have 2 main progestin that we are using actively. We have the natural micronized progesterone, and we have the Dydrobone. But when you see the bioavailability of the two, you'll be able to see that Dydrobone or dydrogesterone is really a very superior drug in terms of bioavailability. When you give it orally, it is 5.6 times compared to the oral progesterone. And I will have 2 slides which I just want to explain in the next 2 minutes. This is one. I already talked about the bioavailability. When you compare, this drug is really very, very good. And most of the people whenever we prescribe progesterone, you find that dydrogesterone is very selective to progestin receptors, meaning the side effects is really very well minimized. And then secondly, you get the response within a very short period of time. When you see the onset of action is the fastest. And where there's threatened abortion, you really need to take care, and you need a drug that will act within a very short period of time. And this you'll be able to get with the Dydrobone. When you see the peak plasma concentration, almost 30 minutes compared to 3 hours of progesterone. So we believe this will be a nice drug for you to consider whenever you get these cases we're talking about. And then my second last slide. Yeah, this is the one that I really want to summarize. If we can get this, you'll be able to get really the benefit between the progesterone, whether you're taking it orally or you're giving it the vaginal formulation, you get that. Ours is the synthesized one. That one's more of bioactive. But still, in terms of bioavailability, this is really, really very, very good. And I've already said, when it comes to selectivity of the receptors, dydrogesterone is really very, very selective, meaning the side effects is really very minimized. Much as we have the formulation of oral progesterone in the market, but when given orally, it undergoes a lot of first-pass effects. So your patient will be able to get less drug, which may not give you the results. So that's leaving most of us only to use the micronized vaginal progesterone, which still the bioavailability is still very inferior when you compare to Dydro. And then secondly, In terms of the side effects, there's a lot of drowsiness because of neuroactive particle which is formed when you give progesterone orally. So in terms of safetiness, in terms of like when you give like breast tenderness, is very rare when you give dihydro compared to the progesterone. So as mankind, we really believe that dihydrobone, which is our brand of progesterone, is really a good drug that we need to consider. Thank you very much.
Thank you very much, the representative from Mankind. Let's now welcome the person from Troika Pharma.
Good morning, ladies and gentlemen. I stand here as Arnold Naturinda, as a field supervisor from Troika, and our stall is also there in the corner. Thank you very much for the invite today. And going on to, direct on to our presentation, Troika is a Russian word that means it was a vehicle that usually was carried by 3 horses. And for us, the 3 horses stand for imagining, innovation, and implementation. So that's then the next. Just further, still something to do with imagination. Back in the Celtic chariots, they introduced the iron rim in the first millennium, that is BCE. And then further still, we also found that, found also back in history, that also in China, in a state of Pingling Tai, also there was a site in Longshan where they also had iron. They also had the rims also that would also help these vehicles also to move. And similarly, as we've seen this evolution, maybe some of us as the millennials how used to watch on Cartoon Network, there was a cartoon that was called Flintstones. If you remember Flintstones, I think they had an iron rim like this. So whenever you saw the Flintstones running, the vehicle was a little bit bumpy. And as you notice, as evolution continued, it became a little bit smooth, as you saw now. This is what Troika, the horses usually used to ride. Then also wait. Then still, that was, I think, the one of the first vehicles that they had. Then this other, the extreme wheel. I think many of us enjoy that one, especially for those who enjoy the other modern cars also. They tend to enjoy that other kind of rims. This is a hack to the ladies also. As you're giving us birthday gifts also, that rim would be very good also for us as gentlemen enjoying for the Fathers Union. So in the summer we've embraced the technology. We'd like also to call on for you to also embrace the technology also in the pharma world. How? As you've seen how the rims kept on evolving, also in technology, in the pharma world also we've innovated medicines that are also able to give comfort to your patients. How? If I gave you a medication that would be very affordable and also very easy for your clients to take, would you be able to prescribe it? That's a question now to you. The next slide. In the earlier times, me when I was born, there's a time we used to take paracetamol like this. We used to take 500 milligrams, 1 gram, 3 times a day. And each tablet was 500 milligrams. So that means you had to take about 2 tablets in every time you took a dose. Meaning in a day you only had to take 6 tablets. So with Troika saying that imagine and innovating, we introduced a new formulation, a new way to administer paracetamol, whereby you only needed to swallow 1 tablet 12 hourly. So which is Zyka Extend. Zyka Extend is a bilayer tablet that has 325 milligrams as immediate release and 675 milligrams as extended release. Next. So with this, it ensures a minimum effective concentration of 4 micrograms per ml. With this, a patient will be free from fever for 12 hours. Next. As you see in the conventional paracetamol, you needed to have frequent dosing because the half-life of it usually would range within 1 hour to 4 hours. So within a period of about 6 hours, the fever likely will get a recurrency of the fever. Next. So again, Zyka Extend is a bilayer tablet. You'll have a blue layer and a white layer all on 1 tablet. The whole tablet is 1 gram, but with the blue layer, it's 325 milligrams immediate release, because when a patient comes to you, the mother comes to you, they really want to get relief of the fever or the pain. So with this, the immediate release ensures fast onset of action within 15 to 20 minutes, then the white layer sustains the pain relief for that. So it's manufactured with dual phase technology that ensures that, that release. Next. That is the same that we were just talking about. Still with low-grade fever, 1 tablet in the morning, 1 tablet in the evening. The only exception comes with only high-grade fever that we may need to start with 2 grams as start and later on taper to 1 gram. As a cautionary tale still, this remains paracetamol. Please do not exceed 4 grams in a day. Zyka still remains as paracetamol. Still do not exceed 4 grams in a day. And just as still we were talking about innovation, also we have nasal beetle spray. So one of our new formulations that was innovated in 2019 is methylcobalamin nasal spray that every time you pump it emits 250 micrograms of vitamin B12. So it's manufactured with Nasomax technology. And nasal beetle spray for today, for mothers who are pregnant, those who are in lactation, those with PCOS, especially the ones that have vitamin B12 deficiency, nasal beetle spray will come in handy. The next. Lastly, but not the least, is Neurotroy SRR, that is a combination of methylcobalamin 1,500 micrograms, sustained release, and folic acid, 5 milligrams, then pyridoxine. Pyridoxine will be very crucial in preventing hyperemesis gravidarum, and folic acid also would also come in handy to prevent the tube defects. Neurotroy SRR is the only drug that we have. It's registered as a drug in NDA, as most of the nutraceuticals usually cannot be registered as this if you don't have the recommended dosage. So Neurotroy SRR is very available. Even Zyka is also very available. Then lastly, with our store, we still of course have other products, which is Dynapa AQ, Dynapa injection, which is diclofenac injection that you can give either IV or IM. Then also Dynapa tablet, and also lastly, Dynapa spray. Thank you very much for the opportunity. Have a lovely day.
Thank you very much, Troika Pharma. Please, another round of applause for our sponsors. Thank you very much. Besides the ones seated right there, we would also like to recognize other people that sponsored us and are here with us. In no particular order, we want to thank Mayanja Memorial, Ruharo Mission Hospital, Maristops, Divine Mercy, Sagifam, Chitagata General Hospital, the Department of Obstetrics and Gynecology, especially Eurogyne, Mbarara University of Science and Technology, NeoCare, Ajanta Pharma, Via Health, Crown Health. Thank you very much for the support. We really appreciate. And as you can see, we've put your money to good use and people are giving us knowledge. So thank you very much. I don't know if we have any questions from the house. We also want to thank Ayit TV on the ones and twos. Please, when they point the camera, you always smile. The tea is ready. At least now we can expend a little energy. Any questions from the presentations? Okay, if no presentations, thank you very much. The teams that have presented to us, please, for more information, they are around us and outside. You can reach them and have a discussion with them. Thank you very much. Okay, at this point, I would like to hand back to the chair as we sort the next item.
Yeah, colleagues, let's have Professor Mujeni as the last presenter. And then I think we shall be going to break there.
Yes, I'm glad to stand between your appetite and time. I'm Associate Professor Godfrey Mujeni. I'm an obstetrician gynecologist, and I'm going to share with us a presentation on effectiveness of the modified WHO labor care guide in a mood to detect prolonged labor and obstructed labor among women who were admitted at 8 publicly funded midwife-led community health facilities in rural Uganda. And this was an ambidextrous study, and it was carried out within our district, our city, and this is work that is expected soon to shape our practice. And I thank my sponsors. Troika sponsored me to be here, and I'm glad to be part of the sponsorship presentation. This is part of my PhD work that was supervised by Professor Josephat Byamjisha, the chair of NASMEC, and Professor Yarini. This work was funded by Support Moms project, which is an NIH-funded program at Mbarara University. We all know, next slide. I have no conflict of interest other than declaring that this was my PhD work. We all know that labor monitoring is essential for ensuring maternal and fetal well-being. And this is where, as a nation, we are crying. Our way of monitoring labor is not sufficient, and we want to pull up our socks. Prolonged labor, is just labor taking longer than expected. Obstructed labor is when there is failure of progress despite, adequate contractions. And this failure should happen as a result of mechanical problems. And when there's a mechanical problem and you don't relieve it, the next is going to be ruptured uterus and the resultant complications. Labor monitoring and early detection of these complications and treating them early is the only sure way of averting these labor complications. We all know that we have used the pathogram as a gold standard for monitoring labor for more than 50 years. And in 2018, WHO called some modifications, and this led to the next generation pathograph, which has been called the WHO Labor Care Guide. And this tool incorporates effective intrapartum care guidelines, including respectful maternity care, which has been ably presented in part by Dr. Julius. Next slide. Yes. The FIGO, Federation of International Association of Obstetricians and Gynecologists, made a statement. And in summary, a position statement is one of the high-level recommendations in our practice. In summary, they said there must be universal adoption of the labor care guide in all birthing centers in the world. In the interim, before we are there at the gold standard, monitoring labor using the labor care guide, the pathograph can still be used. So even if you're using pathograph, you're well. If you have moved to LCG, you're in the right position. Next slide. This study was a big project, but for today I'll only present objective 4, which is highlighted in red. But objective 1 was a systematic review to understand the practice of labor monitoring in sub-Saharan Africa, focusing on the pathograph. Objective 2 was exploration of healthcare provider perspectives on sustained use of the new tool as it was being introduced. Objective 3 looked at iterative development of the modified labor care guide. And then objective 4, today's focus, was to assess the effectiveness or the diagnostic predictability of prolonged labor, obstructed labor, and other implementation outcomes of the new labor care guide. And here we used some implementation science frameworks, including Proctor, and this we did among healthcare providers. The majority of you are here in Mbarara City and Mbarara District. Next slide. Generally, the methods, we had an ambidextrous cohort, which is a two-way. You start from here, look backwards, review the records of the patients that were monitored using the labor care guide. And we used the first quarter records of 8 health facilities in Mbarara City and Mbarara District in the year of 2023, meaning that we collected all pathographs which were filled in those facilities between January and April of that year 2023. And then you look forward in future, a prospective cohort. We enrolled women on the labor care guide following sufficient training of healthcare providers in the participating health facilities. We let them monitor labor without interruption. At the end of the period of 4 months, in 2024, January to April, we corrected all the LCGs that were used, and we subjected all the LCGs and labor care and the pathographs in the previous cohort to the same data correction tool, correcting variables from all these LCGs using the same tool. And we went ahead and analyzed this information, and we shall shortly share the results. Of course, we already know that we had 6 health facilities at the health center 3 level, 2 health center 4s, and all labor records in the time were reviewed. We excluded mothers who had an IUFD or who had breech presentation or who had twins. We also excluded mothers who had missing critical information, especially on the primary outcome. We did statistical analysis, we did qualitative study analysis, and next slide. What are the main findings? We found that 1,739 out of 2011 records came from health center 4s, and 272 health records came from health center 3s. This means that most of the labor actually takes place at health center 3s. The volume is very high in our area. We need to work hard to functionalize more health center 3s to conduct deliveries. The next finding is the labor care guide diagnosed 6 times more cases of obstructed labor and or prolonged labor combined compared to the pathograph. Let's this sink in. The labor care guide diagnosed 6 times more cases of prolonged and or obstructed labor combined. When you combine the two, the LCG was able to diagnose 6 times more. Next finding, the LCG was 4 times more likely to diagnose a case of prolonged labor alone. If you now say, when you combine them, it diagnoses 6 times more. But when you separate them, what is the situation? Still, the LCG was able to diagnose 4 times likely the cases of prolonged labor compared to the pathograph. Now we again looked at detection of prolonged, obstructed labor. When we studied the tools that had obstructed labor, we found out that the labor care guide was likely to diagnose a case of obstructed labor 12 times more than the pathograph. And I think that is very important. Next slide. We also had secondary outcomes. We looked at the level of labor augmentation. There was an increase in labor augmentation while using the labor care guide 3-fold. So people who were using the labor care guide were 3 times likely to be augmented compared to those who were monitored using the pathograph. Cesarean section. LCG increased the rates of cesarean section 6-fold compared to the pathograph. 5-minute APGAR score. We had improved APGAR scores 2 times more in the LCG cohort compared to the pathograph cohort. We again looked at tool completion. The LCG showed 2 times more likelihood of being completed compared to the pathograph. The data is clearly seen in there. We also looked at subgroup analysis and looked at many other variables here and there, and we did not find a lot of significant differences within the two. How do we interpret these findings? The LCG, next slide please. The LCG was found to be simple, and this is borrowing from the other previous objectives. I'm now combining the entire study. The LCG was found to be simple, easy to use, and was reported as a one-stop center for most of our labor monitoring needs. Healthcare providers reported that they took 2 to 5 minutes to record the parameters on the tool after assessment. What does that mean? I have my mother, I examine, and I know what I'm going to write. So it takes me only 2 to 5 minutes to put down the findings on the tool compared to the pathogram, which was taking them longer. Next slide is conclusion. The LCG was found to be a good and timely decision-making tool in routine labor monitoring. The LCG detected more cases of prolonged labor and obstructed labor before complications set in. And I just wanted to clear up something which I should have mentioned on the increased cesarean section and increased documentation, at the same time improving the APGA scores. So whereas in our cohort, C-section is seen to be increasing, it is because we have an unmet need. We have to reduce the cases which were going more into obstruction and ruptured uterus, which would have required cesarean section. And in this cohort, using the labor care guide, we found out that the cesarean sections were actually being done earlier when required, compared to waiting to do them late with complications and having poor APGA scores. I think that's the interpretation I should have mentioned there. In conclusion, the LCG was recommended for national rollout, and this is in progress. I acknowledge my supervisors, the funders, the Ministry of Health, the research team, the participants, healthcare providers, and we had ethical review at MAST and at the National Council. I think this is a summary of work that was done in 3 to 4, 5 years, and I've been able to present it in a very short time. You should clap for me. Thank you. I don't know who is my session chair. I seem to be in a session alone, and thank you.
Thank you. Welcome. Any query? One? What? Yes.
Thank you very much. Oh. Thank you very much. I remembered that I was one of his guinea pigs. Why? Because I'm a very strong proponent, supporter of the pathogram. And he wanted to convince me that the labor care guide is better. We shall ask him at the end whether he has managed that. Two things that I thought about. Completion. In your opinion, what made the labor care guide easier to complete compared to the pathogram? And number two, one of the main problems we've had with the pathogram is the retrograde feeding of the pathogram. The mother's delivered, then they go back and feed the pathogram. What makes it difficult to fill the labor care guide retrospectively compared to the pathogram? Thank you very much. Sorry, Dr. Waswasalong. I'm an advanced skilled birth attendant.
I would ask Chair, that I answer questions of my mentor before I tackle any other. Predominantly, there are three. The first one is, I will answer the last one first. About retrograde feeling of the LCG. We have been triggered a lot by very many challenges that we faced with the pathograph, and one of them is RBF, result-based financing. They paid you for filling the pathograph correctly. Because you know you're being paid, you'll monitor labor while you're sleeping, the mother delivers, then you come back, use your pen, and fill everything as if it is gold standard. The LCG also faces the same predicament, I'm very sure. Anybody can do anything. But to curb this, and I think I should stand up for emphasis, the Ministry of Health is moving to electronic medical records. And they have tasked my research team to digitize the labor care guide for IAFIA and any other medical records that is going to be used in the country. The process is ongoing, and every parameter you put in will be time stamped. And I think when you time stamp it, whoever comes tomorrow or next year will put the cursor on that parameter and we'll see the time when it was done. And I think that is going to solve the entire thing. Even when most of the medical records, when you go in to write anything, it will time stamp. And so will be the LCG. And I think without wasting a lot of time focusing on the hard copy, the case of investment for the LCG using the hard copy would have costed the country between 28 and 35 billion. Rolling out the LCG using the hard copy. But the soft copy is going to reduce that by 40%. And it has all the advantages, being enough here, having indicators that can easily be reported on and etc. So we hope we're going to go with a digitized form. What made LCG easier to complete? Whereas the LCG is a tool like any other, the same parameters like we did with the pathograph, only the way you present them is what matters. And what stands in between the complexity and the simpleness is the training. The quality of the training, changing attitudes, and knowing that the tool that we have is the best is going to make it happen for us. Our team, we know there are people who are very strong-hearted with the pathograph. They are very, very, very negative up to today, some of them, with the labor care guide. But with the training, with attitude change, our target is to convert all those diehards into champions of the LCG. They will love it better because it is simple, easy to use, and a tool of the ages. Thank you.
An applause for Professor Mjini. Thank you so much, Prof. I think you have done this. You may take your seat.
I'm Charles Irumba. Where I work, you know, they digitized that pathograph, the other one, into EF. But I don't know which devil came in. They never took the papers. I'm really praying that that day reach that LCG when it is digitized. Well, I don't know. It's a bit difficult, but I think if something is proven to work, it is really. Thank you much for your effort and enthusiasm with the LCG.
Thank you. I think that's just a comment. We hope the devil of of the pantograph doesn't follow the LCG. Thank you. Thank you.
Okay, thank you, Prof. That devil, we bind it. I was about to say, praise the Lord. Amen. So I think we have come towards the close. And so we are glad that we are almost, you know, the 3 delays. This microphone is not. 3 delays. I hope they will not affect us today. So with us today, we are lucky already that the chairperson for this conference is already around with us. And just would like him to wave to you so that you know that he's around. At the right time, he'll talk to you. The Professor Musa Kayondo, just wave to your people. And so anything good you see here is on him. Anything bad is on us. Eh? Yeah, take it like that. And so we are also lucky that we still have very many dignitaries who have joined us. We have directors of different hospitals who are here with us. We shall make a mention of them. We have several heads of departments from different hospitals, heads of departments for Obs and Gyn from different hospitals, and also the universities in the region are well represented. We have also several workers in health of women at different cadres. You have had PhDs, we have had masters, postdoctors. We have medical officers, we have residents who are doing masters, we have certificates, diplomas, bachelors in midwifery. I think we even have those who are not medical here. Some of them who are seated on the behind tents, they are here as exhibitors, but they work in health of women. So they're here to update you on how to work. We are also lucky that amongst the people that have joined us, we are lucky that amongst the people that we have several donors, people who we work with as partners. This being our first symposium as Western chapter of the Association of Obs and Gyn. We have very many people that we worked with, the donors. We thank you so much, Mayanja, Sajufam. I am told also CCare is around. Premium, the director of CCare is around? Is he around? I hope I am not wrong. We have Premium Medical Services, Crown Healthcare, Mankind Pharma, Maristops, Neocare, Trika is with us, Mbarara University of Science and Technology, Eurogyn, Divine Mercy Hospital. We have the Ministry of Health. We have Ajanta Pharma, Neocare I mentioned, Ruharo Mission Hospital. That's where I come from. As you can see here, we have very many sponsors. Chitagata, I saw the executive consultant around, Dr. Fiona. So many of them, we are glad that you joined us, and we are happy to work with you. This is the first symposium for Western chapter. With us for the Association of Obs and Gyn is our president. I would just like him to wave to you before we break off for tea. Professor Rogers Kajawangu. Please welcome you. That's my boss, and I'm the chair for the Western chapter of the Association of Obs and Gyn. We're glad to have you, and the next session is tea. We shall come here for the real gist of the matter. After break, we only have 20 minutes for tea, so I hope they will be served quick. Anyone to bless our tea? My immediate neighbor.
Good morning to you all. Let's humble ourselves and pray for the time we have been waiting for. Thank you, Jesus. Thank you, Lord, for the time we've spent here. Thank you for the journey mercies. For those who are still on the way coming, may you bring them safely. For that we are going to eat, we thank you for it. Continue to bless us and let it be so healthy to us. We have prayed and breathed. In the name of the Father, Son, and the Holy Spirit.
A table is set. Thank you so much. Those who have presentations, please make sure they have been loaded the email we gave you, because we don't want us to go back and forth.
established at MUST by the current speaker, myself. It's available on offer for midwives and everyone. Every time we have an AOGU function, this book goes on sale at half price. Ordinarily it is at 100,000 shillings, but for today, it's at 50,000 shillings. So you buy one and take two. You buy one at 50 and take one. But if you buy one at 100, the normal price, you take two. It is available in the corner there. Please support us. Thank you. 50,000 shillings, you can send it by mobile money, you can pay by cash. The rest, we can talk later. Thank you.
Thank you very much, Professor Mujenyi. So, members, our next session is about gynecology, and I'm told we're going to adjust the program a bit so that we have most of the presentations before lunch, and then the opening and then closure and other activities come later. So I want to request the other presenters to be loading their presentations onto Professor Mujenyi's computer for the interest of managing time. Where have my presenters gone at? Okay, Amos is here. Amos and Brenda are here. Yeah, so our session is about gynecological conditions we encounter in our practice, and we have colleagues that have done very interesting innovations to help us manage our patients better. So we're going to have 3 presentations. Dr. Amos, are you ready, or we? Just a minute. Okay, so we'll have the first presentation from Dr. Amos Muhumza, followed by Dr. Caxton, and Dr. Brenda in that order. We are going to have the presentations following the same guideline as we were using in the morning. You have 8 minutes presentation, but we are going to divide these 8 minutes into 5 you present. You save the other 3 for the Q&A at the end of the 3 presentations. So ensure that you try to manage time and strictly use the 5 minutes so that we spare some time for fruitful discussions. At this juncture, I want to welcome Dr. Amos Muhumuza. So the presenters will be given a signal of 2 minutes remaining during the presentation. Our timekeeper is right there. So as you engage the audience, also engage your timekeeper to ensure that you are managing time. Dr. Amos, please take the floor.
Okay, thank you. Good afternoon, our dear guests. Hope that everything is okay. My name is Dr. Director at KI Teaching Hospital. 2023, we embarked on a study to assess the prevalence of sexually transmitted to assess the prevalence of sexually transmitted infections and symptomatology among women seeking cervical cancer screening at Mbarara Regional Referral Hospital. And today we are glad to share our findings. I was the lead on this paper, and those are the affiliations of the different co-authors. Thank you. Next. So there are no conflict of interest to be declared, and this was funded by NIHS. And to note is that we know that sexually transmitted infections remain a major burden, health burden in the low and the middle income countries, causing illnesses, infections that result into infertility and death from these complications. Also, we note the burden that they put on mothers in terms of physical, emotional, and sexual influences. Common infections include human papillomavirus. We have HIV, chlamydia, syphilis, trichomonas, gonorrhea, among others. But importantly, we should note that 16% of all the cancer cases are attributed to infections that are related, and these cancers have been linked to sexually transmitted infection. We note the importance of human papillomavirus for cervical cancer, and we've seen that Trichomonas vaginalis, which result into cervical inflammation and lead to exposure of mothers to these infections that result into cervical cancers, among others. However, we know that there is limited data to do with sexually transmitted infection in this region. Next. So we set out to determine the prevalence of sexually transmitted infection and associated symptoms among women undergoing cervical cancer screening at Mbarara Regional Referral Hospital, and our study aimed to bridge this gap to know the magnitude of the problem and then which mother is most likely at risk. Yes, next. So it was a hospital-based cross-sectional study and done at the cervical cancer screening clinic on Mbarara Regional Referral Hospital. Our sample size was 746, and we assessed all mothers who had come in for cervical cancer screening under the AVEMA project. And off from mothers that underwent this screening for DNA and the HPV testing. What is important is that blood tests were done for syphilis and HIV testing, and this data was entered into REDCap and analysis was done at multivariate, and a p-value of less than 0.05 was considered to be statistically significant. So our findings, we see the prevalence of sexually transmitted infection at 51. What this informs, 1 in every 2 of the mothers that underwent cervical cancer screening infections. And of the this is because our mothers who came through the cervical cancer screening clinic mainly they come from the Thank you. This was followed by human papillomavirus, and then the others follow in that regard. Next. So at the analysis, we see that the education level, yes, education level was important, and those with no formal education actually were 3 times more likely to have sexually transmitted infections. We think this is because of the attribution of knowledge when it comes to education. Those who are highly educated tend to have knowledge on the preventive measures, but also early treatment, and so you find that the prevalence will be low in them. For mothers who reported partners who had other sexual partners, they were 2 times more likely to have sexually transmitted infection, and this is clearly explained because we note that there would be cross-infection from the partners. But also the partners tend to present asymptomatic and cross this infection to the mothers. Then for partners who were not sure whether their partners actually had other sexual partners, also were at risk almost twice the likelihood of getting sexually transmitted infections. Next. For commonly reported symptoms, we noted that abnormal vaginal discharge was among the common at 34.3%, then low abdominal pain, genital itching, dysuria, and dyspareunia. Those were the commonest. What this informs us is that overall, self-reported symptoms did not really show us the likelihood of having infection or no infection. And this tells us that we need to screen when we are taking this, when we are reviewing these mothers. Then relying on the syndromic treatment, which is the most common mode of approach for sexually transmitted infections in our setting, is not actually appropriate. So we need to do lab-confirmed tests and treat, because if you are doing syndromic treatment, then you are most likely to undertreat or overtreat these mothers. Then we think that integrating cervical cancer screening with STI screening is very important. Next. As we conclude, we note that the prevalence of sexually transmitted infections is high, and the reported symptoms surely poorly were overall poor predictors of having a sexually transmitted infection, and this leaves syndromic approach not an appropriate way of treating our patients. We recommend that there is offered risk assessment for every mother that comes in for cervical cancer screening, and then for health systems, we recommend to have low cost but rapid testing measures that are able to identify these sexually transmitted infections and are treated appropriately. Then in future, we think there should be studies to correlate the visibility of these point of care diagnostic algorithms and enforcing them. Yes, a point to take is that negative symptoms when screening these mothers did not actually inform the existence or not existence of an STI in a mother. Next, please. Yes, we want to acknowledge the participants who freely took part in this study and the staff of Mbarara Regional Referral Hospital, the AVMAP project, and the co-authors, and then the lab team which did the investigations. This work was done under the approval of MASTREC, and we had submission to the Uganda National Council for Higher Education. Thank you for science and technology.
Thank you very much, Dr. Amos. I'm sure you have used more than the time allocated to you, but I hope that doesn't impact on the next presenters. Members, will keep the questions for the Q&A session later. Dr. Caxton, please take the floor and
good afternoon, everyone. Sorry about that. Good afternoon once again. I'm called Caxton Kakama. I'm a gyne laparoscopic and endometriosis excision surgeon. I work with Henry Hospital and Roswell Hospital. So I'm going to take you through a case of deep infiltrating endometriosis that was involving the bladder and the bowel, and the patient had features of partial intestinal obstruction. So endometriosis affects over 10% of women in their reproductive age, and the common sites are uterus, ovaries, tubes, and less commonly it does involve the urinary tract, the diaphragm, the pericardium, and any other structure in the body. However, over 12% of these patients with endometriosis suffer from bowel endometriosis. And the most common part of the bowel that is infected is the rectal sigmoid, which contributes over 72%. And among these 72%, less than 1% can have intestinal obstruction. Over 4% of these women may also have urinary tract endometriosis, with the bladder contributing the highest percentage of up to 85%. So the aim of this case is to describe the laparoscopic surgical management approach. And this patient was a 33-year-old nulliparous, had dysmenorrhea for over 15 years, had chronic pelvic pain, had failure to conceive, had dysuria with occasional hematuria during the menses, and also had issues of constipation with a 4-day history of failure to pass stool. Upon staging and examination, had an Asian score of P3, O2/2, T33, F3, B2/2, and NST3. You can see the bowel nodule was about 3 centimeters. And when we did a transvaginal scan, it was about 5 centimeters. Length was 5 centimeters with a depth of 2 centimeters. And also had bladder involvement. Next slide. So these were the transvaginal findings on the scan. The first image shows a bladder nodule. Don't know if you can put some pointer to highlight it there. Yeah, so that is the bladder nodule. And then the other image is showing you, could you please go back? The other image is showing you the rectal nodule, which stretches all the way from there to there. And it is, that bowel was attached or adherent to the uterus at the level of the torus. So there was a torus nodule with a bowel nodule there included. Next slide. So this is the survey. When you put in a scope, this is what I was able to see. And from there, see there's a frozen pelvis with the kissing ovaries. Though both ovaries had endometriomas, but the right endometrioma was smaller than the left one. And you can see the whole pelvis is frozen and all the structures are adherent to each other due to the endometriosis. So, could you please go back? So this is an image of the bowel nodule. When we were doing resection of the nodule, you can see how big the nodule is. And this is the nodule that was causing a lot of dysuria and hematuria during the time when this patient was in her menses. So this is an image showing the distal portion of the rectum after resection. You can see an area, could you put a pointer? You can see an area where the nodule is, the other part there. You can see the difference. And with endometriosis, it mainly affects the serosa and the muscularis of the bowel. Less likely does it involve the submucosa. So you can see there is a very large nodule there that was causing those other bowel symptoms this patient had. So this is the histological diagnosis, and when we took the samples for histology. And most of these patients, maybe to note, can come see a person and they suspect maybe could be having rectal carcinoma and stuff, but in reality sometimes these mothers or patients have bowel endometriosis. So here it's an image showing you the time when we were doing resection, and the first image we were doing linear stapling of the distal portion of the rectum. And the other image is showing you when we had finished stapling, and now we are anastomosing both the distal and the proximal portions of the rectum. So in conclusion, despite bladder and bowel endometriosis being there, they can lead to severe complications like intestinal obstruction and kidney injury if left untreated. So early screening and diagnosis is always important. So it should be done for all women who have chronic pelvic pain and dysmenorrhea, so that they can be treated early before severe complications come up. So take-home message is do not normalize menstrual pain, because there could be something behind that pain that lady is suffering from. Next slide. All right, so let's all involve in this fight of endometriosis so that these young ladies can be saved. Thank you so much.
Thank you very much, Caxton. Brenda, please take the floor. And
Thank you. Good afternoon. Yeah, I'm Brenda Ainomjisha, and I'm representing a team that worked on this work about spatial access to cervical cancer care in Uganda, a geospatial mapping analysis. Next slide, please. I have no conflict of interest to declare. And like most of us know, cervical cancer is a preventable disease and treatable if diagnosed early, but it continues to be the leading cause of morbidity and mortality in Uganda. And among very many other factors that lead to this, disparities in access to the care, both prevention and treatment, is understated. And the geographical distribution of health facilities offering cervical cancer care and the accessibility is critical in improving cancer care. Next slide. Yeah, so we did a study where we mapped up health facilities in Ankole region along the cervical cancer treatment cascade from prevention to treatment. And we also evaluated the spatial access to these services for the female population in the region against the road networks and also the modes of transport that we commonly use. That's either walking, public transport, or driving. So it was a cross-sectional study, and we looked at the 12 districts and the one city that are in Ankole region, and we're mainly focusing on the female population in the region. We looked at all the health facilities in the region and also the road networks. And then we did the geospatial analysis, and where we estimated the female population coverage. If a female had to leave their home and go to a facility within 30 minutes or 60 or 120 minutes, either by walking or by driving. And this is what we found. For starters, in our region, we have about 3,608,000 females, and this makes 53.3% of the total population in Ankole region. And as you can see, the deep blue are the districts that are more densely populated. That's Ntungamo, Isinjiro, followed by Ibanda, and then they are closely followed by Bushenyi, Shema, and Mbarara City, and then the rest have a smaller population of females. Yeah, this is really showing the distribution of health facilities that offer primary prevention, which is the HPV vaccination, and then secondary, which is the screening. So the first map up there shows you the facilities that have the vaccines, which are many. About 50.4% of the facilities in the region actually had the vaccines. But then when we came down to those that are able to offer screening, the numbers came down to about 26.7%. And then those that are able to offer some form of treatment. And I need to say that this was collected in 2024. Things could have improved in the last 1 year, but only 10 facilities out of the 478 facilities in the region had reported some form of treatment for cervical cancer, whether it's a simple hysterectomy going upwards to the chemotherapy. So next slide is really showing access. The 3 maps this side are by walking, and the 3 maps on the other side are by driving. The dark gray shows access to vaccination, and then the lighter gray is to treatment. So you notice broadly that in the first 3 maps, even if people had up to 2 hours to access treatment, most of our region is going to remain untreated. And then when we move to the other side, if we have to access services by driving, even up to 2 hours, we still have places where they would not be able to access a treatment facility. Yeah, and this is really showing almost as maybe a simpler interpretation of the access. So the blue line goes for those that can access care within 30 minutes. The red line is those that can access care within 60 minutes, while the yellow line is for those that can access care in 2 hours. First graph is for walking, while the second graph is for driving. So you notice that if we're all able to drive to health facilities, maybe about 98% could be able to access treatment by driving. But when you come down to walking, in 2 hours, you're at about maybe 12%. And how do most of our patients come to the facilities? By walking. Next slide. Really, our conclusion is that there are substantial geographical inequalities in access to cervical cancer care in southwestern Uganda, and we think there is need for targeted expansion of the screening services, also strategic facility upgrades, so that some that are in a good location can have more services. You notice that we had districts that had a very high female population, but don't have a treatment site. And then also strengthen referral systems, because at times we don't know what happens to the cases that are identified in the different places, because we don't see those numbers translating into the numbers that are received at the treatment center. And also incorporating geospatial evidence into the cancer.
Okay, there's a gentleman behind there. The last person on this row. Any other person? Annabelle, okay. So we'll take those three. Yeah.
Thank you, Dr. Caxton.
When should we get worried for us to come to hospital and check whether we have endometriosis? Thank you.
Thank you very much, Dr. Annabelle.
Thank you so much. I'm Dr. Mchung's Hannibal Victor. I have two questions. One is going to Dr. Caxton, another one to Dr. Amos. Dr. Caxton, we are glad to have you in that area, and we are impressed by the work you are doing on endometriosis. I also acknowledge that in some settings, endometriosis is underdiagnosed, and quite often we treat it as recurrent PIDs or chronic PID. There is something that I wanted to know. If upon surgery, because basing on the theories of endometriosis, the pathophysiology of endometriosis, some seem to be recurring. So upon surgery, could there be prophylaxis against recurrences of those specialized cells outside where they are supposed to be? Thank you. Dr. Amos, thank you for informing us the burden of STI. Most of us have, thank you. All of us, most of us here, at one point or the other, must have had a partner. I wanted you to elaborate the partner involvement in the drive to curb this problem of having so many cases of STIs, and maybe if we can co-treat them, should we use the same drugs at the same time? So if you could help us understand the impact of partner involvement in reduction of this burden of STIs. Thank you so much.
Thank you very much, Anipo. In the interest of time, let's take two. Dr. Masembe.
Thank you so much.
And the lady next to you.
My colleague, friend, Dr. Caxton, I'm Dr. Masembe. I'm a fertility specialist. You excited us with this hidden but common condition. Actually, in infertility, it is double the prevalence of the general population. Unfortunately, not diagnosed in most of the patients. My question is, what do we have in our setting to improve diagnostics? Number two, you rightly said that the diagnosis now is largely through transvaginal ultrasound scanning. And this is a skill we've left to the radiologists. And in many settings, this skill must be taken back to the gynecologist who sees these patients. So where are we in helping our regular gynecologists to diagnose this condition ably? Thank you.
Thank you. I'm Prudence Noe, a DHO MCH and acting DHO of Buhweji District. Mine is not a question, but I want to appreciate Dr. Brenda and the team for coming to Buhweji, because by the time you came to Buhweji, our screening services were at around 6% in facilities, much as they had the knowledge but without the skill. And after your visit, we were able to roll out all the screening services, all our 14 health facilities. So we realized that it was a gap that required a few things to put together and help our mothers. We also included referral of the mothers that require treatment, because we do not treat, but we included the mothers who require treatment in our referral system using ambulance on the first visit. So whoever is identified is brought to Mbarara on a free cost, then subsequently they pay for themselves. Thank you so much.
Thank you very much, sister. One more question, if it is for Brenda, because I want her to use her time of questions and answers. If it is not there, I return the mic to Dr. Amos to answer the questions, then Caxton, and Brenda, if there are any final words. Thank you.
Thank you. Yes, thank you so much, Dr. Mchunguzi, for the question. I must first state that the study, like we've shown, was a cross-sectional study, and I will answer this outside the findings. But from the findings, mainly we note that the sexual partner was key, and having a sexual partner who was having other sexual mother at 2 times more likely to have these STIs. So that means we cannot oversee that factor. It is an important factor, and it was evidently associated with having an STI. So going back to the treatment, the guidelines are clear. We identified this mother with STIs, and you've done laboratory confirmed test, you're supposed to treat accordingly. That's what I might have to say, that treat this mother according to the STI, and ensure that they get the appropriate dose using the guidelines that are appropriate. And for the partner, because we note that symptoms are not direct predictors of who has an STI or not, you have to ensure that in the active period, usually guidelines put it at 60 days, that partner has to be treated, and treated also appropriately by using the appropriate treatment as per the guidelines. That's what I can say. So it is important that when you're treating this mother, so the partner that they have engaged with within the last 60 days gets treatment if you achieve complete recovery. Thank you.
Thank you very much. Please hand over to Caxton.
Thank you so much for the questions. I'll start with a question where the other alternative approaches to the treatment. So before we decide on the treatment approach, we have to consider some factors. For example, the severity of the symptoms, the age, the fertility desires of the patient. And so there are 2 treatment modalities, that is medical treatment and surgical treatment. So not every endometriosis case is managed surgically, but depends on those other factors. For this particular patient, she did require a surgical management approach because of her symptoms and fertility desires. However, for the medical approach, we use quite a number of molecules. For example, you can use the general H agonists like Luprodex or Luprolide acetate, or you can use the antagonists, elagolix. You can use the combined hormonal pills. You can use the injectables, for example, the Depo. So those are some of the medical agents that you can use during the management. For the management approach for endometriosis in frozen pelvis, we mainly use laparoscopy and we do retroperitoneal dissection during the surgery. So when is menstrual pain considered not to be normal? So the pain that makes you want to take a painkiller during the menses, or the pain that makes you to be uncomfortable. For example, you feel like you are unable to work, you are unable to walk because of that menstrual pain. Or whenever you think of menses that are coming, you're like, I'm going to die or something like that. So a pain that makes you not to be comfortable. You understand? Yeah. So it's always paramount for you to do the screening. As I said, if you are 10 ladies, if you are 100 ladies, 10 of you might be having endometriosis. About the recurrence prophylaxis, so we do combined approach during the surgical approach. So we do surgery, then after that we give you, we put you on hormonal treatment for about 3 months to reduce the risk of recurrence of the disease. So how to improve the diagnosis? It's a call, and again it's a request to all the gynecologists to at least try to learn how to diagnose endometriosis using a transvaginal ultrasound scan, which is very available in our settings. So in right hand, the scan can tell you that this patient has endometriosis, so this patient does not have endometriosis. And currently we do some trainings for radiographers and also for the gynecologists that are interested in learning how to diagnose endometriosis using a transvaginal ultrasound scan. Thank you.
Brenda, any?
Yeah, maybe some parting shots. I'm certainly glad about the feedback from the DHO Buhweju, and that's impactful, and I want to believe that it happened in even the other districts. Yeah, maybe to encourage the facilities, because I know there are so many doctors and midwives here from other facilities, is for you to report the work that you're doing, because we're getting reports from the biostat, but also visiting facilities, and some of you are doing work, but it doesn't translate into your monthly reports. So the ministry and the district doesn't know that you're doing anything along the cervical cancer care, yet you actually are. And maybe since we have someone from the ministry, is to let you know that a few of these facilities that are offering some form of treatment, it's largely because they have gynecologists who are working there. Some of them still employed as medical officers, but some of them as gynecologists. And there are only 3 districts out of the 13 in the Ankole region. So it's to advocate that if we could have gynecologists at all these levels, then certainly we would have more treatment happening and also better outcomes. And also finally, we know that radiotherapy is mainstay of curative treatment in advanced cancer, but we don't have a radiotherapy center in the region. And that's really our cry. If that can happen, then we would see these cases go down. Thank you.
Yeah, thank you very much, Tim, for the very impactful studies. I appreciate the testimonies, and I hope these continue to change lives. Ladies and gentlemen, join me to thank our presenters for the good work done. And I request you to take your seats, and we move into the next session. Dr. Emma, please come and take the floor and take us through the next group of presenters. Thank you very much. Apologies for where we've not managed the time very well and other technical glitches. Thank you.
Thank you very much, Dr. Nesmas, for this session. Ladies and gentlemen, good afternoon. Dr. Emmanuel Okurut, Head of Department, Obs and Gyn at Kampala International University. Very glad to lead this session and chair it now. It's going to be on maternal health. I want to take this very opportunity to rightfully welcome my team that will be doing the different abstract presentations. Let's welcome Dr. Patience Naiga. Let's come to take on the stage. Yes, you're welcome. Dr. Masembe Zalio, you're welcome. Let's also have Dr. Joel Kabanzaho join us on the team. Let's clap for them. They have excellent work. I personally want to listen to it again and again, and I hope that we'll take note of so much that they offer, and then from this also be able to inquire where we need to inquire. Yeah. Dear presenters, thank you for taking up the stage. We'll still have 8 minutes. That is the entire time that we have per presentation. So I request that maybe we can do a few 5 minutes to present the abstract, and then we can save some time for the discussion accordingly. So I request that we'll listen to all of them, and then thereafter we will have a time of Q&A. Thank you very much. Let me, I think Dr. Masembe, your presentation is already on. You can start. Thank you.
Thank you so much. Ladies and gentlemen, good afternoon. I'm Dr. Masembe Cesario. I'm a gynecologist, obstetrician, and I'm a fertility specialist, and also a minimally invasive surgeon. I work at New York Specialized Hospital and Fertility Center in Mbarara. I'm not going to talk about fertility now, but the outcomes of fertility in advanced age. Ladies and gentlemen, with the advent of advanced fertility treatments, we are increasingly seeing advanced aged mothers giving birth. And we are also seeing mothers delaying their conception up to old age for so many reasons. And now to the maternal health section, this comes with complications. So I did a study analyzing the adverse maternal outcomes associated with advanced age in mothers that were delivering at Kabare Regional Referral Hospital in southwestern Uganda. Next slide. As already said, these mothers who are defined as mothers aged 35 and above are traditionally known to be faced with complications during pregnancy and also delivery. And these include obstructed labor, antepartum hemorrhage, all the obstetric complications that you can mention. However, the prevalence of these complications are not well studied and characterized in our setting, and this is why we undertook the study. So the objective was to determine the prevalence of these adverse outcomes in advanced aged mothers and also the associated factors. So we did a simple cross-sectional study at Kabale Regional Referral Hospital on postnatal wards, and we were looking at mothers who are aged 35 and above who gave birth in the unit, and we interacted with them in the immediate postpartum period. And these were 427, okay, that met the criteria, and we did statistical analysis on our findings. So what were the main findings? Number one, the mothers who were advanced age giving birth in the time of our study were 16% of the total deliveries. This is a big percent. We cannot ignore it. Number two, the adverse outcome rate in this particular age group was 37.6%, we defined the adverse outcome as any complication that these mothers experienced. Some had one complication, others had more than one complication. And this was a big chunk of mothers experiencing adverse outcomes. And the commonest adverse events included operative delivery and obstructed labor. Maybe this is where we strictly must use a labor care guideline vis-a-vis other tools. And the associated factors included extremes of labor duration, whereby mothers who had precipitate labor and prolonged labor were more at the risk of getting an adverse event, and those who also had hypertension, either chronic or pregnancy-related hypertension. So this is a summary of the findings and the statistical analysis. Okay, next. So what do we make out of this simple study? It tells us that significantly mothers are giving birth at an advanced age. Okay. Number two, it tells us that these mothers have a proportionally higher risk of getting adverse events vis-a-vis young mothers. And we also specifically look at the risk factors that put these mothers at a higher risk, including hypertension, prolonged labor, precipitate labor. Next. So we recommend close monitoring of these mothers during pregnancy and also during delivery, especially those who show you prolonged labor and precipitate labor. You keep a closer eye on them if they are advanced age. Those who have hypertension, again, bring them so close to you during your care because they are at risk of bigger events. And being a cross-sectional, simple observational study, we think this forms a big background to bigger studies, longitudinal studies, to start analyzing these factors deeper. And I acknowledge my co-researchers, the assistants, and the mothers who participated in this study. Thank you so much.
Thank you very much, Dr. Masembe. You can hold on now. Let's appreciate him again as we welcome Dr. Patience to also pass her presentation. Welcome.
Good afternoon to you all.
Yes, good afternoon.
Through you, Chair, I want to inform you that I'm Sister Naiga Patience, a midwife, not a doctor. I
sincerely thank you. Thank you for...
So, once again, I'm Naiga Patience, a midwife working at Mbarara General Referral Hospital. I'm happy to present to you our research which was done at our hospital, and it is to do first office blood pressure reading, overestimate perinatal blood pressure. What do I mean here? When these mothers come for antenatal and we take the blood pressure once, does it make us diagnose them to be hypertensive or not? Next slide. Yeah, I have no conflict of interest. So hypertensive disorders of pregnancy are associated with severe maternal and perinatal morbidity and mortality at Mbarara Hospital. And the research which was done in 2022, it showed that 4 in every 10 women who are having hypertensive disorders are likely to remain hypertensive. In a clinical setting, the first recorded office blood pressure may influence triage and clinical decisions. So the repeated measurements are really recommended. Next. So to examine whether the first same VIST blood pressure reading differed from the second and the third reading across preconception, pregnancy, and postpartum. Here we are getting mothers preconceptive. We take their BPs at first, then we see them when they become pregnant, even at postpartum, most especially at 12 weeks. So the method, the setting was in Mbarara General Referral Hospital, which is in Mbarara City, and it was prospective cohort study, which was aiming at women who were planning to become pregnant, with the sample size of 240. We analyzed our data using the paired t-test to compare the average blood pressure. What was our findings? We found that complete triplet blood pressure reading were available for 240, which was pro-conception, then 109 first trimester, 91 second trimester, 89 third trimester, and 83 12 weeks. You may ask yourself, if we had 240 preconception, what happened? Of course, there are mothers who didn't become pregnant, there are mothers who aborted, there are mothers who didn't come back to us. So across all visits, the first systolic blood pressure and diastolic blood pressure reading were consistently higher than subsequent readings, meaning that systolic blood pressure declined by 2.9 to 5 millimeters of mercury from the first and the third reading. So what we were doing was to take the first blood pressure, the mother rests. In between the second and the third blood pressure taking, the mother would rest 3 minutes. Then we compare the two. So using the first reading alone, classified more women of having elevated blood pressure using the mean reading of 2 and 3. So here I mean that we were getting 41 mothers out of 240 versus 22 out of 240 preconception, meaning that if we took the first BP to these women as their real BP, we are going to have 41 mothers to be hypertensive. Yet when we repeated taking the BPs, we saw that we got 22. That is almost half of the number. That was preconception, and we saw 4 out of 108 versus 2 out of 108. So you can see that it was really important to repeat these blood pressures. Next. So whatever I was explaining, it is in this simple graph. So in conclusion, first same visit office blood pressure reading consistently overestimated systolic blood pressure and diastolic blood pressure compared to later readings across the perinatal period. So the repeated same setting blood pressure measurement with averaging other readings may reduce the first reading effect and improve the blood pressure classification. Next. Acknowledgement. I do acknowledge the doctors who were on our team, CAPREP team. And at this moment, I want to acknowledge Dr. Rugobe Henry, who are my mentors, and Dr. Agaba Corinis, and all the team which was on the ground to do the work, and also are trusting me so that I can present this work. Thanks so much.
From the hand clap, you can tell that this is a very impressive concept. Thank you very much, Sister Patience. This is really impressive. Let's welcome Joel to give us his abstract, which is the last one that we'll listen to in this session to conclude this maternal health section. After that, we'll have our question and answer session. So I hope that you're taking note of your questions, and then this will be concluded. You're welcome.
Good afternoon, ladies and gentlemen. Yeah, so Dr. Joel Kabanzaho, and I'm presenting the findings of my research, which was about incidence and risk factors for primary postpartum hemorrhage among women delivering vaginally at Mbarara Regional Referral Hospital. So I declare that I have no conflict of interest to disclose regarding this research. So about 27% of the maternal deaths worldwide are contributed by postpartum hemorrhage. And this is even worse with our low and middle income countries, where in Uganda it contributes about 45% of the maternal death. And in our region, in Ankoy region, it is even higher at 48.1%. At regional referral, according to the departmental report of 2024-2025, about 31.6% of the mothers had died due to postpartum hemorrhage. We also realized that there is still a lot of visual estimation of blood loss, and this has been proven to be inconsistent and somehow delays recognition and treatment. Also, the local magnitude and the risk profile among women delivering vaginally has not been well defined. That is why we conducted this study. And we also needed a reliable local evidence to guide prevention, preparedness, and timely response. Our main objective was to determine the incidence and risk factors for primary postpartum hemorrhage among women delivering vaginally at Mbarara General Referral Hospital. So we used the prospective cohort design where we did this study at the antenatal ward, labor suite, and postnatal ward at Mbarara General Referral Hospital. And our population, we enrolled mothers who were in latent labor and were above 26 weeks of amenorrhea, and those that we anticipated to deliver vaginally. We enrolled about 418 participants consecutively, and we analyzed using the modified Poisson regression and adjusted the risk ratios with a 95% confidence interval. We measured blood loss by objective. We used objective methods to measure, that's the volumetric and the gravimetric, where we use the calibrated drips to measure the blood loss, and also we use pre-weighed gauze pieces and pads to measure the amount of blood. So we enrolled 459, but of these 41 ended up going to theater, were delivered by emergency cesarean section. So we ended up with a sample size of 418. And of the 418, 70 of them were found to have postpartum hemorrhage, and that contributed about 16.7%. So primary postpartum hemorrhage affected approximately 1 in 6 women who were delivering vaginally at Mbarara General Referral Hospital. The independent risk factors that we found for the mothers that had low maternal education were 1.6 times more likely to get postpartum hemorrhage. Even those who got prolonged second stage of labor were 1.8 times more likely to get postpartum hemorrhage. And those mothers that delivered babies that were 4 kilograms and above were actually more at risk of getting postpartum hemorrhage. We realized that uterine atony was the most common cause, as other literature has stated. So women with fetal macrosomia had the greatest adjusted risk, and uterine atony was the commonest probable cause. Next. So the incidence was similar to some study that had been done earlier, which was also around 17.4%, and even other areas like in Ethiopia. And we also realized that objective blood loss measurement is likely to improve case detection compared to the visual estimation. So for prolonged second stage of labor, it could be that there is uterine fatigue and traumatic birth that is associated to it. And then for macrosomia, there is increased risk through uterine overdistension and birth trauma. And mothers who had low maternal education, this may reflect the reduced health literacy and delayed care-seeking behavior. Okay, so we also noted that using the objective blood loss measurement, prepare PPH, also to prepare PPH emergency kits and to intensify surveillance for women with prolonged second stage of labor and those you suspect to have fetal macrosomia. So early recognition and readiness are very central to preventing severe maternal outcomes. Our recommendation, we recommend that we standardize objective postpartum blood loss measurements and we maintain readily accessible postpartum emergency kits in our labor suits and also escalate surveillance for mothers that may have prolonged second stage of labor and those we suspect to have fetal macrosomia. So in conclusion, primary postpartum hemorrhage was common among women delivering vaginally at Mbarara Regional Referral Hospital, and low maternal education, prolonged second stage of labor, and fetal macrosomia were independent risk factors. Next. Yeah, so I want to acknowledge my supervisors when I was doing this work, the Department of Obstetrics and Gynecology, and Department of Maternal, Newborn and Child Health, which provided partial funding for this research, the research assistants and all the staff at the Mbarara Regional Referral Hospital, and we got our ethical approval from MASREC and also the Uganda National Council of Science and Technology. And then we also noted that we have no conflict of interest. Thank you so much.
Thank you so much, Dr. Joel, for that insightful presentation. We've listened to all of them. I know that we have some questions. You can shoot up your hand and then we'll reach out to you. Let me have a few more microphones. Thank you. Senior, let's start from you. Hope it is not about PPH.
No, it is about all of them. The presenters, can I remain seated, please?
Yes.
Thank you. Dr. Masembe, Nkulina. What do we have to look out for in mothers with advanced age during the neonatal period and labor? From textbook to practice. And you guys sitting up there, what is this thing called white coat effect? Why does it occur? And how can we overcome it? Naiga. Being called a doctor does not mean that you did MBCHB. I'm waiting to follow you up to do the PhD. You talked of measuring blood pressure once. I think that was during the first trimester and did not follow up into the other thing. What about if we measured the blood pressure 3 times during that first visit? Wouldn't it be, don't you think it would reflect more about the blood pressure than taking it once and then saying it is high or low? If you took the blood pressure after taking a history, asking her about her husband and the children, after you've done the abdominal examination, you take the blood pressure out, the pressure again. What about taking the blood pressure again? Madam, before you go for the drugs, can we take the blood pressure again? Could this help streamline out that problem? Hey, Dr. Kabanza. Nkwine. From textbook to practice. We know the causes of postpartum hemorrhage. Those things you talked about. We know how to manage them. We have trained people how to manage them. In your opinion, why is postpartum hemorrhage still happening?
Thank you. I know they have taken note. Let's hear from Dr. Hannibal.
Thank you so much once again. Dr. Masembe, I'm intrigued to be your associate in this fertility issue. And I'm looking forward to seeing you as a solution to this problem of advanced maternal age, especially in this era where Mr. Right is never seen. There has been a disproportionate increase. We know very well about 20 years ago, the population has increased. There is a disproportionate increase in as far as the sex is concerned. And this probably could be explaining why Mr. Right is never seen. And I look forward that you be the solution to couples to have a sex of the baby at a particular time they wish, so that you can have a balanced population. There is, I wanted to know whether you clearly delineated the complications in as far as the number of pregnancies is concerned. Were these complications more in the prime gravida or the multigravida at advanced maternal age? Thank you.
Thank you, Mr. Wright. Yes, please.
Thank you. My question goes, I'm Dr. David, I'm a gynecologist. My question goes to Dr. Masembe. What upper age limit would you recommend women conceive? Because these you are seeing women have money, they want to add more babies, others are delaying. But at what age upper limit will you not tell this woman, please don't conceive, your life is danger? And some examples of what you've seen, what medical condition you can give us of your experience when you can send a woman, please don't have a child. Thank you.
Thank you very much. Yes, Dr. Nesmas can come on.
Yes, and I'm Dr. Adam SHO in KIU. And I want to ask Dr. Masembe, based on your findings, should we consider all pregnancy mothers with advanced age as a high-risk pregnancy? Thank you.
Thank you. Let's hear from Maureen.
Thank you, Sister Naiga. I'm Maureen. I work from Ruhara Mission Hospital. Maybe as a midwife who is learning from you, I would want to know how you selected the time interval. And in this that we are living in, the high rate of preeclampsia and eclampsia, how you'd help this midwife who is alone in MCH, and maybe she has a line of 200 mothers. Which interval from this panel would you think really suits the midwife to say that the second BP would be normal for her or would still be adult for her compared to the first BP? Thank you.
Great. Thank you very much. Let's
Yes, thank you so much. I'm Dr. Arnold, Ruhara Mission Hospital. My question is to my brother, Dr. Joel. He mentioned something to do with measurement of blood volume by weighing the pads before, weighing the gauze before and after. I'm requesting for clarity about that. How would you go about that? Thank you.
Thank you for the question. Yes, please.
Yes, thank you, our presenters, Martin Tumukunde, Perinatal. My question goes to Dr. Masembe. That was such a beautiful study. I must applaud you for that. This is information that is very relevant, and as one of the few Gen Zs in the room, these are topics that keep running around on social media, and oftentimes the information is gotten from people that are not even medical doctors, and everyone has their opinion. So my question comes to specifically the study that you conducted. If I want to use this information, maybe when I'm in my consultation room giving advice to my patients, or when I'm just chatting on TikTok or Twitter, and I want to reference you in that conversation, how do I interpret this data? As you are doing the study, did you have a previous study in the similar setting or in the country that probably spoke about the prevalence of these adverse pregnancy outcomes in the general population? I have I've seen some of the adverse outcomes include cesarean sections, which are quite common. So am I right to tell my mother to be worried because of a prevalence of 37.6% without knowing if it could not be probably higher in the general population? I would love to know if you have a study in the setting, or probably there is a study in our setting as a country, Uganda, that looked at this, such that I can use this information probably better to advise people out there. Thank you.
Thank you very much. A question, I know it's noted, please.
Thank you very much. My name is Stella Pio. I'm a midwife working at Mbarara Regional Referral Hospital. To Joel, this is not actually a question, mine is a supplement. I participated in his study, and the study was so interesting. One of the things that I realized that is very important that most of us are not doing is the HB estimation. We realize that most of these mothers, we've been asking ourselves, when someone is giving you a report like they brought a referral, and maybe the mother ends up like dying, and then you follow the observations that the midwife is giving you. The midwife will tell you the mother did not bleed much. So we realize some of these mothers come when they're already anemic before, but we don't take interest in that. So I realized during that study that HB estimation for these mothers is really very important. Then another thing is having one midwife in the maternity. During this study, that's one of the things also we said for sure. If we are to follow up these mothers and then we manage or we prevent or we recognize PPH early, it means the midwife really needs to stand on the mother and takes her time on the mother. But you think of you're delivering 3 mothers and you're one, and you're running to the other and you're leaving this one. Or within 30 minutes, you finish delivering the mother, you tell the mother, please, postnatal. And in postnatal, maybe there's no one even attending to this mother. That's where mothers end up dying the other side. So I don't know in his report, I don't know whether his finding was basically for him to pass or to improve the life of our mothers by sending this report to some of the leaders or to ministry to emphasize that, please, midwives are needed. We need more. 1 more million midwives we need. Then on the use of the drapes that we use, thank you very much, Dr. Waswa Sarongo is here. The drapes that we used during his study was brought by Dr. Waswa from ministry. And after finishing that research, the ones that we had were very few. But using these drapes is really very important, and to Ministry of Health, we really need these drapes. I realize that the 500s we've been talking of, that estimated 500 meals. No, we have been talking of 500, yet it's something like 1,000 meals lost from these mothers. Because when you look at the drape, the 500 is far much below, and already saying that that one is enough to kill that mother. So if we continue using those receivers and the rest, they are not working out for us. So during that time, it's the reason you're hearing him saying we found very many mothers having PPH. We always report few. Mothers always end up with PPH if we are to really say we are estimating at 500 or 300, because we say 300 with other signs. So we need those drapes. We are requesting, Joel, please follow it up. Let those drapes be brought to us. They are very important, and HB estimation should be done. Thank you very much.
Thank you very much. I think these have been a number of matters raised, very, very pertinent. And Senior Salong, I think you are also in the loop. I might ask you to go in front shortly. Thank you very much. Let's listen to her, then we'll come to this gentleman. Maybe because of time, we'll limit to maybe 3 more questions, and then we'll hear the responses. Thank you.
Okay, thank you very much for that opportunity. And I want to thank the panelists. First of all, I want to thank Sister Patience. Thank you, the midwives in the house. Let's give Patience her flowers. Yes, yeah, having a midwife representing us is something to be proud of, okay? Let's give her flowers again.
We agreed she's the
Yes.
doctor.
Yeah, she represented us very well, and I appreciate. Yeah, my name is Pleasure. I'm a midwife, and I work with Mbarara General Referral Hospital, and also I'm a trainer for postpartum hemorrhage. That is why I was very attentive, and this study took my interest about the postpartum hemorrhage. Dr. Joel, you talked about the recommendation for, you said we are supposed to do objective measurement of blood loss, and that is true. That is what we are recommending. However, I'm worried about it's how we are going to imply it. How are we going to really intervene? How are we going to do it? Because these things have been recommended several times. Everyone comes, they do the study, and then it stops from there. Someone else is going to come, do the same study, and then it stops from there. How are we going to do it? How are we going to make sure that every healthcare provider, every midwife that conducts a delivery is doing objective measurement of blood loss? Because the study you did, when you completed, the drip stopped. I no longer see anyone measuring blood loss. That is the truth. So what are we going to do? In your recommendations, in your study, what plans did you have to sustain your project to make sure that everyone is actually measuring blood loss? Thank you.
Thank you very much, Pleasure. Let's hear from Dr. Rumba.
Thank you very much. I'm Charles Irumba. Yes, the panelists, thank you, and Joel to you. I saw you did your study in 2025, December. Emotive was already out. There are some modifications in the definition of PPH, how to diagnose. I see you zeroed on 500 mils. Didn't you? Some other PPH patients would have enriched your study. But also, you know, it is an interesting topic. It takes our mothers. Did you think about the emotive perspectives and how they do it? And maybe to answer sister, I have heard several from the PPH subcommittee that they are advocating to have that drip into the essential, it's called what? Essential medicines is something that is supplied by NMS. So I'm not sure how fast it will be, but probably if we advocate, we might receive. Thank you.
Thank you very much, Dr. Rumba. Let's have just one more.
Good afternoon, everyone. My name is Nisi
Okay, and one more. Yes, let's please, just go on.
Yes, my name is Dr. Nisi Marecha. I'm a medical officer. My question is to Dr. Masembe. So the complications of advanced age mothers. So the complications that you gave us, are they limited to early advanced age mothers, if there is something like early advanced and late advanced? So was it just a scope of all advanced age mothers, or just maybe early advanced and late advanced? I think that couples with the earlier asked question of, is there a limit to telling a mother, you know what, Chimala, stop giving birth? And then my other question is about the fetal complications. So one thing known for advanced age mothers is the complications of the child, maybe fetal anomalies, etc. Did the study stretch to look at the babies? Because that's something that advanced mothers are actually worried about. So did it stretch? And if it did stretch, what are some of the complications that we should look out to advise the mothers to have a stop or a limit to giving birth? Thank you very much to all the presenters.
Thank you so much. Pal, you can say in a few seconds. And then
thank you so much, the moderator. My name is Kwichiriza Pal Agatha, and I wanted to inform the team in the room that JMS has calibrated drips. And I know we have private sectors in this room. Kindly utilize the calibrated drips from the JMS, and then also to inform us that Ankole region has PPH national trainers, so we can utilize them and ensure that we improve our service delivery. Thank you so much.
Thank you very much. There are a number of burning questions, and time is also running with us. Let me give my grace to only 2 people, but in a very few seconds. Thank you.
Thank you so much. My name is Edward, and uncommonly, for me, I'm a biomedical engineer, although I'm interested so much in this. So recently, I'm working with a company that produces mama kits, but Vital Care Connect, I hope you have heard of it before. So we have been trying out to see whether we can include the calibrated drip in our mama kit. But still, we had a discussion internally to check it out. The recent supplier that we had in town, I come from Kampala, so the recent supplier that we had comes from Bweyogerere and was selling the drip at 20,000. So we imagine that if we could involve this, how much will the mama kit be? So I think this is the better discussion that you should have. I think I'm in the right place right now for you to discuss of how best we can have this and then include in the kit, and the kit, its price doesn't increase because you people represent those people, the mothers. As we were discussing, I was saying that I told the team, let's include the drip, but they told us that let's discuss with the people in Obs and Gyne that are responsible for this. So just in case able to give us your idea, I'll be around. You can take the contact, or you can reach out to Vital Care Connect and have your idea there, and we'll see whether we can include it in our mama kits. Thank you so much.
Thank you very much. Thank you. Yes, just lastly, please.
Okay, thank you so much. Our dear presenters, we appreciate. Rachel Msimenta, a passionate midwife, and I work with Mitoma General Hospital, and a founder of Mama Infant Care Uganda. This is a company, or you can call it a social enterprise, that is here to support mothers in their journey of pregnancy, labor, and after childbirth. So my question goes to Dr. Masembe. From your research, I heard that some of these mothers delivered normally, and then others delivered by C-section. So I would like to understand the mode of delivery that you recommend for these mothers, because like if I get a prime gravida who is 40 years, should I let her try labor, or we can opt for elective cesarean section? Thank you so much.
Thank you very much, Ms. Menta. At this opportune time, I want to invite my presenters to answer the questions. I know you've received quite a lot, but let's try to maximize the response in a minimized time. Thank you very much. Let me start with Dr. Masembe.
Okay, thanks so much. I think to have received more questions. Maybe this is an interesting study that I did. I will start with the last question from my dear sister from Mitoma Hospital about the recommended mode of delivery in advanced aged mothers. The mode is going to purely be determined by obstetric factors. Age alone is not an indication for a C-section or not. Okay? Thank you. The other question was from my teacher and my mentor, Dr. Waswa Salongo, about what closely look out for in these mothers during their antenatal time and delivery. Again, I will say they have to undergo the routine, traditional medical way of monitoring antenatal mothers. At each visit, you have to do a comprehensive history taking, and in this history, you have to focus on the risk factors. You have to do a full review of their systems, look out for any medical risk factors, especially cardiovascular disease, which is heightened with advanced age. In their history, still try to look out for any chronic conditions, especially hypertension. My study revealed that hypertension was a risk factor in these women in terms of poor outcomes. So do the routine, comprehensive assessment, but closely look out for risk factors. In terms of labor monitoring, my study revealed that prolonged labor and precipitate labor were risk factors to other big adverse events. So as you routinely do the labor monitoring, pay close attention to the labor progress and also the labor duration and act accordingly. Thank you. My young brother, Dr. Hannibal, asked about sex selection in terms of population balancing. We still have a lot of ethical and legal issues regarding sex selection, and in most countries, including our country, sex selection is only indicated for medical reasons, not for social reasons of sex balancing. And if I'm to do sex selection, it should be medically indicated. Maybe I'm trying to overcome a sex-linked genetic disorder. And I have to select embryos and do biopsies, do genetic testing on them, and those that carry the trait of the condition, I will not give them to the mother. But if I'm not in that line, then sex selection is not yet allowed. And we know sex selection is part of natural selection. If you see a certain couple producing kids of a certain sex, there is a natural selection going on. Maybe the other sex bears a genetic trait that doesn't help them survive. Okay, that's what I can say about that. You asked if parity was a factor in the adverse events. We analyzed for this, and parity was not a risk factor for adverse events in mothers. You asked about the upper age limit for mothers, above which we discourage conception. Globally, it is at 55, but we also base on the medical, physical status of the mother. We can discourage the mother based on their assessment medically. Otherwise, in terms of age, currently in our country and globally, we are not doing assisted reproduction in women above 55 years of age. Another question was, should we link advanced age to the question was, is advanced age a risk factor? Should we classify such mothers as high-risk mothers? The answer is loudly yes. Whenever you're dealing with mothers of advanced age, just know you're dealing with high-risk mothers, just like teenage pregnancies. C-section rate. A question arose to compare our C-section rate in this age group vis-a-vis the general population. We don't have so many studies, but a recent study was done in Eastern Uganda by Komuhanji, and she looked at the prevalence of C-section in the reproductive age range from the age of 18 up to 49, and her study saw a rate of 17%. When we did specifically C-section rate in the age group that I studied, it was 23%. This is high. We know the recommended WHO C-section rate should be between 10 to 15%. And the recent analysis of C-section rate shows that actually it is as low as 6 to 7, but we have discrepancies depending on the unit we are dealing with. If we are dealing with a referral unit like Mbarara, where you have all units referring, it can even go above 40. Okay? Okay, analysis per age. Dr. Rachel asked if these advanced aged mothers had risks categorized per age group. We did this and we didn't find age group as a risk factor. Okay, we looked at those between 35 and 40, then 40 to 45 and above 45, and all of them were equally affected by the risks that we studied. You also asked if we went ahead to see the outcomes in the mothers. Yes, we did, and we published a different paper. Even this very paper is published, you can find it. And we also found babies born to advanced aged mothers are faced with neonatal outcomes that are poorer than the other age groups. So our pediatricians also have work to do in these mothers. And actually, in my practice, when I'm delivering such mothers, I have a pediatric arrangement for neonatal care. Yes, I think yes. And another question, I think I'm done. The last question was the mode of delivery, which I explained. It has to be purely based on obstetric factors, not age per se. Thank you so much.
Thank you very much, Dr. Masembe. Yes, please, Joel, go on.
Yeah, thank you. Let me also go ahead to answer my questions. The first one was why postpartum hemorrhage still happens or is still a burden to us. And the truth is that these risk factors for primary postpartum hemorrhage are still there. Multiple pregnancies, fetal macrosomia, all these are still there. And maybe what is more important is why is it still killing our mothers, maybe? Yes, happening, it will happen because the risk factors are there. But why is it still actually, yet it is actually a preventable cause of death? And the answer is that all of us have a role to play in this. We all have to pay close attention to these mothers as we conduct deliveries to make sure we do objective measurement. And in case we detect this early, we should be able to intervene as early as possible so that we prevent maternal death. Then the second question was to clarify on the gravimetric methods that are used in this study. He said that we had pre-weighed pads. Okay, we had a weighing scale where we weighed our pads before giving them to the mothers. Because in labor suit for the first 1 hour following delivery, we are able to get all that blood through a calibrated drip and would actually look at the volume. But then they could not stay in labor suit. They had to go to postnatal. That is where now we gave them a pad that we had weighed. And then we reweighed after it was full or after every 4 hours. We collected them. We reweighed and then we converted to meals as 1 gram equaling to 1 meal of blood. And then we got the total blood loss of these mothers. And then some midwives were concerned about the objective measurement, the sustainability. I'm glad that this question has already been answered. I think the Ministry of Health and other partners are already thinking about it. And like I said, very soon maybe you'll find every mama kit having these drips. Now our work will be to train the midwives on how to use these drips and how to detect postpartum hemorrhage early and then intervene in time before our mothers get adverse outcomes. And then there is someone who asked me that I used PPH as 500 mils, that I could have missed these other patients. So the truth is when we are doing this study, because we had a calibrated drip, there are other parameters we are taking, like she said, we are doing HB for these mothers, and we are also monitoring these mothers, doing the blood pressures and also monitoring them. We noted that in this study, we didn't have any mother who had blood loss less than 500 mils and had symptoms of hypovolemia. Because we also had their HBs. Actually, the mean HB was around 10.4. So most of our mothers were not that anemic that after losing 300 mils, they could actually get these symptoms. But they are there. I'm not saying that they are not there, but in our study, we actually realized this did not happen. I think that was it. Thank you so much.
Yeah. Thank you very much. Before I think we can listen to Sister Naiga. Thank you. Let's appreciate her again. Pleasure said she's representing all the midwives in the place. But she's not only representing the midwives, she's also representing all the doctors in the house. So let's appreciate and welcome her to say, respond to this. Thank you.
Thank you. If I can briefly answer questions. One was from Dr. Wasa Sarungo. His worry was, how were we taking this blood pressure? What if we took this blood pressure after maybe a period of time, the mother has gone to pick drugs, and again we take these BPs? So if we can see, as we saw 240 participants, this mother would come in, she rests for about 5 minutes, we take the first blood pressure. And throughout, we did this preconception, pregnancy, and specifically in pregnancy, we are seeing in first trimester, second trimester, third trimester. It consistently remained high in all those trimesters. So the mother would come, rest for 5 minutes, we take the first blood pressure. In between the second to third, the mother would have rested for 3 minutes in between. So that is a total of 11 minutes, but still throughout seeing of this mother, the BPs remained high. Another question was from sister from Mbarara. Because that's, you are seeing the rate of these mothers are very many compared to the midwives who are working on them. My first advice to all of us is never, never forge a blood pressure. The day you forge a blood pressure, you've just consider yourself you've killed the mother. At least we should try and do the quality care, and we take the blood pressure of these mothers. Yes, I know there are very many. That's why they are advocating for 1 more million midwives so that we can advocate this. That's simply how I can reply those questions. If maybe you need more clarification and maybe it is not clear about your answer, I can refer that to Dr. Rugobe Henry. Thank you.
Thank you very much, Senega. Let me, before we close the session, I want to hope that you still have your books where to write. I want to give Professor Musa to ask one thing. Thank you.
Yes, thank you, John Chair. Let me stand up even. This goes to my student, Masembe, because I didn't want him to leave before asking this question. And I've always wanted to ask him. And today is the chance I have gotten. One, you said, what is your success rate? What's your success rate? IVF, yes. 40%. So that means for every 10, 6 will fail. Not so? For every 10, 6 will fail. From my little understanding, I know that's not an expensive, that's not a cheap procedure. The last I heard of it is that the minimum should be like, you should have some 10 million in a bank somewhere. Is it 17, 20? 20 million for one side. So my question is, do you have, this is from a medical ethics point of view, not economics point of view. Do you have any plan or whatever for, I'm not saying a full refund, a percentage refund to the failures, to those 6 who fail? I know my student Mutumba there drives a COV 20 million things. So he says, you know what? I've put my car there, 20 million, I've given it to Masembe. I want the baby. Things fail. One cycle, 20 million. So do you give Mutumba? Probably, let me refund Mutumba 10. Oh, you say, Mutumba, we have failed, but the next cycles are going to be free of charge until you conceive. So, Mutumba, I mean in Masembe, tell us.
Thank you so much for this not an easy question. Yeah, your feelings are exactly our feelings when we are treating these patients. Unfortunately, it's not a cheap process. The drugs used are not cheap. The reagents used in the labs are not cheap. And this is purely met by the patients. So some feelings at one point we get like if we were the people to meet this, but it's not easy. So almost 95% of the 20 million is spent on the utilities used. So the question of the positive and the negative at the end of the cycle becomes a difficult question to the client and also to the doctor. Because the 20 million you paid actually at the end of the cycle is not kept anywhere but by the supplier of the utilities that were used. So what do? We sometimes do concessions, we do discounts here and there, talk to the suppliers to discount things. And periodically, we actually invite these patients who fail to come back for repeat cycles at generous discounts. And this is supported by the suppliers of these drugs that we use. And patients get good counseling from the start that IVF is only at that percent. Actually, in some settings, it's only 25%. I have had it sometimes 60%, 100%, but it's difficult to determine. And with this counseling the patient gets, they are not ready for just one cycle, a minimum of 3 cycles. And they have to plan for these cycles. Okay, thank you so much.
Thank you very much. I think this concludes the session on maternal health. I hope that we've had a very wonderful deliberation and we've understood so much. I want also to echo that there are 2 abstracts that should have been presented in this session. One of them is on a very insightful study on the outcomes of mothers that have been managed in ICU. Quite a number of women were looked at and the outcomes are well documented. Some of the factors that improve survival and some that lead to death are all well recorded there. So I encourage us to look at it, that abstract. Then there is another one on those rhesus negative mothers. How common is rhesus isoimmunization in these women? This is another one that should have been presented, but I know that we can take up these books and be able to find it in the section of the abstracts. I want to appreciate the presenters and I want to request that we can take our seats. Let's appreciate them together. Thank you very much, everyone. And at this moment in time, allow me to hand over back to Dr. Beckson to continue with the rest. Thank you.
Let's applaud Dr. Okrut, Emma, for chairing the session well. Thank you so much. I think I'm the one standing between you and your lunch. Yeah, lunch is almost ready. Some people have just eaten, but we still have to eat it. You'll understand why me and Dr. Okrut are gaining a lot of weight today because we eat a lot in the hotels where we spend our days. Dr. Okrut has started is the head of department for Obs and Gyn, KIU. He has started being a politician also because he gave a lot of time to these people. But we manage. He used to be so scientific, I was more political than scientific compared to him. We would like to recognize most of you who are here before we get out for lunch. I already showed you our chair for this scientific conference, Professor Kayondo, who is here seated with us. I showed you the president of the Association of Obstetricians and Gynecologists of Uganda, who is hosting us tonight. Professor Rogers Kajabwangu is also here. I would like to also note to you that the chief guest for this function is already here with us, the Commissioner for Clinical Services, Dr. Ronnie Wahatunjire, ably represented by Dr. Grace. Kindly wave to us so that people can easily interact with you outside when we move. Thank you so much for coming, and we appreciate. Next to her is a senior consultant of Obstetricians that we are listening to from here, Dr. Wasa Salongo, and he says he's the advanced skilled birth attendant. Some of us are still about to get advanced, but we have to be skilled until you say 1,000 midwives, 1 million midwives, 1 million. Isn't that too many? You want jobs or you want to take care of women? Okay, we shall make sure that 1 million midwives are added into this word. Would like to recognize most of you that have already come. I understand the president for AOGU is here with some of his executives. I'd like to recognize Dr. Irumba Charles. Kindly stand up, people can see you from far. Dr. Irumba is an executive of the Association of Obs and Gyn of Uganda. And later on, afternoon, together with a few other colleagues, they will give a panel discussion on the topic that is before us. Together with we shall have a keynote speech in the afternoon, delivered by the Deputy Vice Chancellor of Mbarara University of Science and Technology, who is just about to enter in. So the bigger session is just immediately after lunch. We have also some deans in the house. We shall have the Dean for Faculty of Medicine, also doing a panel discussion, Faculty of Medicine, Mbarara University. We have, I think, the Dean for Bustema, Faculty of Medicine. Soroti, yeah, Soroti University. Soroti, where is he seated? Yeah, thank you so much for coming, Prof. I think some people didn't know they were seated with big shots. Yeah? So actually, if I was to introduce you people, you know that today it's a big thing. Thanks, Prof, for being with us, Dean. I'll be joined with your colleagues in the afternoon very soon. We have also the chair for Uganda Medical Association, Ankole chapter, Dr. Elias, kindly stand up for recognition. Now I'm doing the politics. I'm not doing the politics, but that's our chair for Uganda Medical Association. We work closely with them. I would like to recognize a few hospitals that you know the people that are here with them. Professor Kayondo from Mbarara University and the Mbarara Regional Referral is here in case you need anything, you'll talk to him. They also are part of the sponsors for this symposium. He's with a big team here. Ruharo Mission Hospital also has a big team here. Dr. Edwin Semambo comes from Ruharo Mission Hospital and is the treasurer for this symposium. He's the man, the other fat man behind there. People have money usually look like that. Yes, and I also work in Ruharo Mission Hospital as the medical director. Yeah, just like the AOGU president, like the professor. We are aspiring anyway, we're learning how to have money. We have Divine Mercy Hospital. I think the director is around. Professor Mujenyi, kindly wave to us. Stand up for recognition. You already presented. They are part of the sponsors. And he came with a big team. I may not make them stand up, but I know there are very many. Like, since I didn't make others stand up. Okay, you stand up just for recognition, our colleagues. There are several of you. Why did you sit one side? Thank you so much. The ones for Haru can as well stand up. Very many of you. We even have Bazungu. Mbarara University of Science and Technology and Mbarara Regional Referral, kindly shoot up. Get up. Oh! I think you are the winners. Tonight we accept that defeat, Professor Kayondo. Hands down. We already introduced KIU. I think the dean, is the dean around yet? He might be hiding. The head of department for Obs and Gyn is here. Kindly stand up, Dr. Cruz, together with the KIU team. Oh, wow. Wow. Thank you so much. Thank you for representing. There are very many in the house, mostly the doctors. I think we also have Neocare Fertility Centers who, Neocare Fertility, the director is around. Yeah, I said behind there, Professor attacked from the blue corner.
that the money has to get what it was paid for. But those are chances. Reproductive health is just like that. We also have the executive consultant for Chitagata Hospital. I think you had already seen her. Kindly stand up so that they know AOGU is blessed. She's there, Dr. Fiona. She has a team. They are the team from Chitagata. They are about to eat me up. Kindly stand up. There are several of them actually. I know they are scattered, but we had recognized you. We know you are here. We have Mayanja Memorial Hospital. Mayanja Memorial, yeah. Doctor is here. Yes, the director, medical superintendent, director, everything. Together with your team, thank you so much. C-Care, I think hospitals. Yeah, we have one of the directors around. Thank you so much for being with us today. Did we get someone from Kabale? Kabale team? Oh, we have a lecturer from Kabale University, and she was one of the presenters. We understand your residents didn't come. They have to serve this world. Eh? We also have, I think most of our sponsors had been mentioned. We will recognize you again. Ibanda. Oh my God. We are going to also, Ibanda Hospital and Ibanda Region as well. Kindly stand up and recognize you. At this point, I recognize actually most of the seniors. We have not done in the capacities, but some people sponsored a little thing also. That's why I might have forgotten some colleagues. But I would like to request at this moment, we shall have a photo shoot later after the important sessions that are coming. At this point, can we have the OBS and GAIN colleagues for Professor to see that he has his constituents around? I've seen many of you. OBS and GAIN specialists, consultants, senior consultants, kindly put the hand up. Wow, very good representation in the region. I hope the women are safe wherever they are because all of you are gathered here in the region. And we understand also that there are those OBS and GAIN in training, the residents, the master's colleagues. Kindly put up your hand. You might be the majority here today. Oh, wow. Thank you so much for representing. You're not few. We have some medical officers. Yes. Yeah, there are many. Kindly shoot up. The hand only. Yeah. Thank you so much for coming. And fellows for you. Those doing fellowships. I think they don't fall in the category of the other side. Let's see those doing fellowships. Yeah. I had seen some of them. We even have those who are already fellowship qualified, but those are super specialists. We have majority super specialists. They want to, Brenda, why are you hiding? Thank you so much for. Thank you so much, Doctor, and your team. We have the other people that are qualified to manage women, the specialists, midwives. Yeah, you stand up, kindly stand up. Kindly stand up for recognition, the midwives. Midwives. Wow. The camera has seen. Stand up, colleagues, stand up. Let us see all of you, because we want to, if I was at their church, we would say they'll reach out to you and welcome you with a hug. Our waitress, are they waitresses? Our ushers will reach out to you and welcome you the way we welcome people at AOGU. The president will explain to you later. We have associates in OBS and GAIN. So you are supposed to be members, and we are receiving the membership. We'll explain to you the fees. So the sponsors, once again, Mega Healthcare. Those are the people who bring Ferroton. Yeah, Mega, I think those are the people who bring Ferroton. We have Mega, We Care. You might see their brand somewhere. Kindly support. We have Mankind. Those people are here with us today. We have Troika. I think those ones are the NASO B12, those other things that you spray in the nose for iron. Huh? And Zaika, yes, and Zaika. We have Maristops. Maristops, thanks for being there. Those are the Misoclear people. And something like that. Premium Medical Services Limited, thanks for being there. And I think I would mention the health facilities. Via Health, they are also here today. They are the ones who bring the other, who trust things. If you want to get trust, you just, those other things. And Pronto and all other brands. Sagifam is here. We have Crown. They have, those people bring equipment and equipment of different kind. You reach their table, and Ajanta and several other sponsors that are here with us. If I've not mentioned you, kindly forgive me, but we recognize your presence here and thank you so much for the support. Next is our lunch, and the lunch is ready. We shall take it so quick so that we come and do the sessions that are more about the topic as we come to conclusion. I trust that it is going to be yummy. We shall give coupons as we get out, and so we request that this table with the chief guest will work and get a coupon at the reception with Dr. Edwin and the team who are responsible for welfare. And then the specialists of Zandgain will follow Professor and his team. And then all of us will follow. Lunch is just in the opposite room. Let us pray. Heavenly Father, we thank you for this afternoon. And we pray that you bless the lunch that's before us. Also, continue to provide for those who do not have. In Jesus' name we pray. Amen. Enjoy your lunch. Thank you. Kindly, let's go and dine. I understand we have some intern doctors here as well, right? A hand up, a hand up. The intern doctors. Yeah, I'm seeing several of them, some from rural and other places. We have
Excuse me. Protocol observed. Ladies and gentlemen, good afternoon. My name is Patience Shemelire. I'm an intern doctor at Mbarara General Referral. I'm here to invite us for an Western Uganda all interns. Those are intern doctors, pharmacists, nurses, and midwives event happening on 1st August at Dreamhood. Present, I had directors, hospital directors. If you're interns, please, even the hospital cover, Tagata, if they reach out to you to come for the event, please permit them to come. Potential partners, Professor Mjeni has already partnered with us, a very huge package. So if you have a private healthcare facility, pharmaceutical companies, please you're invited to support us. Thank you so much. No. No, we're celebrating end of internship. Thank you.
thank you. Kindly join in. The specialists, kindly, let's have our lunch. The obs and gyne specialists. Let's follow quickly, and all of us should join the line so that we serve quick and we get back here and do real maternal business. Thank you. Enjoy your line.
I think we are all back from lunch. Let's come back to the conference. Attention, please. It's a good sign that people can still talk after eating. So otherwise it would have been, the normal is the opposite, to sleep. But since they are talking, it means we are doing very well. So we are going to the next session, which is a very important session for this conference, which is the official opening. And you know, we have done it the Ankole way, where people do the function after eating. Not from Central where we come from, where you eat after the function. So let's have all members in. In this session, we are going to have the official opening. We shall have addresses from the chair of this conference. We shall have an address from the president of AOGU Western chapter, who is really our main host here. Then we shall have an address from our president, of our national president. You know, the last national president from Western Uganda was Dr. Wasa Salong in 2007, 2008. So, Professor Kajabang, you have made history after how many years? 18 years of being the next president whose state house is in Mbarara after Dr. Was. So thank you. So we shall have from the president, national president, who will invite our keynote speaker, who is none other than the Deputy Vice Chancellor Academic Affairs of Mbarara University of Science and Technology. And AOGU, please, as I think this is also history, that we are having a member of our association being the second, in fact, we call it the first deputy vice chancellor of the second public university, in this country, who is a member of the Association of Obstetricians and Gynecologists of Uganda. So please, you have never congratulated him, so I beg you to stand up and congratulate him as an association. Thank you so much. And our keynote speaker, after giving us the address, we shall have the address from the Commissioner, Clinical Services. Some of you don't know that our association still is one of the privileged associations which belongs to two departments in the Ministry of Health. We fall in the clinical services, and we fall our mother, which is reproductive health. So we are privileged to have representative, we are privileged to have the Commissioner, Clinical Services, represented by none other than, we're also very lucky as Mbarara University trainers to have a Commissioner, Clinical, who is our daughter. And you'll see her when her time comes. Thank you. So that's the program we are going to have. And as the President Western said that everything bad is on me and everything good is on you, I am here as the chair of this conference to welcome you. First of all, those who don't know me, I'm Associate Professor Musa Kayondo. I'm the head of Department of Obstetrics and Gynecology at Mbarara University and Mbarara Regional Referral Hospital. And I head the National Urogynecology and Female Reproductive Pelvic Floor Reconstructive Surgery Program, which has a fellowship, the first of its kind in East Africa here, based at Mbarara University. Yes, my residents, I can see you clap harder. So I want to, first of all, observe protocol. Commissioner Clinical, Deputy Vice Chancellor Academic Affairs, Mbarara University, AOGU President, the deans of the different faculties of medicine in the universities present here, KIU, Mbarara University, Kabale, any other? Soroti, our super specialists and specialists, stroke trainers, our residents in all years, even those who have just finished. Our midwives from all institutions in our area of our catchment area, AOGU Western. As the president will tell you of Western, he will describe that area very well. And we are glad to have you all here. All our sponsors, as mentioned earlier. Ladies and gentlemen, I want to officially welcome you to this conference. By first of all thanking you. When I walked into this hall, I was really delighted that we can have this hall filled up on our first and inaugural conference for Western Uganda. I want to thank the organizing committee, and please come forward. Dr. Semambo and all the organizing committee, please come forward such that people can see you and recognize the work we have done for the last 3 or 4 months. Hey, you know these days they are no longer called medical superintendents. They are called senior executive consultants. And I'm glad we will have one here as part of the organizing committee. So I want to thank this team, but let me give each of them 5 seconds to tell us exactly their position on the organizing committee.
Thank you, Prof. Kayendo. Professor Mjenyi. I've been working as the Chief Resource Mobilizer. I headed the finance team, and we have done so well. Our partners, we are inviting you for the next one. This one is done. Thank you.
Thank you, Chair, Professor. My name is Dr. Bekson Tayoba, and I have been the Vice Chairperson for this committee. I am also the representative on the AOGU Council, and I've also been the food soldier for the committee. Thank you.
Thank you very much, Chair. Semambo Geoffrey is my name. I am, or I have been, the treasurer for the organization of this symposium. Thank you.
Yes, thank you very much. Livanti Waijuka. I led the team, the scientific committee team. I know Dr. Byamukama is not here, but he contributed immensely as well on this committee. Thank you.
Dr. Masembe Cesario. He acted as a resource and also the attendance mobilizer and also a funder and publicity. Thank you.
Thank you very much. My name is Hilary Tudiahebwa, and on the committee I was part of the mobilizing and the welfare committee as a member. I work at KI Teaching Hospital. Currently I'm at Fort Portal Regional Referral Hospital site. Thank you.
Thank you very much. Once again, Dr. Manuel Okurut. I was part of publicity. Thank you.
My name is Dr. Simwe Fiona. I was and I am the General Secretary of AOGU Western Chapter. My role was to write, because I'm the one who's good at English, to take minutes, and also the executive consultant of Stagata Hospital. I was also a funder to some level.
Yes, good afternoon. I'm Brenda Inomcha. I was in charge of welfare. I hope you're well.
Yeah, so Onesimus Ahabwe Magezi is my name. I work in Kabale Regional Referral Hospital and as a member of the scientific committee. Thank you for coming.
So thank you so much, team, for this immense work. And I'm very sure, because we are live everywhere in the world, that AOGU Central, represented here by Dr. Irumba, that you are going to tell people what you have seen that site. You should take yours to Serena. So this, but this, want to thank the president for making this happen. Now this really shows that the organization has grown. The organization has grown. But we couldn't get this number. We couldn't get this number. We couldn't fill up this hole. But if we can now organize for the Western and we can feed up this hole. And also I'm happy that when we don't only feed up the hole, but we also feed up the parking. So the welfare is also very good. So we are really grateful and we hope all our other regions can do this to strengthen us. It will show the work we have been doing for the last year or so. And it will motivate even the associate members to really join this association. When we were growing up as residents, we did not have this motivation because we would not see. For us, we thought AOGU was Department of Obstetrics and Gynecology of Makerere University. But that's not right. And now you can see AOGU is really a national association. Thank you so much, Chair. I think you can see that the president will give the statistics, but we can see now gone are the days when you wanted a super specialized gynecological service and you had to go to either Kampala or Nairobi. And I'm now glad that we are becoming the site for the tourism of gynecological services in this country and the region, that people are leaving other regions to come to our region for the care. And not only for care, but also for training. So thank you, members. It is only through this that we can, other people can see what we have done. To all the residents who are still in training, this is one of the ways you can really make your work be seen everywhere. I want to thank the residents who have just completed from KIU and from Mbarara University, Kawale or whatever, who have really put in their abstracts and they are in the book. You have made history to be in the abstract book, the first of its kind for the Western chapter. So please pin it. I know you love those things of current situation. Please pin it. Put it wherever. Some of your TikTok doctors, please put it on TikTok. And spread the gospel that the association is big. I want to thank our partner institutions from where we run to for support. And I'm very sure, and I can really put it on record, that those institutions survive 98% on our members of AOGU. So Mayanja Memorial, thank you so much. Divine Mercy Hospital, thank you so much. Ruharo Mission, thank you so much. Chitagata, thank you so much. Sikea, the new players here. You asked me that you wanted to get some tech gynecologists. They are here. You get them, they are here. They can't run out of the room. Engage each of them one by one. Engage them and take them, but please pay them promptly and early. Please pay them promptly and early. So I want to end by the President Western said when he was giving when he was a session chair, say that all the gynecologists are here. And he was worried if the women are being seen. To me, and the answer is yes, the women are being seen. And to me, as a trainer, when I see all gynecologists seated here and the women are still being seen, I think we have made very big strides in this country. It means we have passed on information and skills and knowledge for work to continue even in our absence. So I want to thank all the trainers from your work. It's because of your work that we have this conference and the papers are out, because you have passed on the skills. So I want to thank you so much. And I want to thank finally the residents in all universities which are represented here of obstetrics and gynecology. You guys you not only study, but you do lots of work for this country. And you spend sleepless nights seeing these women. And we can't thank you any better. But you know, Obs and Gyn is the only discipline. For us, we don't say that we have gone for work. Each day you leave your home, you have not gone for work. You have gone to war, isn't it? You have gone for war. That's it. So for us, that's why we are not called supervisors. We are called commanders. We who look after you, we are called commanders, because we deploy you and assign you. For us, we just deploy. We don't say please, we deploy. And in the army, thanking has never been by patting at your back. They thank you by shooting in the air. You have seen when they are appreciating the dead, even in the army, they do what? They salute you by shooting in the air. So the only way we appreciate you is by percussing you more. Whether you report us to the vice chancellors, to the deans, we are rest assured that the technique we are using to train you is tried and tested, and it's the best for you. With those few words, I want to invite our President Western, But also thank you very much once again for coming over here.
The Commissioner, Clinical Services, Minister of Health, represented by Dr. Ruth Grace, representing Dr. Ronnie Wahatunjiri, the Deputy Vice Chancellor, Mbarara University of Science and Technology, the President of this, that is the Professor Gonzi, then the President of Association of Obs and Gyn, Professor Rogers Kajawangu, the Chair for this conference, Professor Musa Kayondo, all protocol observed. The institutions that we have here, I think I understand we have Mbarara University, we have the hospital, we have Ruharo, we have Divine Mercy, we have Neokea. I think their directors are here, our chief guests and the DVC. Their directors are here. Most of them we had recognized them, people had seen them. Chitagata Hospital, Mayanja Memorial Hospital, KIU, I think the person you had not seen is the Deputy Director for KIU Teaching Hospital. Is he around, Dr. Mhumza? Is the one I had forgotten to recognize. Yeah, he's seated there, and he's a gynecologist. Maybe before I complete even that, we need to brag that the Obs and Gyn is leading in every field, like the chairperson of this conference said. The DVC, the deans for KIU, the heads of the deputy directors, executive consultants, most of them are AOGU members, and so we are just lucky. The sponsors for this event and other institutions that we have, CCare, please if I forget you, I'm sorry, but there are many local governments that are here or represented. Thanks for partnering. The sponsors that we have here, that is Mega, Troika, Maristops, Via Health, Sagifam, Ajanta Pharma, Crown Health, and all the other sponsors that partnered with us, all protocol observed. Good afternoon, ladies and gentlemen. My name is Dr. Bixon Tayebwa, and I'm the chairperson for the Association of Obs and Gyn of Western chapter. I represent the Western region on the council for the Association of Obs and Gyn, which is headed by the president, Professor Rogers, who we are glad to have here today. Even if you know him, just know today he's from Kampala. Because he's, the president said that he's from the headquarters. Our regional offices are in Kampala. He will tell you where they are located. We are not a briefcase organization. We are an NGO, but also fully registered company, so we can sue, we can be sued. But also, our objectives, the president will tell you. We have a building and that we own. We have offices. The organization started a long time ago. The president will give you more details. Mine, so I work at Ruharo Mission Hospital. I'm the only one who didn't introduce myself, chair. I work at Ruharo Mission Hospital as an Obs and Gyn, but I'm also the CEO and medical director. I came with my team, they are here. And several of you who usually come to work with us, our doors are open, especially to serve maternal, but we also do kanokalango. We do eye care, we do all things. I'm privileged to lead the team of Western chapter, which has membership. They are not few, there are many. And I think one of the leaders used to tell us that a leader without followers is simply taking a walk. So I'm glad that we have people that we work with. And I remember when we were starting to organize for this conference, when we approached Professor Musa to organize this conference for us, it was like me, I would not sit in a hotel. It was like I would not sit in a kafunda. Here I will not sit in any basement of any building. I will not say where that comes from, but those who attended conferences, you know. But he said I will sit in a hotel for a conference. So, and I had Professor And we said we shall organize the best, and they deployed us, and we ran around, and the welfare people ran around, and this is where we are. We hope that you enjoyed the environment. We hope that you have enjoyed the scientific sharing. We hope that you enjoyed your stay. We hope that you have had time to share with the teams, the different people that you have not met before. We hope that you have met some new people. We hope that you have collaborated and also made new friends, but also you'll keep them as colleagues after here. That's the reason why we meet. When we meet, we dine, but we also make sure we keep the contacts, because you don't know where you are. Today is not a day for being in the perineum. At least you have had a chance to come here and look at some light, some nice light, and the residents also, you have survived the percussion on the wards. So at least today you can enjoy yourself. We have had this as the first conference, Commissioner, because we feel like in the region, Obs and Gyn is usually the heart of medical services. In any hospital you enter, in most cases, obstetrics and gynecology is the eye. Those of you who are not directly in maternal care, if a woman died today, the regulations we work with, if a woman died today in the process of trying to deliver or give birth, or because they were pregnant, within 24 hours, you're supposed to sign a certain form, and it reaches the Ministry of Health in Kampala, the headquarters, and that form they update the World Health Organization channel. So meaning it is known internationally that you have killed a woman in the world. Okay, not killing, but we know some of you can have those events in the wards. But if a woman dies, that's how much it is, meaning we are the eye, meaning we have to deliver quality at all times, no chances of trial. So we hope that this first event of us coming together will create a platform for us to share. You have benefited from the presentations made, but also we hope that we shall meet more often at that little fee that you paid, but also if our partners can continue to work with us to create this platform for you, so that we pay only that little fee or no pay at all. Some of them were good people, others are yet to be even much better. So we thank all of you. I would like to just make a call that we continue being united in all ways, as I conclude, in all ways, first of all as Obs and Gyn, but also the way we have always been working together with the midwives, but as well, there's a team that usually doesn't leave us, the pediatrics team. DVC, the Dean for Mbarara University Medicine, Health Sciences, is a pediatrician, is expected to be, is he already here? The Dean? Yeah, but in a short while, him and his other colleagues, deans, will deliver a panel discussion. So the pediatrics team, I just wanted to say that continue to be part of us. Are there people, pediatrics, who are here? Pediatrics. Yes, several of them, I think, who work in pediatrics. But this conference was not just about maternal, but also perinatal health. Perinatal is just part of us, so we can't run away from you. We have to be part of us. We'd like to appreciate you all, especially the organizing committee that has organized this. A lot has been said already from the morning, and a lot is yet to be done, but also a lot is written in the abstract book that you have received, and most of the things will be or is shared as we continue to share. We'd like to make a call that we continue to work together, but it's better until mobilize your colleagues towards the call of improving maternal health in the region, because when you miss such events where people share updated knowledge, in most cases you are the one who raised the team backwards. People have shared research, but also they will share experiences because we are at different levels of experiences. We have seen the professors, you have seen associate professors, you have seen consultants, senior consultants, and all of them have different experiences. And so when we share, then we are on the right track. May God bless you and continue to enjoy this journey as we dine. Thank you. Let me also take this singular honor to welcome the the president of the Association of Obs and Gain, my boss, who is visiting us all the way from the headquarters in Kampala, to come and address his people at this moment. Thank you so much. Professor, you're welcome.
It's been a tiresome trip all the way from Bukoto, where our offices are. Thank you, Dr. Beckson. The Minister of Health representative, Dr. Ruth Grace, the DVC, Academic Affairs, Mbarara University of Science and Technology, Professor Joseph Angonzi, the Deans of Medical Schools are present. Our Dean from Soroti, I was pleasantly surprised to see you. I know that this is a hand clap for him. It's he registered a while back, and as soon as the announcement was out, and we're happy to see him this morning. That Dean Medical School at must be on his way if he's not yet here. And KIU is represented. We had someone from Kabale. The AOGU executive member present, Dr. Irumba. The chair, AOGU Western Uganda. The colleagues at different levels of seniority. The midwives, I was expecting a shout as we recognize the midwives. And our friends, the pharmaceutical companies. Good afternoon. This is giving me a lot of joy, and I would like to congratulate the Western chapter of AOGU for organizing such a big event. This, everywhere we have been sharing the pictures, people are wondering how such a big event was put together. Another hand clap for the chapter. Now, the media people do not record this, but it is good to change leadership. It is good. I have seen it is good. A few years ago, I was the representative of AOGU on the council from this region. We had a number of meetings, but I can tell you, not as big as this. So I want to congratulate the new leadership again. And this is a lesson that sometimes changing leadership is good. I want to say that again. Yes, so for AOGU, I'll be handing over next year in November. And I know, again, it would be good for the association. I would like to thank the organizing committee that has been led by Professor Musa Kayondo and your team. Thank you very much. Thank you. You have made us very proud. I wanted to single out a gentleman who, because I've been party to the organization of this, I know has worked extremely hard. And that is Dr. Semambo Edwin. Please clap for him. Where is he? He must be moving around. He's there. He's not so big, so you need to look straight for you to see him. Yes. And the whole team really, Prof. Mujenyi, Dr. Livan, and Dr. Brenda, I could tell, I tried to join in a little bit in the organization, and I could tell they were working very hard. This is not an accident that things have been as good as you see. Looking at the organization of this symposium, you could tell that everything was well thought out. The structure of the room,
the organization of the science, the guests that were invited, the attendance, you could tell that people had a plan and they have executed excellently. Another hand clap for them. I'd like to speak to two issues as I end my brief speech. One is on the theme, which was titled Research-Driven Innovation for Better Maternal and Perinatal Health in Western Uganda. Research-driven innovation. You know, gone are the days when research was being done to increase the number of publications. Now, all the fora I attend, people are asking themselves, how can we move from research to practice? How can we use the findings from the research we do to make a difference in the lives of the women that we take care of? So I thank again the organizers for choosing such a theme, because research should inform innovations. It should inform practices that are going to change the trend of women's health. Practices that are going to reduce maternal mortality. And sometimes it is as simple. I know we want to complicate it with p-values and big terms, but sometimes it is as simple as observing what is taking place in your facility, the outcomes you're repeatedly getting by using a certain practice, and asking yourself, how can I make a change? And I assess what happens when I change how I do things. And this is very scientific, because the most basic level of research is a case report. One case, you see one case, follow it, see the outcome, and use it to inform how you look at other cases that present like it. So I just wanted to challenge us in that way. In that station where you work, can you try to make an observation of the outcomes you get when you work in a certain way? And after doing that, can you try to find out how things are done elsewhere? And then that should help you to make decisions on how you can change to make a difference. I can tell you the most important, if you're like me, in our practice, and I know most of us here are either gynecologists or medical officers or midwives, and the most important person to us is the mother, that woman who comes to you with a challenge. What are you doing to make her life better? That is what I would like us to be asking ourselves. The second thing I would like to speak to is collaboration and association. And I will take just a brief moment on this. Even if you just look at our theme, in research, in innovation, in practice, you need collaboration. Different people need to work together to improve outcomes. At that facility, the doctor cannot work alone. Dean, you're welcome. We are very happy to have you. I suppose we could clap to welcome the Dean. Yes. But I was saying that we need to collaborate, interdisciplinary collaboration. Gone are the days again when doctors would come and just issue orders to the midwives. Now we work together. The midwife can advise a doctor. The doctor needs to speak to the midwife. Let them work together. Let them see how to improve care. At the national level, at the leadership level, at least in our association, we are trying to mend ways. A memorandum of association is being worked on right now as I speak, with the Nurses and Midwives Association of Uganda and AOGU. I had a meeting with several members of the executive at our office a while ago, and we are asking ourselves, how can we work together? We are doing everything in our power to make sure that people can come together. We've approached anesthesia, the pediatricians, we have reached out to them. The only way we can improve outcomes is if we work together. So that is collaboration as we do research, as we practice. But finally, I wanted to speak about association. Association, some of us have a habit of isolating ourselves. You finish, you're posted to a station, and that is the end of you. You're buried in the station. Your colleagues never see you again. Such meetings are organized. You never turn up. I want to discourage you against that and encourage you to it with colleagues. Something adds onto you, whether knowingly or unknowingly, when you come out and meet people like we are meeting today. You see Professor Ngonzi and you see what he's doing. You know that there is a fellowship of urogynecology that is about to release the first official graduates after certification, after the program being approved. Next year, we'll have our first cohort of fellows graduating. You may not know that if you're buried at the station. We've seen the presentations here. All that information, you will not have it. So we are asking you to get into the habit of associating at the different levels. The people in Uganda, I was very happy to see you today. Please clap for them. There are people I had last very many years ago, like Dr. Kaimakas. I was very happy to see her. I hope Dr. Kaimakas, are you still around? Yes, please clap for her. It is good to see you, Dr. Juko and Dr. Musinje and many others, and the midwives that we are meeting. So come out of that shell, come out of that station. The chairperson of the committee said, no one is going to die because you have left for one day, unless you have not been doing a good job mentoring other people to work. So I would like to end it here, but by encouraging us to continue having the heart of doing research and making observations, but also having the spirit of collaboration and association. I thank you very much, and I am very glad that all of you have come today. I now would like to take this opportunity to welcome our keynote speaker today, Professor Joseph Ngonzi, who is going to come and speak into our theme that is once again titled Research-Driven Innovation for Better Maternal and Perinatal Health in Western Uganda. Professor Joseph, we are very happy to have you. We are very proud of you as the association. To have a DVC for a university adds a lot of weight to our association. When I move around, I tell people AOGU has a very strong membership, and you're one of the names. Yours is one of the names we mention when we are talking about that strength. So I want to welcome you to address the gathering today. Madam President, my journey was not as gruesome as yours, but I also came from very far, which is Mbarara University Town Campus. And that's where my headquarters are. Good afternoon. I want to thank you all for your resilience. And I'm very delighted to see these big numbers at a 5-star hotel, which has been raided by obstetricians and midwives. If you understand that statement, you'd clap much better than now. But of course, I will not forget that in our midst, we have pediatricians. I hope they'll be able to also borrow a leaf. And we have a much bigger meeting for pediatricians in this region. The commissioner, the president of AOGU, my boss, the chair of the organizing committee, the deans present. Let me see deans. Yeah, I'll specifically ask all of you to stand up, and we welcome you in a very special way. The deans, please stand up. Okay. Please keep standing. I'll also ask heads of departments to stand up wherever you are, and also are they consultant executives? Executive consultant. Okay, so yeah, these are technical heads. They are superintendents of our training and clinical practice. So thank you. I'm very happy to see you. Thank you. Let's welcome them again. I did share a few thoughts, but before I delve into the details of those thoughts, I also want to appreciate everyone who's been able to make it, the obstetricians and gynecologists. I know where you find an obstetrician, you're sure that a midwife will be there because they work together. So the midwives, in a very special way, we want to appreciate the work that you do. And we welcome you. It's my hope and prayer that in the next couple of years, we should be able to raise more than 1 million midwives. And that will be the one single shot that will improve a lot of our maternal newborn outcomes. So we value your contribution. When I was invited, I made sure that I'll come. I do appreciate the innovations that the leadership is making in making sure that regional AOGU conferences are happening. Many years ago, we used to think that AOGU belongs to a privileged few. But as years went by, we all feel included. So my brother, Dr. Rogers, congratulations to you and your team. Yeah, let's do it better. It's good to know. You'd go for FIGO meetings and you'd find just a few, 2-3 people, and you definitely know where they are coming from. But now, at the last Cape Town FIGO meeting, we had more than 30 obstetricians from Uganda. Okay? Now for me, that is global impact. The theme of our meeting here is very deliberate, it's focused, and I definitely want to appreciate you once again for giving me this rare opportunity, which will go down on my CV as having been invited by my mother, by my mother association to say a few thoughts. When I'm editing my CV tonight, I'll also add it there and say, I was invited at this meeting, so please prepare a certificate for me. So I come here not as a keynote speaker, not as a deputy vice chancellor, but as a fellow obstetrician and gynecologist trained in Mbarara, and as a member of this remarkable association, which is bound together by a shared calling. And that calling is very simple: to safeguard the lives of women and newborns. And as things get a little deeper, I'll not give a lot of statistics because I know you know them. But permit me to begin with a story of a mother, and this story may actually be common knowledge to all of you who are seated here. Imagine a mother, a young woman from a village in Kanungu. Okay, Kisoro. Oh, Shema. Is Chitagata a district? It's not. Isinjiro, Mbarara district. And this woman wakes up before it is daylight. She's carrying new life within her. She walks several kilometers to the nearest health facility, which could be Kabianda Health Center 4. The road is rough. Transport is uncertain. She arrives when she's very tired but hopeful. And she's trusting that the health system will protect her and her unborn child. At that point, there are so many things running in her head. How many of us have experienced such cases? Okay, most of you practice from Mbarara town, you don't see these cases, but let me see, okay. Have you ever received a mother who is a little uncertain about the future, confused? You can do like this, proudly if you have. Yeah, for those ones who have not raised their hands, you are AI doctors, but it is well. At that point, this mother is not thinking about sustainable development goals. She's not thinking about the vision 2040. At that point, she has even never heard of those things. She's not thinking about health financing. All she wants is her baby born alive, and she goes home alive and well. She's not thinking about the difficult things, artificial intelligence, genomics. She's not thinking about very strange things. All she has entrusted us with is a divine, precious process. She wants a safe delivery. Her life and the life of her child, and that trust is sacred. You cannot read it in books. Neither can you buy it in shops. She has come and she wants support. I was telling, I think Professor Mujenyi or someone else, we were talking, yes, with the commissioner, Dr. Mugahi. I just decided one Saturday to go to Mbarara City Health Center 4 because a friend had called me that I am here. I need your help. So I reached there at 11 a.m. I left at 3:15 p.m. A person who had gone to check on someone to offer support, I found myself doing inevitable things. I went into the labor ward, I examined, wrote in their files, and I left very satisfied after those 3-4 hours. We are here today as in, we can have projected. I'm not sure. Are they there? Good. We are here today to or indulge in a few things. I've called them thoughts that will be able to provoke the things that we have listened to today. Thought number one has got components. One is, most of you have heard beyond the numbers, such a statement, isn't it? Beyond the numbers. And I believe that Uganda has every reason to celebrate meaningful progress. You know the statistics, you know the trends. The commissioner hopefully will be able to enlighten us about those. Over the past decade, maternal mortality has declined substantially, that we know. Skilled birth attendance increased to over 80%. Neonatal survival for the for all of us in the room has also improved. Investments have greatly improved. Uganda has made significant progress, and for that I would want us to join us together. We appreciate everyone who has contributed to these gains. And yet every midwife, every obstetrician or gynecologist in this room knows another truth. Behind every encouraging graph lies a mother who did not return home. Behind every national average lies a district that is struggling. Behind every policy, there are so many policies, lies a health care worker who is making impossible decisions with limited resources. Impossible decisions. You have 10 mothers in labor, and you have how many pairs of gloves? 5. And yet they must deliver. You begin writing on papers, go and buy, and you sign. The following morning they say, who sent a mother to buy gloves in their supposed clinic? You're thrown behind the bars. By the time the truth is discovered, you're mentally broken down. But I believe that progress should be able, and to work still humbles us. And for me, I also believe that the greatest danger in our healthcare system is not failure, but becoming comfortable with the partial success. We should think about the whole ecosystem. Why should research matter? Like I said, the theme of this conference is very important because it recognizes one fundamental truth, that research is not an academic luxury. It is a clinical necessity. I'll say it again. There are clinicians who demean the contribution of research. For you to be able to remain at the cutting edge of practice, you must know what new knowledge is being generated, what new practice is coming through. And every improvement that we celebrate as individuals, as a country, today exists because someone somewhere dared to ask a difficult question. What happens to these mothers who are leaking urine? Kayonda and his team in the corner, they say, I think we need to find out. What is the quality of life after repair? Or repair, do they go through? Mothers in labor, how can we best optimize their outcomes? Tamujenyi and his team, they're like, we need to look at the labor care guide. Okay? Preeclamptics. Dr. Lugobe is there scratching his head. What can I do? Kaja wangu, Livan, who did metabolic syndrome? There are difficult questions that you must ask. Why are mothers dying? Why are babies dying? Why are interventions succeeding in one part of Uganda and yet failing in another? What happens if we change the way we train residents, we train midwives, the way we train nurses? How do we predict obstetric emergencies before they become catastrophic? You must ask yourself, and you should not only remain at asking yourself, move out. Research, you need to find out what works. There are guidelines that have been developed by WHO, adopted by Ministry of Health, and yet some working. You employ implementation science to make sure that these guidelines work. These questions, which I've called difficult, they change the scope of medicine. Evidence transforms policy. Policy transforms practice. And when we practice with evidence, lives are changed. And for me, this is the remarkable journey from curiosity to survival. Mind is not asking those difficult questions. I would rather that Dr. Kumba and other deans, they provide an opportunity for you to meet a few psychiatrists. Let's go back. That's the first slide of my few thoughts. The next one, or before we go to the next one, let me just read this verbatim. Thank you. Okay. Good. Thank you. Every improvement we celebrate today exists because someone dared to ask. Please go and ask. Those uncomfortable things. Why are we saying a mother whose blood pressure is normal, no protein in urine, and then we are saying, this one has eclampsia? Ask the difficult things. A mother dying of sepsis, and you've given the antibiotics that your microbiology unit has given you a report about. And you're like, but we are giving these antibiotics. Why are these mothers not improving? You need to ask more genomic questions. What are those unculturable bugs that cannot be cultured? How do I go beyond this? For me, ask the difficult questions and look out for people to help support you. The second set of thoughts. Why is local evidence important? The scope of our meeting is Western Uganda. Am I right, Bwana President? And Western Uganda is unlike anywhere else, as Northern Uganda is, and Eastern and Central. There are unique things about these particular regions. The geographies are unique, the communities are diverse, the disease patterns also differ. The referral pathways, they face distinct challenges. The challenges faced in Ilwengo may not be exactly the same challenges as they are in Bundibujo. Up from the mountain up there, the distance may be 10 kilometers, but it may take 7 hours to reach the nearest place. They are different, distinct challenges. Local evidence matters because, one, It strengthens practice that is hinged on things that work. A protocol that has been developed in Europe to manage a particular disease may not exactly work at KIU Teaching Hospital. It may provide certain insights, but there are local things that are specific, and we must look out for local evidence. Local evidence. The future, in my own opinion, of maternal health care, Madam Commissioner, in Western Uganda must increasingly be informed by research conducted, but also with a focus on the needs of this region, just like other regions will also demand. And at that point, that's where the research focused institutions also come in. We have a role to play. The responsibility of universities or other healthcare institutions. We believe that we should not just be producing graduates. We must produce solutions. A patient who will come to you does not want to know how many degrees you have. And you're introducing yourself. I am Okrut. Where's Dr. Okrut? I'm Dr. Okrut. I have a MBCHB. I have an M.Med. I am the head of department. My friend, they are not even listening. All they want, can you help me? And we must be able to produce people who give us the solutions, okay? Our lecture theaters must prepare compassionate clinicians. Even when the pockets are empty, but what I saw down there, I don't think there's anyone whose pockets are empty. Okay? We must be compassionate clinicians, or else clinical practice becomes just a routine. Our postgraduate programs must cultivate scientific leaders. That's why we ask you to go through a research process. And when you're done, your lecturers sit down with you and they say you must produce a paper, a manuscript. And this evidence needs to be heard everywhere. The true impact of research is not measured by the number of publications. I'll say this 3 times. The true impact of research is not measured by the number of, I think that's number 2. Number 3, the true impact of research is not measured by the number of, it is measured by the number of lives improved. The finest paper, whether published by the New England Journal of Medicine or the Lancet, has limited value if it never changes clinical practice. I am not negating the need for us to publish. We should publish. Someone was telling me that the adage publish or perish is now dead. We are now into innovate or perish. I don't think so. Publish, innovate, those things must move together. Otherwise, scientific inquiry will produce lazy graduates. So knowledge that we generate, asking the difficult question, that knowledge becomes meaningful when it reaches the bedside. A midwife is able to pick it up and they're able to offer care. Innovation is bigger than technology. Many people hear the word innovation and immediately think about AI. AI is important. It's indeed transforming healthcare. Okay? Machine learning. Some of you already have heard of algorithm development. Some of you have published. It's true that Technology is very important. Telemedicine is connecting specialists with remote entities, remote hospitals or systems, electronic health records, continuity of care, and these are very exciting developments. We must be able to use these innovations to improve care. Data must become our compass. Now, when you find a clinician trying to demean research, please give them a few years. They will become extinct in terms of cutting-edge practice. Healthcare without reliable data resembles navigation without a compass. Even Christopher Columbus had a compass, am I right? Did he get lost? I think he did. But he finally found his way. If we do not measure accurately, if we do not use data to inform practice, we cannot improve consistently. There's a lot of data that we must use. Maternal death surveillance data, perinatal death audits, near-miss reviews, clinical registries, QI, quality improvement data. This data must become helpful in terms of being translated into clinical practice. My last set of thoughts. When you look around, there are generations that are represented here, am I right? I'll not ask you to raise your hands up when I say, who has hit the 8th floor, the 7th floor? There are people in their 60s, 50s, 40s, 30s, 20s. I'm not sure we have less than 20 here. They are there. If you're 20, let me see your hands up. If you're less than 20. 20 and below. I see Mutumba saying he's 20. Kairi is an old man. And when I look through the house, I see professors, senior lecturers, senior consultants. I see policymakers. There are residents. Let me see the residents who are here this afternoon. Residents. Okay, some people do not know the word resident. Okay, master's students. Just proudly like this. I'll ask the specialist to clap for you. When I look through, I see future heads of departments. I see deans. Okay? Many professors, vice chancellors, heads of hospitals, MPs, ministers, commissioners, director generals. To you all, I'll say this, and please listen carefully. Never separate clinical excellence from scientific curiosity. Research, that's the theme. Do not accept inherited practice simply because that is how we have always done it. That's how we have always done it. What new knowledge do you have? You're telling us this is the new bug here. No. For us, we have always known that it is streptococcus. Now you're bringing in what? Gardnerella, what? Of course, you must question respectfully. You must investigate rigorously, collaborate, publish ethically. If your data is to create impact, it should be something that has been derived ethically. I'll not mention somewhere where I was reading a student's book, and you'd clearly see that this is not data that was collected. It was cooked data. Cooked data. And the student was very wise. The English was perfect, used AI to autocorrect and do many things. And in depth, on a little deeper inquiry, the student confessed and said, you know what? I used AI to come up with this dissertation. Now, such data that is cooked, that's not real, will not create impact. It may be beautiful, it may be published in the best journals. Let's publish ethically. And I believe that Uganda's next breakthrough in maternal newborn child health may come from someone who is sitting quietly here. And you must come out. Collaboration, the greatest innovation. For me, this I consider it as the greatest innovation. No institution can eliminate maternal mortality alone. No doctor can eliminate maternal mortality and morbidity alone. That's why I said the midwives are very important, the doctors are very important, and we must work together. Put aside our egos. Say, for me, so for you, you must listen to instructions. My friend, someone with a certificate will be able to guide you better than someone who has a PhD. So let's respectfully collaborate. Together we can achieve what none of us can accomplish individually. Together. That's why when I walked in and I heard that there are midwives, nurses, there are doctors, professors, residents, my heart was filled with a lot of joy, because with concerted effort, we can get somewhere. Our greatest innovation may not be in a new machine, but in stronger partnerships. We must work together. When clinicians collaborate with, with engineers, with the sociologists, with economists, epidemiologists, with data scientists, with uneducated people in the community, we are able to come up with very important solutions. So these are my last two things. When we look at, yes, Western Uganda, but also this would speak at the national level, I do believe that the team here present can create a leading regional hub for maternal newborn child health innovation. If you believe it, let me see your hand like this. It's possible. Is it possible? We have outstanding clinicians here who will enter theater at 6 a.m. and come out at midnight. They have not eaten. They are giving their life. We have committed researchers here. We have young, energetic scientists. We have resilient communities that we serve. Very resilient. And above all, in regard to collaboration and whatever, we have a shared purpose. We came here for something that we believe in. And that is where we must be able to optimize. A call to action, finally. As we engage in this meeting, I know you've heard a lot, you've listened to many presentations, cutting-edge research, which is good. We must be able to appreciate everyone's contribution. We must be able to appreciate that alone cannot make significant progress. And so as we agree on a shared purpose, I invite each one of us to make these 6 commitments. I'll read them verbatim or mention them. 1, let every research project, whether it is midwifery or nursing or residence, let every project begin with a real health problem faced by our mothers and newborns. Nothing theoretical. If you go to Rukunjiri, deep in the village of Tamujenyi, it's Chisizi, Nyarushanje. Yes. And you're telling a mother there in her garden and you're saying, you know what? AI can make you rich tomorrow. AI, my friend. Begin with the real problem. Her issue may be lack of transport to the next health facility. Innovate around that. Number 2, let every innovation be judged not by its novelty, but by its impact on quality and survival. 3, let every experienced researcher here commit to intentionally mentor younger people. They could be young in the practice, but also young in age. Is that a commitment we are willing to make? Yes. Many of you have heard of this adage. The richest place in the world is not what? And not the gold mines of South Africa or Zambia, but the graveyard. Tukwe. In the graveyard, what do we find there? Books that were not written. Research papers that were not written. In the graveyard, very rich. None of us wants to go to the graveyard with those ideas. And let us mentor younger people. If you have no one you're holding a hand, you must question the purpose of your existence. Number 4, every institution, I know there's KIU, there's Sorority, there's Mbarara University, and many others. Let every institution strengthen partnerships across disciplines and sectors. The institutions that decide to work in silos will die out soon. Let's share knowledge. Number 5, let us train. Now this one I put it in bold in my head. Let us train and recruit more than 1 million midwives and nurses. Okay? I've been privileged to come to go to different places of Africa. I've been privileged to travel now 72 countries. When you get to rural areas, you find where there is impact that is tangible. The so-called lower cadres, for me, they're the most important people. We must advocate for them. Number 6, let us remember that every paper we publish, today is research, isn't it? The theme. Every paper we publish, every guideline we develop, every policy we influence, and every innovation we introduce must ultimately serve one purpose: to ensure that more mothers return home safely. 2, more babies celebrate their first birthday, and ensure that families experience joy instead of preventable loss. Can you imagine? Mother goes in to push her baby. Nothing wrong. And she remains on the bed, gets PPH 12 hours down the road. She's in irreversible shock. And you're like, what happened? In the file, there's no blood pressure. There's no heart rate. 12 hours. Where were we? Very painful. Preventable. That should be our commitment. With the mother who placed her trust in us, remember the sacred trust. Such a mother may never know the names of the researchers in this room. And they don't need to know. They may never know that Professor Kayondo has published these many papers. It's none of their business. All they want to know is, can he help me? They may never read our publications. Some of them may read, some of those who are educated. They may never attend conferences like this one to hear what we are speaking. We are speaking to ourselves, isn't it? The next conference, we need to invite mothers. Have their 2-3 tables there. They may never experience the consequences of our decisions. Such a mother, her child will thrive or struggle because of the evidence we choose to generate and the innovations that we choose to implement. That is why our work matters. Our research matters. Our innovation matters. And that is why gatherings like this inspire us to go back and think in a different way. Together, let us commit ourselves to building a healthcare system where science serves humanity, not journals, where innovation advances equity, and where every discovery translates into dignified care. It's my hope and prayer that this meeting has sparked new collaborations. I hope we have been able to talk amongst ourselves during the breaks. We've been able to exchange business cards. No, they told me not many people have business cards. We've been able to exchange phone numbers. We've been able to, to reaffirm our shared conviction that evidence, compassion, and innovation are the strongest medicines we can offer our nation. I want to thank you. Thank you once again for inviting me. And it's my hope that maternal newborn child health in Western Uganda and the entire country will improve just because this conference happened. Succeed we must. Thank you.
Thank you, our keynote speaker. Please, can we give a standing ovation to the keynote speaker? I think this is really a good message to all of us. My residents, Monday, I'll ask some of you to give me the key points from today's keynote address. So I would like to call upon our chief guest, the commissioner, clinical. As the commissioner clinical is coming up, please, all of us here, can you please stand up and appreciate this? Dr. also stated, and appreciate our grandfather, Dr. Waswasalo, for being here. We are all here because of him. Whether you are third generation means that he trained me, I trained him, Lugobe trained Kairi, isn't it? That's the generation we are talking about. Thank you, Dr. Waswa, for all the big parts. Yes, Commissioner, thank you.
Thank you very much, Dr. Kayondo, Professor Kayondo. I stand by the already established protocol. Good afternoon to you all. I am gifted by nature. I try to elevate my height, but I'm still short. So I will stand on the side. My name is Ruth Grace Kakova. I'm an obstetrician by training. I am a proud MUST alumni. Succeed we must. And yes, thank you. And all these are my teachers, and I'm really humbled to be here today. I also had my postgraduate, I think, community placement in Uganda. So I think I am surely from the West. I am a born and raised of Mbarara University, by the way. I was born in Mbarara General Referral Hospital, so I am home. But today I'm not here to pride in who I am. I'm here on behalf of the Commissioner Clinical Services and the Commissioner Reproductive and Child Health. And I will humbly give my remarks. The good thing about being a delegatee is that you get to give your remarks, listen to what the concerns are, deliver them to where they should be. So that means I will not be on the hot seat for today. I know there were already some questions to the ministry. So I would start off by saying, one, the Ministry of Health is very pleased to have this event held. It's the first reproductive health symposium in the country. If I get to know, we've been doing a lot of reproductive, maternal, newborn child health symposiums, conferences here and there. And this is the first one that's looking at how are we dealing with issues within our regions. And thank you very much, our President, for having that. Why this is important is because Dr. Onesmus Biamukama reached out to me at the beginning of the year, and he said, we have a conference we are thinking about. And I asked him one question: what is the theme? Why Mbarara? Sometimes you ask a question, not to show that, but you're asking, because of course I said, Mbarara, this is beautiful, but then why? And it makes a lot of sense when you read a lot of statistics saying Mbarara has the highest levels of HIV prevalence. Now, I coordinate the Newborn Secretariat, and we know that the Ankole Chigezi sub-region has only 26% of neonatal care unit coverage. That is alarming. So it means babies born anywhere in Ankole Chigezi sub-region are going to end up here in Mbarara General Referral Hospital for care. And then Dr. Kumba Kumba will call me and say, Dr. Ruth, our building has to open. And I will say, yes, we need to open it. So it is not a mistake that this is held here, and thank you very much for organizing this. And I will start with my own speech, and I will go to the speech, the final speech. Now, sexual and reproductive health is very important. I saw reproductive health symposium, and I said, okay, what about the sexual health? One of the doctors mentioned we are products. We have partners, and I said, okay. So what we do with our partners is very important, because later it will lead to the reproductive health concerns. I was taught by my teacher, Dr. Kayondo, so we don't hold backwards. But anyway, we are all in the same environment. So reproductive health is not only for women, but then also for men. I think the organizing committee was trying to communicate that by having only one lady be part. But why I say this is because most times we say that the reproductive health concerns are mainly obstetric. And as the Department of Reproductive and Child Health, we said, well, there is a lot we have done to improve the numbers of the mothers who are dying. We've reduced significantly from a maternal mortality rate of 336 to 189 per 100,000 live births. So the question is, yes, we are not yet there, but we are improving. What can we do now when it comes to the other issues that are not obstetric? Gynecological care. I loved when Dr. Caxton was presenting. There was a very interesting response from the audience. Someone who is non-clinical asked a question. Women here have menstrual pain. So when do we know that menstrual pain is not normal? There was no direct answer given. It's important for women to know that menstrual pain is not normal, even if we've normalized it. It's like saying FGM is normal because we were told it's normal. So it is not normal to have any pain. And that should have been the communication that we clearly give out. Now, her question raises a lot of unanswered things we see in the clinics as gynecologists. And indeed, in this room, we are here as gynecology, as associates to gynecology, the midwives, the nurses, and the pediatricians. We are all here as clinicians. but we are talking to ourselves, which is good as well. Because I'm sure for some people it was the first time to see a nodule of endometriosis. I was lucky, the first time I learned about endometriosis was in my MEd. I did not know about it. The first time I saw a lesion was also in my what? In my residence. And I said, okay, so this is how it looks like. So it means that there is more teaching to do and there's more training to do in the line of gynecology. Many women are diagnosed with UTIs because they have abnormal vaginal discharges. And they are prescribed antibiotics in and out. We always say that when a woman comes and says, I have a UTI, the statement has become very common in clinics that even as health workers, we know, okay, we know UTI. And women take it up. And they will tell another woman will tell another one, and then we'll end up in the same mess. UTIs are becoming cervical cancers. UTIs are fibroids. It doesn't sit well with me when we see cases, you asked for radiotherapy bankers, when we see cases that are end-stage cervical cancer from a woman who has been attending care at a facility and she's managed for UTI. And then when she starts swelling up is when we say, but maybe something else is wrong. Then we send her to the medical ward, but all we could do is just a speculum examination. So I'm speaking to also the interns, the midwives, and the medical officers who are with us today. A speculum examination is not a gynecological or a specialist procedure. It is a physical examination. The reproductive health organs have to be examined. Same goes for the men. Men are not examined these days. I know they fear the annual exam for the prostate cancer, but the good thing is that now you have tests to predict prostate cancer. How many times do we examine men when they come into our consultation rooms? Testicular exam. So, reproductive health. When it comes to research, the Deputy Vice Chancellor, Professor Ngonzi, has said it all. I was really advocating for if we can have this information not only placed here in Mbarara, we need it. At the Ministry of Health, the various technical working groups have a platform for anyone that has work that they would want to publish, something that they want to change in the country to come and present. And we do have a knowledge management portal. How I wish that all the work we have here today could be actually uploaded there. We need more of our work. So please endeavor that this is put there, and we shall be able to also facilitate you with that process. When it comes to clinical care, a lot of concerns come through with health workers in regards to, I do not have this commodity, I do not have this medicine, I am exhausted. You are right to be exhausted. My DHO is in the house, I know, are struggling with a lot of healthcare workers who are burnt out. And midwives, I appreciate you. The midwives learned what they call self-care. Even if they are tired, they will work there 6 or 8 hours. Some people do 12 hours in where they are very short-staffed, and they'll go home on the mark. Then you find doctor. From last night, he didn't even eat breakfast, didn't eat lunch. It's now 8 p.m. He's the most irritable doctor in the world. No wonder one of our researchers is saying that at least 82% of women experienced an abuse when they were in labor. So when you're that frustrated, you can't endeavor to serve. Now, our DHOs, we know that the doctors keep on waiting to work at least 4 days a week, and then they go away. So that is not correct. Public service standing orders at least will say work your 8 hours. You're better off working your 8 hours a week, so that when you're looked for, you don't say, I was home sleeping. Sometimes people do not understand, and yes, they will not understand you. Let us advocate for self-care for us as clinicians. It's important. Someone who is not well cannot serve a mother. We've had cases of midwives who have taken their lives. We've had cases of doctors, even residents, who have also taken their lives, dropped out of the residency programming, dropped out of school, Others attempted suicide because it is too much. So what do? Does it mean we keep saying, yes, let's grind and keep pushing? The answer is no. We need to look at the drawing board. It will be good for us to know that in Uganda now, someone can easily say we have enough gynecologists in the country. It's a sensitive statement to say. Because now when you finish your residency, you are going to now look at Professor Ngonzi and Dr. Kumba and say, Dr. Kumba, even Dr. Kayonda, and say, Dr. Kayonda, do you have an employment opportunity? That is the reality. Many medical officers are looking for the jobs. Now, even us as obstetricians, gynecologists, we're also looking for the what? For the jobs. Does that discourage training? The answer is no. It is actually a good thing that we are having extra numbers of healthcare providers that are actually specialized. It is good to note that the Ministry of Health, working together with the different ministries, is going to be able to provide extra wage, and most of this wage is already available in most districts now. There's been deliberate efforts to increase wage for recruitment of all healthcare cadres, including specialists. There is a push for general referral hospitals to have the specialists in. So where there are staff who are saying that they are not yet promoted, now is the time to please put in your request once again. Do not tire. In advocacy, we do not tire. Put in your request once again, because now is when you may actually get into public service. So there is always some good improvements. When it comes to commodities, for those who have some information about it, is that the government has done some ring fencing for medicines and supplies, especially for reproductive health. I do not know if we have this information. For those who do not know, we have now heat-stable carbetocin, oxytocin, misoprostol, all ring-fenced, and magnesium sulfate. So it means that a facility or a mother should not be asked to buy magnesium sulfate in our facilities again. If a mother comes to a health center for this medicine is available. When we ring fence, it means that all the medicines will be available for free for the next 3 years. It's going to be free. Now, PNF, please don't ask me if you can also get, but I think you'll get as well. Let's just do proper lobbying there. So all healthcare leaders that are in this room, that means anyone from health center 4 upwards, your budgets have increased, especially for commodities and supplies. I want to let the team know that at Health Center 4, the minimum budget someone has right now is 270 million for a financial year, just for medicines and supplies alone. So it means that when we go for support supervisions as leads, I've had the PPA champions in the house, let us go and ask and support the teams to do proper quantifications. If you find a facility has stocked out, even on gloves are also now available, syringes. So someone should not tell you, I don't have a syringe to give the magnesium sulfate. We know about all these concerns. So let's support the teams in proper quantification for this. Now, ring fencing means that now facilities also have surplus budgets. In addition to the extra budgets that they were provided with, they now have surplus budgets. It means the budget you had where you are going to buy magnesium sulfate is now available for another medication. So it's the time to say, is there something else that we wanted to purchase? And I'm glad to say that in the newborn space, facilities have improved their requisitions, and we have now caffeine, citrate, and surfactant provided, including Mbarara General Referral Hospital. Was able to procure some surfactant this financial year. When it comes to clinical care guidelines, healthcare workers, please kindly follow the clinical care guidelines. We are giving the council a lot of work, and majority of cases are our cases. Midwife did not document. Midwife did not monitor. Doctor did not write theater notes. And we always say the mothers who sue are where? In private. Okay. They are now suing us in what? in public. I'm not saying be afraid of patients. It is following clinical care guidelines that will support you and save you. We had a case in one of the districts, I will not mention which one, where a baby was born preterm and wrapped and given to the parents as a dead baby. When they reached to bury in the village, the baby started making noise. And the baby was brought back to the facility. Managed in Soroti Regional Referral Hospital, is now a live baby girl, somewhere thriving. We are clapping hands, but the first question is, how did the baby end up in a what? In a box. Usually they don't even have coffins, box for burial. It speaks to a lot. We're having a lot of cases as well where mothers who have congenital anomalies, I'm sure these cases you see them, they are aired out on media, or they are published by the council. A mother delivers a baby with multiple congenital anomalies, which we think are not fit for life, right? Baby is handed over, again and said, go and bury. Baby found what? Alive. Baby died a few days later, but what does that point us to? It points us to just the basics, communication with our clients. Our clients, whether private or public, are entitled to clear communication so that they can have safety while with us, and so that we can also be safe with our clients. Lack of understanding of clients is what promotes the litigation cases that we get, and we do not love seeing our healthcare workers behind bars. It is so inhumane. Let us work on that, and surely we'll be able to improve our clinical care. Health infrastructure, Ministry of Health is deliberate in improving that. And I think Mbarara General Referral Hospital is a testament to some of this, that there's been deliberate improvement in the infrastructure designs for the Ministry of Health, and also equipment to support both maternal and newborn health. Just last month, we flagged off about a 1.2 billion investment for neonatal care in the Chigezi sub-region, and call it Chigezi, and across the country. Dr. Kumba was able to receive that and support some places in Shema. So DHO, you should be very happy. Shema, this Shema Health Center for Shuku Health Center 4 now has a neonatal care unit. So it means that some babies will go off the back of Dr. Kenema and Dr. Stella when she's back. So all that is done so that we can be able to improve our clinical care. Now someone is going to say, you give us the equipment, but you don't maintain them, and what? Colleagues? This is advocacy, and there are always plans. As we talk about things to do with specialization or super specialization, we appreciate Mbarara University for being one of the key facilities and universities that have taken on the fellowship programs in line with our health care of reproductive health. Having a fellowship of urogynecology within the country not only provides just a step towards the future, an improvement in our clinical care, but also a landmark for all other universities to benchmark on and ensure that we do have these services provided in our country. So we do appreciate you, and we hope that we can continue creating that. Creativity and media, if you can move to the next slide. These are all opportunities for creating advocacy. When we talk about fistulas, when we talk about stress urinary incontinence, when Dr. Caxton goes on his TikTok and shares with us about endometriosis, I think some of us didn't know it until we started hearing him talk. It's very important to be a TikTok doctor or an ex-doctor, whoever it is, because this is where we are moving to. We cannot hide away that media is the new place. Right now, I am sure if someone is live streaming, you have a very good TV here, the AIT, is it the AIT? If they are live streaming, it's not going to be on NBS or what, it's going to be on what? On social media. That is the new TV. When NBS is under, is it NTV? Is under closed doors somewhere, they're now on what? On social media. So we cannot hide away from that. And what is important is if we could also have some of this work that we do, I would be very happy if a midwife somewhere gets, even if it's just a kit, a mama kit, and you show a mother what she needs to do when she's coming to the healthcare facility. Mothers think they should only carry the baby clothes and cotton. That's it. Is that all? The answer is not. And when she comes, we start raising our voices and say, oh my God, why are you like this? So it is important that we do share this information, of course, with clarity and clear background information. You don't just put out information to public because it will cause confusion. And AOGU, this is to you. If you can be able to support some of this work to ensure that we have clarity of information on our social media platforms. My Vice Chancellor talked about it. As a coordinator of the Newborn Secretariat, I cannot leave this platform without saying, where is the baby? The reason why obstetricians are happy people is because at the end of the day, you have someone who is doing that, who is crying at birth and very happy. These discussions are very incomplete if we do not mention anything to do with the child. And I appreciate the people who are able to do research around this. It's important for us to keep advocating for both the baby and the mother. The newborns are the majority of Ugandans that we are losing in our country. I'll repeat that statement. The majority of the Ugandans dying are newborn babies. Some do not get to even be born. Majority of babies are lost at the time of childbirth and come out as fresh stillbirth. There are even some who try to breathe and we score them 0-1 and then we write fresh stillbirth. Paul knows who does that. A lot of our data is cleaned. A lot of cleaning has to happen because we lie to each other and we say, no, my God. Because when a health worker asks a question and says, a mother has come in and she has prom. It was a very interesting conversation today on one of the LMNS platforms. A mother came in and she has prom. So someone shares literature about what should be done for a mother who has premature rupture of membranes. And then someone responds and says, but for me, the practice I have seen is you just induce the mother and she delivers. I have what? Seen. So, are we welcoming new knowledge or are we stuck to the old practices? Evidence-based information takes precedence over expert opinion. I may be more trained in the area, but my expert opinion is perhaps I will use 50 micrograms of misoprostol, but evidence says use 25. If evidence says use 25, your own colleague who is next to you today will be the first one to say you did something wrong in the courts of law. We shall not defend you, neither will I. Because clinical care is disadvantaged then. Now, finally, the speech of the big man. I have finished my little speech. So, thank you. So, on behalf of Dr. Ronnie Bahatungire, the Acting Clinical Services Commissioner, the Department of Clinical Services appreciates the work done by Mbarara University in putting in place the first annual Reproductive Health Symposium, themed research-driven innovation for better maternal perinatal health in Western Uganda. This is a landmark and challenge to all other regions and specialties. The learnings we get today are a testament to the growth of clinical care in the country and also in the region. All said here, we celebrate our wins, but also have the symposium as a stepping stone to further improvements of clinical care in the country across all aspects of health. We are with you and are committed to ensure evidence-based clinical care is provided, Service delivery is not compromised, working closely with you as the service providers and ensuring that patient-centered care is provided across all levels of care. We, as the Clinical Services Department, will work hand in hand with all the gynecologists and the midwives to ensure that clinical care for the mothers and their babies is upheld not only in the public but also in the private sector. Thank you to the teams that have placed this together, the university for the stewardship in academia and providing a platform where knowledge is shared and disseminated. We appreciate the work done by all our leads within the various districts of Ankole and Chigezi sub-region in ensuring that clinical care is improved, but then also ensuring that all supervision is done timely and healthcare workers are able to do their due diligence. Thank you again to the Almighty God who has made this possible and brought us here on today to be able to listen to these remarks that we've listened to. And on behalf of the Ministry of Health, I applaud you and ensure and give commitment to ensure that as the Commissioner of the Department of Clinical Services, working closely with the Reproductive and Child Health Department, we will be able to provide you guidance, and our doors are open to at any time and any day for clear consultations with our dear healthcare workers in the country. Succeed we must for God and my country. Thank you.
Thank you so much, Commissioner, and please let's give a standing ovation to the words of wisdom and encouragement delivered to us from our mother ministry, the Ministry of Health. And when they give us all this, we are really encouraged and we are really energized. You had the 8 hours, you had the many hours. Yeah, we are really energized. And you had we clinicians seeing women, and it's very true. Most of us who have been in the service for long, Dr. also will tell you that a gynecological exam is not complete without bare minimum if you don't put a speculum. For us, our stethoscope are these 2 fingers, people. These 2 fingers. They have eyes, they feel, they smell. They are better than an ECG or an echo for those physicians. Please, let's put these hands there, these fingers there. You know where I'm saying, please. Women will not come here for being treated for PID for 2 years. And all you are saying, as she has said, is lateral pelvic wall involvement due to cancer cervix, stage 3B. And you can't do much. Yet you'd have done something 2 years ago by putting 2 fingers or putting a speculum. So that's very important. Thank you so much, Commissioner. Since we are running out short of time, we're going to have a very short next session, which is the awards ceremony and a photo. You know these residents. If they live here without a photo of the commissioner and the deputy vice chancellor and the dean on their statuses, current situation, over what, they will not, the conference will not have taken place. So let's have that come up. Professor Mjenye and the president, Western chapter, I think you take us through this session.
Thank you so much. Let's clap for Professor Kayondo for leading us well. Professor, what would we do without you? Thanks for always encouraging us. And the far we have come is majorly because of his leadership. And thanks for putting this together. It's been worthwhile. The next session is going to be a bit short as we come to the conclusion. We ask you to be a little patient. You have seen the program. I think we are good time managers. The photograph is not yet, LCG, the LCG has not yet been exceeded. Is it already obstructed or it is just, yeah, we are going to do the awards for a few recognitions. Thereafter, we shall do a brief photo moment, then have a session, which will also be brief, on a panel discussion, and we shall leave after that. And then with that, one of the first awards, let me allow one of our senior colleagues and the committee to introduce that in less than a minute. And then I request that the president and the rest of his team, the chief guest, if they don't mind, they could stand here and award these people so that it will be short, I promise. President, chief guest, DVC, the chair for the conference, and the dean, so that we complete this very quickly. If you can stand here just on top, and then introduce sales, you could stand.
Yes, thank you, ladies and gentlemen. As we come to this session of awards, we have 3 categories. The first category is going to be a Lifetime Service Award, and this is going to be presented on behalf of AOGU Western Chapter to none other than Emeritus Dr. Waswa Salongo. Dr. Waswa Salongo, as you come, AOGU Western Chapter wishes to recognize Dr. Waswa Salongo with the Lifetime Service Award, the highest honor in AOGU Western Chapter. Dr. Waswa, you can stay there, first turn and face the audience. The audience doesn't know who you are. You could now be guided to step up more and stand next to the commissioner. So Dr. Waswa Salongo is awarded a lifetime achievement as a trainer, a researcher, a clinician who has extended or spent his entire career life in Western Uganda at Mbarara University Teaching Hospital, now called MUST, Mbarara. And to us, you are a father, a grandfather, a colleague, and for this, AOGU Western Chapter recognizes you. Dr. Waswa Salongo, I'm still talking about him. Dr. Waswa Salongo is an ex-ACOG fellow since 2019. Dr. Waswa Salongo is an MMed, just like the residents, but for him he did it in 1991 in Makerere College of Health Sciences. Dr. Waswa Salongo was an MBCHB 1984. Okaborahe, where are you? Currently, he is retired emeritus senior executive consultant. He still works the National Safe Motherhood Experts Committee. He's a pillar of MPDSR, and he's currently emeritus SEC senior executive consultant at Mbarara Regional Referral Hospital, where he was appointed since 1992. Dr. also worked in one hospital in his entire career. The reason as to which AOGU Western Chapter recognizes him, he's a trainer, a teacher, a mentor, If you have been trained or taught or mentored by Dr. Waswa, please stand up and clap for Dr. Waswa. I see the midwives who have been mentored by Dr. Waswa. You have not stood up. There are here very many. And for this, we recognize you and we wish you good health. We thank you and congratulations.
Thank you very much. When you are somewhere, leave a legacy. Some of you know Dr. Ndiwalana? Dr. Ndiwalana was being taken to court, as Dr. Wabidi here said. And what saved him? He had documentation. Ladies and gentlemen, when Dr. Ngonzo was talking, Professor Ngonzo was talking here, I said, now, what can we do? Can we go back and look at our notes? We need to document. What you have not written, you have not done. And very many of you have heard these words being said very many times. What you have not written, you have not done. Write down what you have done, and the world is the limit.
Thank you so much, Prof. So the next category is some of our sponsors. They're in two categories, the silver and then the bronze. Let's do it quick. If we read you, please, I'm going to read them in just an order so that they all come and pick as they go back so that we do not delay. In the bronze category, we have Crown Healthcare. Crown is our sponsor for this event. They will be followed by Via Health. Via Health, do they have representatives still around? Via Health, someone come. Crown first, then Via. Let's have Crown first. Yen Sajifam, Ajanta, Mayanja Memorial Hospital, Ruharo Mission Hospital, Chitagata Hospital, Mast Urogain, and Ministry of Health lastly. Let's have them. Yeah, one representative is enough, or if you are orderly, then you can come quick. That is Crown Healthcare. Can we have Via Health? Thank you for the support. Thank you so much, Via Health, for the support. Sajifam, this is just a token of appreciation for you to support us to come and sit in a 5-star all the way from the Perinatal in Chitagata and Chavujimbi and other health centers. Sajifam, is that right? Done? Oh, Ajanta. They are not here? Thank you so much, Ajanta. You have always stood with us. And then hospitals, Mayanja Memorial, they are still here. Yes. Mayanja Memorial Hospital, Ruharo Mission Hospital. Request the team from Ruharo Mission Hospital. If you are orderly, you can come quickly. You can come with your team if you are quick. Mayanja Memorial Hospital. Stand on the side, yeah. Stand on the side, not in front of the president. Okay. But the president is used to that gender, no problem. Ruharo Mission Hospital. Yeah, stand on the side for a photo moment. Oh, I need to join. You people. Some of you can stand on the sides. We pose with these dignitaries. That was a special one, eh? Corruption is everywhere. But we shall fight it. Chitagata Hospital, the existing consultant is around.
Thank you, Stagata Hospital. That is it Shema District Local Government? I think. Is it Shema or Bushenyi? My geography is. Mbarara University of Science and Technology, Eurogain. They are here, led by the chief. The chief himself, our chairperson, you are representing today. As long as you are not an SHO, it's okay. Residents, sometimes. I wanted to say something, but let me leave. We are able to, let's have the other categories. We shall go. Neo-Care Hospital. They're here. Oh, sorry, I was forgetting. The next category of sponsors are in the bronze category. This gave something a little more. The award might look a bit special. I'm trying to do the politics. Let's welcome Mankind. Mankind, thanks for the support. Premium Medical Services. Mankind. Thank you so much, Mankind, for the support. And then Premium, sorry. Thank you for supporting the Association of Obs and Gyne in our conference in Western Uganda. Premium Medical Services, are they here? Premium Medical Services. Thank you so much. Mega Life Sciences, Mega. Thank you, Mega. Is it the real Mega or it is the? Hey, this is medical. Not to go political. Troika, is it near? Troika? Yes, thank you so much, Troika, for the support that you have rendered. It's just a token of appreciation and recognition. We'll followed by Divine Mercy. The chief of Divine Mercy is around. I need to be the one to bring this one. Oh, we have the director for nursing. Today, Professor is also. Yeah, please kindly, one of us, receive and award this team. Hey. Thank you so much, Divine Mercy, for the support in this symposium in Western Uganda. Professor Muzenyi, we appreciate. Mary Stops International, and that's it. Thank you, Mary Stops. Thank you so much, Mary Stops, for the support. And the last award goes to our mother who mentors us in everything. That is the Minister of Health. The Minister of Health, and with guidance of the chief guest, let me invite the representative for is it the field that is related, the local maternal and neonatal systems, Dr. Livan, who has also been our chair for the scientific committee. Come and stand next to your commissioner and receive the award that is, sorry, the president is going to present to you the award. This is just a token of appreciation that you continue to serve and make sure that the AOGU as well benefits the community. Thank you so much, Minister of Health. With that, let's do a brief photo moment before the guests leave the podium. I would like to request that so thank you so much. I'm going to request the people who are on here to take the seats, and then I request a few people to just stand behind for the photos. Let's begin with the specialists. This chair is enough. You can have in front.
Let's remove this podium.
The specialists who are around today, kindly come, and we filled our team, the obs and gyne specialists. I don't know whether I should ask Professor Kayondo for that to invite only those who have licenses, or those who have completed also should come. He said if you know you have a license. This is good representation. Hey, I didn't introduce, we have DHOs actually in the house. Dr. Irene, you're welcome. The main photographer, when you're done, you just let me know. Thank you so much. You may take a seat. Kindly keep seated. Let's have the organizing committee just stay behind. Organizing committee just stay behind. The rest can sit. Let's have that moment also for ourselves. Those who are seated, kindly keep seated. Where are you going? Organizing committee. Are you done? Are you done? Thank you so much. Can we call the residents? I hope they will fit here. The residents, SHOs who are here, who are still here, kindly let's enjoy this moment. The SHOs. I'm seeing some specialists coming in SHOs. Maybe their license is expired. Yes. Residents, just stand behind, next somewhere, not in front of a chair. As long as you see the camera, we just want to keep a record of ourselves. Midwives, let's have the midwives also come. The real midwives, including the nurses, I forgot, and the students. After that, I'll have the heads of the hospitals who are representing here. Pre-interns. Any student who is around can join in here. not the master's students. Kindly stand in the side. Let's be quick. If you are behind, extend in the side. Are you done? Oh, you can come this side. There is space here. You can come this side. There is space. Thank you so much. Let's have the heads of the different hospitals representing. The heads of the hospitals that are represented here. Heads of Hospital Mayanja, Ruharu, Nyokea, Divine, Chitagata. Kindly let us, let's be quick. Sikea, I think Sikea was here, Nyokea, Wanunangi, Ngenda Makati. Yeah. They are coming, these ones. The heads of the hospitals, kindly, KU. I hope the cameraman was given food so that we make sure we get our photos, so that he doesn't delete the photos. Sometimes when they miss food at events, they delete photos. Thank you so much, all of you, for I would like to take this moment to, we may not fit, we wanted a photo for all of us, but we may not fit here. I think that will be representative. We shall just Photoshop and mix together. So I would like to welcome Dr. Brenda. Dr. Brenda. Who is going to chair a brief final session. She will introduce her team accordingly. And it's going to be short. Meanwhile, I think there is some water on your table. Don't say we didn't have water. Or everyone in this room has water, not so. We have agreed that you have water. Thank you.
Thank you. Good afternoon, good evening. We have a brief panel discussion. I'm sorry we are speaking about 2 minutes to 6, but we'll try to really have it in the next maybe 15 to 20 minutes about our theme. And I would like to invite the discussants on this panel, who are ideally deans of medical schools in the region. And the first one will be Professor Samuel Kabwigu, who is the Dean School of Health Sciences from Soroti. I'd like to invite Dr. Elias Kumbakumba, who is the Dean Faculty of Health Sciences of Mbarara University of Science and Technology. And then I would also like to invite the Dean from Kampala International University, who is Dr. Kello Maxwell, but being represented here by Dr. Okrut Emmanuel, who is the Head of Department for Obstetrics and Gynecology. Yes, you're welcome. I'm not sure whether I ably introduced you or you'd like to introduce yourselves further, but maybe in the interest of time, we would really go ahead. And like we heard from the keynote address and the other speakers, the theme for this symposium has been please forgive me, I forgot to invite Dr. Charles Irumba, who is from Mulago Specialized Women and Neonatal Hospital, and also the chair for AOGU Central. Dr. Irumba, it was, I think it's just the timing, I just forgot. Please come and join the panel. Thank you so much. Yeah, so like we already know, we are really trying to, our main interest is to discuss how we can transform our training into actionable things, how the role of teaching institutions in advocacy for maternal child health and innovation, so that we don't just sit in the class, but we can get out and be impactful in our communities. And the deans here and people from the different institutions, it's a privilege to have you this afternoon. And I just wanted to ask what is happening in your institutions in regard to maternal child health research and innovation? Are there things happening, or is it something we're going to start? Maybe we'll start from KIU and then we'll just run across the table.
Thank you very much, Brenda, for this opportunity. And again, respectfully, good evening to everybody. What's happening with maternal health in terms of research at KIU is quite robust, in that we have integrated and coordinated teams that are actually conducting multiple maternal and child health research topics. And these have not only been publications as they are, but have translated into local projects, quality improvement projects, across the multiple sites and regions where KIU is represented. We happen to have a huge representation nationwide in almost every single region of this country, heavily. And so these have actually been translated into that. One more thing that we are currently on is actually using the data sets that we have to model prediction of different kinds of exposures and outcomes. So we're doing something called no-code learning, and something that we believe, when it is a complete project, will benefit the entire region in terms of modeling prediction. Not to take long, I want to say that we are exhaustively trying to translate this knowledge into practice, such that evidence-based practice can actually be embraced in maternal and child health. Thank you very much.
Thank you. Dr. Kumba.
Thank you very much. One, research is a core mandate of every training institution, every university specifically, and Mbarara University of Science, which has taken this very seriously. We have recently established a master research institute that houses many research activities, including what to actually specifically is the maternal, newborn, and child health department, what used to be called Healthy Child Uganda in the past, which focuses a lot on research in the communities and trains people also in micro research, and so that everyone can have the skills to do research and translate it to the community. Of course, the Department of Obstetrics and Gynecology is very rich in research and has reached every corner of this country as well with innovative research. We have also clinics and support systems for people to do research. And we're also actually right now in the process of sending out calls for government-funded grants, and some should go into MCH, especially maternal research. And so yes, there's a lot of activity going on, and there's a lot of support. A strong grants office also, where a lot of grants are supported. We have a profile of over 96 grants in the grants office, and many of those actually are maternal and child health related specifically. We have a support moms grant. We have multiple others that are doing a lot of good work straight into the communities, linking research in the university into the community. And the progress we see so far, and the papers coming out, but more importantly, the impact is quite immense already. Thank you.
Thank you so much. Doctor.
Thank you very much, and good evening, everyone. I think I'll start by thanking the organizers for inviting us. I happen to have come in like I didn't want to be identified, but I was mocked out from the audience. I also want to thank God for keeping my mentor alive, Dr. Waswa Salongo. When I joined medical school at Mackay in 1989, I think was already in his master's program. I'm happy that he's still alive and with us. So that said, I also want to make another comment before I answer your question. I'm happy that KIU staff and students are here. I'm encouraged. And I also want to encourage you to keep on interacting more and more with the rest of the people or organizations when it comes to conference and meetings. I've been sharing with the dean or head of department, Dr. Okurut, my experiences about this interaction. So we shall be also organizing a similar function at Sorority. Of course, that's by the way, but I also invite you to come and join in advance. In regards to research, we have conducted an assessment, which was a baseline assessment, because to establish a research agenda at Soroti University. Soroti University is one of those new universities, public universities in Uganda. And one of the things that was identified, core, was maternal and child health. We are conducting a number of researches, both operational research and other types of research that are interventional in maternal and child health. Of course, we don't have much time to list one by one, but what is the key is that maternal and child health is one of those areas that are very key in our research agenda at Soroti University. And the best practice I want to share with you, we are beneficiaries of the Research Innovation Fund, which is government funded. I think quite a number of public universities tap into this fund. And one of the areas that are funded through that RIF is maternal and child health. We consume about 25% of that budget. And the next round is about around the corner. And what we usually do, we actually encourage collaborative research across the different schools within the university, but also as a PI, you encourage it in your protocol to include a student as a mentor or a mentee. So an undergraduate student becomes part of the protocol so that they get to know, they get skilled right from the word go, identifying a topic through the entire cycle of research up to dissemination. Thank you.
Good evening, colleagues.
Good evening.
All protocol observed. I'm neither a dean nor a professor, but I work at the Mulago Specialized Neonatal Hospital, which does MCH 100%. It's a tertiary institution. I don't know if some of you know it or all of you know it. And we are at the heart of research. Personally, I am an honorary lecturer of Makerere University. So we have students who are doing research. Our hospital is open to students. They are supported, given a conducive environment to be innovative, inquisitive, answer their research questions. They get guidance. They have an opportunity of having a multidisciplinary team. We are close to Mulago, so we can get the physicians, we can get whoever we want if we have a challenging patient. And therefore, it is easier for them if they're into those hard questions that require specialized supervisors or mentors. On AOGU, you know, is the champion of maternal child health, where I serve as the chair of the central chapter. In the past, we have had small grants for SHOs, though Trump did something. But we used to have small grants for SHOs to support their research, dissertation writing, and those things. But also, you know, we have conferences. You know, if you do your research like the VC told us and you don't disseminate, people won't know, and therefore it won't impact or change their practice. But also as the hospital, at Women's Hospital, there is a research fund. Most of these hospitals, regional referral hospitals and the like, I think they have, if they budget, they can have a research fund, which can be used for training of staff, definitely alongside the students who are training in those institutions to carry out maternal child health related research to improve our practice. Thank you.
Thank you so much to all of you. It's exciting to know that there's work happening in the area of research and innovation, and you're not just treating patients, but you're also doing some research. I have a question. Between a doctor, a biomedical engineer, a data scientist, who do we think is the most ideal person to use our clinic data to develop maybe a tool for detecting pneumonia or diagnosing cervical cancer? Who do we think is the most ideal?
Thank you. I think the question is best answered if you brought all of them together. Okay. For example, when I talked about the algorithms we're developing to predict or to model outcomes and diagnosis and or interventions in healthcare, we have data scientists, we have biomedical engineers, and we have doctors. the part of the obstetrician gynecologist is to think about what is most consequential clinically. But the other cadres will look at how that can actually be modeled, what type of algorithms need to be run. This we may not have this knowledge. So collaboratively, I think working together we can have a better answer.
Okay, Dr. Krut, thank you. And I think it's agreeable to the other panelists, but my question maybe now to Dr. Kumba Kumba is, what is happening at MAST? Are we taking leverage of the biomedical department, the engineering department, the computer science department to support our medical students in innovation?
Thank you very much. We are lucky to have all the departments and faculties actually. And I have almost recently suggested that they should move the biomedical engineering department into the Faculty of Health Sciences because that's where most of the work that we need them for is. But yes, we've been really putting teams together and those who have been in innovation know that you as a clinician cannot identify the problem and solve it yourself alone, and I think that has been discussed earlier also by different speakers. We have to work together. So we have teams for innovation that usually include a clinician who knows what the problem is, but the solution is usually probably going to come from someone else. So we have biomedical engineers, we have even civil engineers on some of the projects, we have computer scientists and data scientists, these ICT people who know how to put codes into those innovations that they that we innovate. We have also business people actually, because every innovation needs a business angle as well. And so we are lucky that we are able to speak together. We have many innovations that have come through the Center for Innovation and Technology Transfer. That and actually one of the prerequisites for them to be supported is to have a minimal multidisciplinary teams which represent each of those areas because you need them for any innovation. And yes, recently we hosted a Minister for Science, Technology and Innovation actually last week, and we showcased a lot of innovations that relate all the different disciplines. So yes, we are very strong at the interdisciplinary engagement for innovation, but also supporting innovation and ideas to come from every corner. So an engineer can innovate something that answers a newborn problem or a maternal problem, whether it is to do with moving the mothers, whatever problem that you want to solve. These I've seen obstetricians using you call them jackets, ones that for PPH or something. Yes, I don't think they were made by doctors. Yes, all those get done by these different teams, and everyone has a role. And we recognize that, and at Mbarara University we are promoting interdisciplinary innovation. Thank you.
Okay, thank you, Dr. Kumba Kumba. Maybe I'll ask Prof. Samuel. That is happening at research level, but I don't know whether it's part of your curriculum, graduate and postgraduate training, where you see combined research happening between students and not just at a senior level in research programs.
Thank you very much, moderator. What I must say is that the first 2 years, some of the subjects that are done, they are shared, like ICT and communication. They are shared by, we have four schools at the moment. So you find that School of Engineering and Technology and School of Health Sciences, they share this kind of training, and they come up with different topics to see that they can be able to conduct collaborative research between the schools. It also happens at the level of the faculty, where there's a collaboration between lecturers and lecturers, coming up with apps, for example, with engineering staff, to test certain conditions, to program, come up with apps that can make a diagnosis. For example, recently we're working on, it's an area of internal medicine where you can be able to feed in, take a picture or scan an X-ray and have this app interpret and give a provision diagnosis.
Thank you so much. Maybe one other question, Dr. Irumba, moving away from that innovation, we know that artificial intelligence is here, whether we embrace it or not, whether we worry what is going to happen to the next generation. What do you think is the role of artificial intelligence in medical training?
Thank you, moderator. Unfortunately, we have nothing to do about AI. It has come. This is the way of this generation. It's upon us to use it to our advantage. And I implore our seniors to allow us, the young ones, to use it well as they guide us, because some actually get irritated, but also I think also so on the other side, we don't use it so well. But as you know, it might not replace humans. For example, like us, OBS-GYN. I don't think it's going to do cesarean section, whether it is a robot or whatever. I don't think. So we still have a role to play, but it will be there to make us more efficient. For me, I look at it as a decision, a tool which helps you to make quick decisions, but of course with your...
The students are represented actually in the Senate, and they confessed to us that all of them are using AI, and they even know how to, when you know there is a check for checking how much contribution is AI, and they've told us you can actually hide behind AI, and they even said when you want to search, you say humans / and then you put what you want to check. I was very shocked, definitely. So we can't avoid it. And that's why we concluded that the policy couldn't be passed on Tuesday, but we said, let us enrich it with responsible use of AI. Let us guide how responsible one should be when they use AI. Don't use it to replace your thinking. But also that the teachers and the trainers need to understand it actually. We cannot sit back and say, for me, I was trained before the computers came, or I don't believe in AI, I will not do what? I will not use, I will not entertain it. We are encouraged actually as trainers to learn, to understand the benefits of AI, and there are many. It quickens your work. When I've been seeing, I didn't come earlier to see the slides, but I'm sure some people presented work they did with AI. Yes, and so we will run from it, but it shouldn't be what thinks for you. You should guide it, feed it well. We have also learned on Tuesday again that even with the AI detecting tools, you cannot detect all the AI input sometimes, and some institutions have raised their cutoff for misuse of AI to up to 60% AI contribution. So that is, for me, that was too high. But people said, no, even 9% is approved. So yes, there is a big problem. What we want to do is to be able to tell everyone that yes, you can use AI responsibly. You can use it to contribute to improving the way you mean your grammar. For example, if you're writing, there are the other smaller tools like Grammarly and others. And also you can use it to find new knowledge that you didn't know where to find it, but then it should not replace your thinking. But importantly, both the teachers, especially the teachers and the trainers, even in clinical practice, we need to use. However, for us in training, we must also strengthen our assessment methods. We are not going to ask a student to tell you how they would do the section with AI or something. Of course not. So we want to focus our assessment methods a lot more on the practical skills. We want to move away from theoretical knowledge and theoretical lectures and thinking into translation of what is in the students' learners' mind into what is real practical in the clinical space. That way we encourage. There's an article that is published, you can look for it, on AI and unskilling in clinical training. There's an article and I can share it eventually. But there's a risk that in training, if we let AI replace our human abilities, then we will actually produce a health workforce that is unskilled, just because they will know everything. Well, they can click. Actually, AI is getting to a point where you can even put it in your lens, and you can actually, contact lens, and then you look at a patient and probably ask questions, and will try to answer questions for you. And we must resist that. Let's not forget that our hands. Dr. Kayondo, professor, was showing us his 2 fingers and how much they have to do. We can learn from that. We must remain as clinical. We must assess students in real practical situations. We recently had a situation where a student quickly found all the questions in a paper and came up with all the answers to the MCQs and handed in. We have to move away from that. Let's get more practical when we are assessing, when we are training, so that we are not allowing a lot of room. And it's not that we don't accept AI, but let's consider where it can be useful, but also avoid losing our skills to AI. Thank you.
Okay. Maybe Dr. Krut, as we conclude, do you think that AI should be integrated in medical training?
Absolutely. And not just medical training. I would want to extend as obstetricians that this should actually, we need to begin modeling tomorrow's doctors on how to integrate AI even in patient care. Yesterday I saw a piece of news that OpenAI has released ChatGPT Health for all the population. What's happening is that before we were struggling with who is going to the traditional birth attendant before they come to the doctor. Now we are struggling with who goes to AI before they come to the doctor. It means the landscape has completely flipped, and we need to reconcile this dynamic. So now, what's important is actually for all of us to appreciate this tool, as Professor said, and employ it in education and all these other different things. Students are using AI at a very alarming rate. Last study that I looked at before I made my presentation in the last conference was that over 98% of the students had used AI, while for the lecturers, only about 54% had used it. This is a stark difference, and what is happening now is that the lecturers are beginning to learn it, but they haven't mastered it, and so they use it wrong. You see? Yeah, and so there is, I feel that the training institutions, the leaders, ought to actually find a way to empower their teams in terms of artificial intelligence and its employment. Yeah, there are so many things that you can do with it, the modeling and all those things. Personalized individual training and student learning can also be encouraged by AI, but it has to be done responsibly and in the best way.
Okay, thank you so much. Prof. Samuel, you have, okay, please.
Yeah, I do agree with my colleagues about AI. It's a necessary evil, but as students who are here, we need to skill up much as the AI. What's coming out from patients, they say this doctor, go to his clinic or clinic, as they are giving him or her the symptoms, is scanning through, is feeding it to AI. So the patients are now also learning. They say this AI patient, doctor is not skilled. So they are causing a lot of question marks. So as we embrace AI, let us get skilled. Let us get the basic facts in our heads, so that we are not completely lost to AI or become cabbages of AI. Secondly, as universities, we need to come up with policies about AI so that we are guided enough. The third point is that, as already colleagues have mentioned, the students, these Gen Z generations, they seem to be ahead of us, of our generations. So we also need to upgrade as lecturers, as professors, so that they don't leave us behind. Thank you.
Thank you so much. And I can't agree more, because AI is here, and the faster we learn and appreciate it and use it responsibly, the better for all of us, because it's evolving actually. I think it's going to reach a point when it cannot even recognize itself, because it's evolving at a very fast rate, and we need to learn it, embrace it, use it to our advantage, but also very responsibly. I'll just end with a scenario. I gave an assignment to a class on emergency obstetrics, and I just said, Mrs. Someone showed up to the hospital and needed a delivery immediately. Please state one of the obstetric emergencies that it could need a delivery immediately and discuss it. It's pathophysiology, presentation. And when I gave that assignment 3 years ago, I had about 9 different obstetric emergencies. I gave the same assignment this year and I had the same obstetric emergency. And when you put the question in ChatGPT, that's the first scenario that they bring. So it shows that, you know, it can really take away all your entire thought process, because there are so many reasons you can deliver a woman immediately. She shows up to hospital. But because it's available and it's here, everyone is just saying, is getting lazy and just saying, put it in, what it brings. And that's what everyone produced. Handwritten, and everyone copied nicely, and the same scripts, 9 out of 10 students. So AI is here, we are not running away from it, but I think we need to embrace it, and the leaders and of institutions, curriculum developers, I think us as the teachers, we need to be up and learn it, because the students are learning it much faster. In the interest of time, I beg that we end our panel discussion here, because we could go on and on. Thank you so much for being panelists. Thank you so much. Thank you.
Thank you so much, Dr. Brenda.
And thank you, Dr. Charles Irumba, Dr. Elias Kumbakumba, Dr. from the pediatric side, the Dean Soroti Medical School, and Dr. Krut for representing from KIU. With that, I think we are coming almost close to the end. So the closing ceremony is what we started with. So don't ask me for the closing ceremony. Not so. Yeah, right now those who have booked rooms, it's almost time to go and put them to good use. I understand people booked their rooms earlier yesterday, up there in the side of the guests. Yeah. I hope those who booked in pairs, your money will be put to good use. Now, ladies and gentlemen, we have a few just remarks as we conclude. The president will be able to close for us this session. The panel discussion was informative. I hope you pick one or two. The discussions cannot end here. This is just an eye-opener to go and think and innovate. And so, but I would like to appreciate the team that put this together, the thoughtful discussions, the thoughtful topic, led by Professor Kayondo. And actually, as the Western chapter, we think that we should have a leadership president. We think that as the Western chapter, we should have a formidable leadership that leads the AOGU of the Western side, including even our associate members, so that we can remain organized. With that, I would like to request that Professor Kayondo continues to be our advisor on the committee that we are going to form now. If members agree, we can clap for him and request him to come and sit here so that we form a committee together. Professor. If you reject, we shall also vote. And we want you to remain our advisor on the committee. So thank you so much. So Professor, I was thinking that we do a committee for Western Uganda, and I thought that we could have a team of people that we worked with. I am thinking that the team that supported in this symposium was a great team. We needed to have a secretary for the team. Since I'm already the chair, elected at the AOGU conference, I am unopposed. I am requesting. We had elections in Kampala at the AOGU conference last year, and then we were like, we should form a committee. So I am thinking that the team that led us, if you don't mind, could become our official team, since it was a team sought after. So I'm requesting Dr. Fiona to first come here in front, and then we see how, and also someone who was our treasurer, Dr. Edwin Semambo, he might be in the money behind there. Oh, Dr. Edwin Semambo, don't disappear with the balance for the service provider. Kindly come here. We need a treasurer. If people say that you're not going to be, you hand over our money very well when we are seeing you. And then we had several other people that supported, including in mobilization. We had the publicity. Is Dr. Masembe still here? Dr. Masembe? Kindly, I'm requesting that you come here. We need the publicity. And he did a good job during the mobilization. We think that people who are leading can lead us in some way. And then we also had some other people that supported so much in this. And we think we should have regional leaders. We should have regional leaders who can represent us very well. So I'm thinking that Ankole can have someone. We had a very good representative from Ministry of Health, Dr. Livan. We are thinking that he joined the team as a representative for Ankole sub-region. Upcoming commission. I partake. Also, please kindly join us so that you represent Ankole sub-region to keep bringing us together, including the midwives. And also Chijezi, we had someone from Chijezi, Dr. Onesimus. Hey, West Kaba Regional Referral, kindly come so that the team sees you very well, so that you coordinate us clearly. And also, we think that the chief residents from the different universities should be part of this. KIU, is Dr. Choroba still here? I think the KIU, kindly join us, if you don't mind, so that you represent the residents from that side. as the associate members. Also, Mbarara University, their chief resident is here. Kindly join us. And also Kabale, I think he had the chief resident didn't show up, but we shall get him. We also think that associate members can be represented. There are some associate paid up members who are here. How many are still here? Sister Pearl, is your subscription currently up to date? Kindly join us on the team. Also, so that one represents the midwife side. Even on the AOGU Council, we have midwife represented. I'm requesting that also we can have a second advisor who are elders to this committee who have served. So, and that is none other than Professor Mujenyi, who has been also on the team. He has been doing most of the work, but majorly fundraising. I'm requesting him to come here. And then I request Professor Rogers to maybe come and see how this team is. And also they can suggest more members maybe on the positions. And then also Professor can do his work. Thank you so much, Pro.
Members, I would like you first of all to clap for this team. From the success of this event, you can see that they are very organized people. They are also very faithful with resources. They mobilized resources and put them into the right use. So on behalf of the leadership of the association, I would like to say that we welcome them and we accept them as the leadership of the chapter. I was hoping the hand clap would be bigger than that. I would like them to another member I'm told who is not here, but who is very active on the team is Dr. Onesmus Yamukama. Most of you know him. He will continue supporting. We appreciate the work that this chapter is doing. I can say without fear that this is the strongest chapter we have right now in terms of being organized and mobilization. A hand clap to that. So team, we are counting on you to continue mobilizing the members, to continue supporting the health workers here to help our women. And let me just make a few remarks as we close this. First, that we are very, very grateful that you could come. Thank you for coming. I know you are all very busy people. I know some of you are engaged in private practice. I saw some gynecologists here and they were counting how much was not coming to their pockets today as they sat here. Dr. Mutumba, we are very sorry. But we appreciate you for the sacrifice. The team from Uganda, you have given us a lot of joy. The team from KIU, please clap for them. They came together. They have been talking about this for some time. Our midwives, thank you very much for joining us today as our associate members. I would like to thank the delegates who have joined us, the deans of medical schools. Thank you very much, Dr. Kumba, for sparing time. I know how the schedule is these days, but you made it. Our dean from Soroti, you have, please clap for him. Some of you have not been to Soroti, Soroti is not near, but is here. Thank you very much. Once again, I'd like to thank the organizing committee for organizing this successfully and the partners that have supported our pharmaceutical company friends. Please clap for them. This could not have happened without you. I would like to thank, as I end, the Ministry of Health. Yes, the Ministry of Health, thank you very much for joining us and for always supporting us. The association now has a very strong collaboration with the Ministry of Health, especially the Department of Reproductive Health and the Department of Clinical Services. We appreciate that collaboration, and we are going to continue to work towards the success of the projects that we are jointly working on. I would like to thank the media. Thank you also for being around and making sure the whole world is seeing this. Will be, I know my people will be looking to the news to see themselves. Thank you for making that possible. I can assure you, members, if you tune in on TV West at 8 p.m., you will see yourself. It is called, which segment is that? I got you entry there. You will see. Yes. You will see yourself on Agacha and Chile. It is already up and live. And you'll be able to play back. So you can look for that exact place where you are, and you see yourself that you attended. Yes. And cut it out and put on TikTok. So thank you very much, media. Thank you very much, everyone. Thank you, Dr. Beckson. Please clap for Dr. Beckson. Thank you very much. And in a special way, as I end, I want to thank Dr. Irumba for representing the executive on this occasion, all the way from Kampala. He traveled last night and he has been here all through. I had some engagement, so I left him. He had to come alone. So, members, it is just gratitude on my end, and the hotel, you have done us very well. This is a very spacious venue that you have given us, and the members also had very good meals. Thank you to the management of the hotel. So I will end here and request that the next time you are called upon, please respond the same way you have responded. I want to take this opportunity to invite you to our national conference, which is going to take place on the 24th and 25th of September at Mestil Hotel. Now, by the time a chapter conference symposium has been like this, you can begin imagining what the national conference will be like, and decide you should decide to even travel earlier and do not miss any moment. So we are working on that also. This morning I was in a meeting and the preparations are going well. Please come and join us there also. As the association continues to grow. 2 weeks ago I was in Gulu for a similar activity. Now this is done. Next stop is Mestil Hotel, Kampala, for the national conference. Thank you very much, and have safe travels as you go back.
So before we sing the national anthem, we forgot just two things, President. As he mentioned, we forgot to mention that Dr. Onesimus, you should endorse him to join us for as the scientific chair. He was instrumental, but also we forgot the welfare, which was organized by Dr. Brenda. I request you to come and join us. Sorry, we forgot. Kindly please join us for a photo moment with the president of AOGU. Dr. Brenda, I know. the president. So all the preparations for the food and other things here, it has been her, and we think she should join us to what? To continue her welfare work in the chapter, and oh. Thank you so much, colleagues and the committee that organized this. So thank you so much, our supervisors. I request a volunteer to lead us in a closing prayer, and that will serve as the national anthem. Should we ask our dean? Thank you, Dean. Pray for us as we depart. Thank you.
Thank you very much. I am not a pastor, neither am I. I almost became a priest, actually. Yes, I was 8 years in the seminary, and they've asked me to pray. So let's stand up and pray. Lord God, we thank you for this. We thank you for the knowledge we have put together in our heads, for the organizers of the conference. We thank you for the leadership of AOGU, the Western chapter. We thank you for the Ministry of Health that provides overall stewardship of health in this country. We thank you for the people you've brought together here. We thank you for the midwives and the nurses, the doctors, and everyone else who participates in saving lives of our mothers and our babies. We thank you for the grace of this day, the discussions, the plans, and all that you've given us today with the food, the drinks, and the environment that we've enjoyed today. It's all by your grace. We pray, Lord, that you continue to guide us, continue to grow the association of AOGU. We pray that you continue to enlighten our minds. You continue to guide the training that produces all these professionals. We continue to bless all those who sacrifice all they have, their lives, to the care of our mothers and our babies. We pray that you give us healthy lives, and that the evening and the days ahead will be blessed. We pray that you also bless our plans and continue to be with us in all that we do. We pray through Christ our Lord. Thank you.
Thank you so much for coming.